This conference will now be recorded. This conference will now be recorded.
Right. So core surgical skills on post-op care. So we do have a template you guys can follow if you feel that can be helpful. So yeah, so obviously in this module, the type of scenarios which appear, they are again mainly patient communication category. So the the information you're going to give will be again generalized. There is not really, it's more like a process again, how you communicate, how you talk, how you make sure that the patient understand. There is not really much depth theoretical knowledge of anything in this particular module again. So the type of questions or scenarios you can have in this one is obviously that can be counseling and consent taking, or it can be something about they can ask you to, I mean, that come under teaching, but obviously they can pick it up from here as well. Sometimes they have the instruments. I mean, online probably this is not going to happen now, this particular station, but they used to have like they have the instruments and they have the dummy and they will ask you, okay, this is the step of abdominal hysterectomy or for some procedure, and they will say, okay, take us through the rest of the procedure. So obviously being an online exam, this is not going to be there. So, and the rest can be post-op care. Obviously, there are different, obviously there is always, there will be a must station on that, and that can be on three main different common complications: sepsis, it can be hemorrhage, or it can be VTE. So, if you just keep that in mind, and when you see the station, if you just try to quickly work out what that is, then obviously there can be combination of both as well. Like patient has a sepsis, but she might have started with the DPT first. So just have a look on that as well to see what it is. So what, say, for example, consent taking or counseling for any procedure, what you're going to do is the same way, introduce yourself, name, date of birth of the patient, ask what you would like us to call. And then you can open up by saying, I understand you're here to discuss, say let's, for the purpose of discussion, we take total abdominal hysterectomy. So you're here for the operation of removal of your womb. And you can tell the reason as well, just to double check again with the patient. She also understands this is what the procedure is and this is being done for this indication. So I will say, okay, so you understand you're here to discuss about the removal of you're going to have a removal of womb. So it's consent, yeah, removal of the womb because of heavy bleeding, right? Is that right? So let the patient confirm it. And then you can ask, so that comes again in various manners. Sometimes it's like, it's the morning round or just the day before the surgery. They're asking you to go and speak to that patient and take the consent. And obviously the procedure, discussion, and all the other like alternative treatment options, whatever, that has been discussed a few weeks ago in some outpatient clinic. So you can just reconfirm, and on the consent form you will also see down at the bottom of the consent form it says to confirm the consent again. Sometimes the consent has been already taken in clinic. So it's very important just to check with the patient to say, are you still happy to go ahead with this particular procedure? Yeah, so that gives them a chance to again confirm, because they might have changed their mind in all those days when we gave them all that information. They kept thinking about maybe some particular complications, or they might like to actually add or subtract some part of the procedure. Say we consult for abdominal hysterectomy and now they come and say, well, I want my both ovaries to be taken out as well. And obviously the reason can be any XYZ, my nan died of this and blah blah. So that's why this question is important to ask again. And then you're going to just ask to help you to save your time what they understand already. So instead of you just start from the beginning all again, what that is and all that stuff, just ask them, just let me know what you know about that already and what discussion has taken place. So obviously then she will tell you all what they have, discussed and all that stuff. So just take that account, yeah. That information, if the role players start talking quite detailed information, this, that means that information you do not need to ask again. That one is kind of, you can say, you're reviewing the notes. So that should save your time, and you should use that time actually in the counseling of the patient. So after that, you can then just start by saying, okay, so say for example, the scenario is this woman is for the total abdominal hysterectomy tomorrow, and you are asked to, either take the consent or go over the consent again and counsel her for the procedure. So after these initial things, now you're going to say, okay, so what will happen now? You're going to have that procedure done tomorrow. I just imagine, I will say, just imagine all that steps of the procedure. Imagine, in your brain, how is that going to happen? How this patient will be actually transferred from the theater, starting right from her bed in the ward to the theater. What will happen when she arrives in the theater? What are we going to do when we are operating? What is going to happen after that? So take the patient from her bed in the ward and then complete the loop of the journey up till you bring her back to the bed in the ward and then discharge home, right? So if you just keep that journey and loop in your mind, you can't miss any step and then related complications or anything whatever is required. So let's start from, so after us obviously anesthetist is going to come and see you. Yeah, so the second the anesthetist will come and also see you. You will have that, so then she's going to have these cannulas and stuff, yeah, getting ready in the ward. So you will have the cannula pass, will start you a drip of some fluids, and then you will be taken to the theater, and a catheter will be passed to empty your bladder, and then after, and then you can give some idea about the type of the anesthesia, say general anesthetic, so it will be put to sleep for this procedure. However, I will leave that discussion about the anesthesia, what type of anesthesia, or any complications or any side effects of the anesthesia for the anesthetist to discuss and explain to you. Okay, so just say that, tell her like you will have the opportunity. That's why I'm not going into the detail of the anesthesia and the side effects and the complications and problems of anesthesia. So once so you will be put to sleep for this procedure, and then you can start telling, we'll open up. So say if it's a laparotomy, like we're going to do transabdominal, then you can say, so then we'll open up, the lower part of the tummy, will open up, and then the uterus, or whatever, we will then, your womb will be removed from there. Now, when you open the abdomen and you start the procedure, obviously we need to think about what can happen if her previous history actually give us any information. She had a lot of previous surgeries, then obviously we are expecting adhesions. And even if there is no history of adhesions, obviously we do expect what we are going to come across when we have opened the skin until we get to the uterus. There is a bladder, there's a bowel, there are blood vessels, yeah? So you can address the risk of injury to these at this point now, yeah, under your imagination. So this tells her, so if she has surgeries already, because you had the surgeries, operations already, every operation heals by some scarring and can leave the adhesions behind, which means your bladder, bowel, and the uterus, they might be sticking with each other. So there can be a risk of injury, rather I will say slightly higher risk of injury in your particular circumstances to your bladder, bowel, and blood vessels. However, we are aware of these complications and we will be prepared to deal with them as well. And then you continue with the rest of the procedure. If we think it's like a large uterus and the fibroid, big fibroid and stuff, all that stuff, then we can also particularly talk about the blood transfusion. And we can say, okay, because you have this fibroid, this is going to be slightly difficult operation or surgery. So there is a high risk of bleeding as well. So if you bled quite heavily, then we may replace that blood loss with the blood transfusion. Will that be okay with you? Yeah, do you have any, reservations about the blood transfusion? So this is how indirectly you're checking she's fine. And on the consent form, you do have blood transfusion question as well. Yeah, and then you can say, okay, so I'll just take your okay to receive the blood transfusion. And then you can ask blood group as well at that stage. And then you go further, and then you will say, okay, so then your womb will be removed once the surgery is completed. Then you will be moved, if everything goes straightforward, then you will be moved into recovery room, and then but in case if any complication happen, like any injury to your bladder, bowel, blood vessels, anything like that, then obviously we will repair that accordingly, and that can then increase the duration of your operation. After the surgery, you will be, again, this part is going to be standard part for everything, right up to the beginning part, up to the incision. In between these, like between the detail of the operation and complication can be different depending upon what procedure we are going to do. Is it abdominal hysterectomy, or is cesarean section, or it's like cesarean with placenta previa. But again, the recovery, when we say you will be moved to the recovery room, from here till the discharge to home should be same. So you all can kind of memorize these phrases and order of these sentences really. So then you will say, after the surgery, you will be moved to the recovery room, and where you will be monitored closely by the nurses, and if everything is for few hours or few, for some time, and then you will be transferred to your back to your ward. Yeah. And if there is obviously any complication risk there as well, then you can say, so in case if anything wrong and we have to repair that complication, then depending upon the complication of the burlas, sometime we may need to transfer you to the high dependency unit for close monitoring. That may increase the duration of hospital stay. When you wake up, you will expect, there will be some fluids going on. You will be given antibiotics to prevent risk of infection. You will be given some blood thinning medication as well, because after surgery, obviously, you won't be quite mobile. That increases the risk of blood clots in legs and lungs. So to prevent that risk, we will be giving you those some tight stockings and also start you on blood thinning medication. There will be a catheter as well to empty your bladder till you are able to be up and about and able to go to the toilet to pass urine. Yeah, so these 4 or 5 things you can tell. You will be given strong pain relief to help relieve your pain. So these 5 things, like the fluids, antibiotics, analgesia, VTE, catheter, these 5 things, obviously you need to tell you this is what you will expect when you wake up. And then if everything goes straightforward, you will be able to go home after usually on day 3. And at this stage, you can establish, does she have support when she go home? Who is going to look after and all that, or help her? And then at this stage, you can check by saying, so do you have some support at home to look after you and help you to recover to your routine activities? Yeah. So let her know, partner or whatever family member, she will say. And then you can say, yes, you will need some help to resume your activities for a few days. And then, slowly and gradually you can be back to your routines. If they ask you about anything about sex or anything like that, just simply say you can have sex whenever you feel comfortable to. The one main advice we give them is we usually ask them, we particularly tell them not to drive for a few days till the wound or whatever is completely healed. And they feel comfortable that if they have to put the emergency brake, it's not going to hurt. Yeah, that's a safety kind of thing. But if you don't say that, that doesn't mean you're not gonna. Don't worry that you're not going to get penalized. There is no particularly marked for that. But that's just a routine conversation, standard conversation which we take. Yeah. So let's go to this next slide as well. Okay, so if I just show you these again, I have discussed them all. But so when you come around cannulas, so just have a read of these, all of you. Right, happy? So let's start now then. Okay. Right. Okay, so yes, so if you are actually asked to do this consent form, then you obviously will say, okay, so when you've completed the discussion, you will just ask, do you have any question to ask? If she says no, then it's very important to say, I'm going to write this down on this consent form. And kind of, now obviously online, again, you don't have to, you just simply say, I'm going to write this all down on the consent form. Please read this carefully. And if you're happy, this is the discussion taken place between us, then and you're happy to go ahead with the surgery, then you can print your name and sign here, and I will also print my name and sign and put the date. And then say, I will give you one copy for you to take home, and the other one will be attached into your records. Yeah, so just simply ask, do you have any questions you want to ask? And then you can also say, if you have any question or you change your mind before, the surgery, you can always tell us about that. Right, so who is the first one to go today? So Pramila, if you have been looking,
Sapna.
monitoring that
Sapna.
Selena is not with us today.
No,
Yeah,
Sapna.
Sapna is the first one to start. Sapna.
Yes, ma'am. Good evening.
Yeah, okay. So this, good evening. Well, mine is still good morning. It's fine. Here you go. That's you.
Okay.
Okay, you can start now.
Okay.
So the name of
Hello.
the lady you're saying, the daughter is, you can say Cheryl Smith.
Pardon me?
So the name of the daughter is Cheryl Smith.
Sharon Smith. Okay.
Yeah.
Okay. So, hello, I am Dr. Sapna, one of the doctors in the clinic. May I know your name?
Yes, my name is Cheryl Smith, doctor. Mrs. Smith's daughter.
Okay. So, could you please tell me your mother's age?
She's 78 years old.
Okay. Uh, so, Sharon, is it okay if I call you Sharon?
Yeah, it's all right. Yeah, you can go on, Sharon.
So Sharon, I understand that your mother had some postmenopausal bleeding, and she had some scan, and we are here to discuss the MDT results. Am I right?
Yeah, that's right, doctor.
Okay. So before we discuss the results, is it okay if I ask you a couple of questions about your mother?
Yes, of course, doctor.
Okay. Sharon, could you please tell me something about your mother's condition? About her Alzheimer's disease?
Yes, so she has been diagnosed with Alzheimer's for quite few years. But last, 4 or 5 years time, she has really deteriorated. And she's at the stage now where she can't really remember anything from the past.
Okay.
And yeah, so she's staying in the care home.
Okay. Is she able to recollect you? I mean, is she able to recognize you?
Yeah, she recognized the family members. Yeah.
Okay. And can she reproduce the information which we give to her? Are you aware of that? or can she recall the information that we give her?
No, doctor, as I told you, like she can't remember things now anymore.
Okay. And could you please tell me more about her bleeding? Are you aware of that?
So, yeah. I mean, I was told by the care home staff that she has some bleeding a couple of times, and then I took her to GP, and the GP wanted to, it send her to for examination, but she couldn't actually tolerate the examination. I mean, she could probably not understand what's going on, so she was supposed to have internal scan. I think they wanted to have a look on the womb, but obviously she was not able to understand, so couldn't have that examination. So they told me that they're going to discuss that with the doctors and then let us know how she can be investigated or treated.
Okay.
And that's why I'm here today.
Okay. So other than bleeding, did she have any other complaints, like any pain in the tummy or discharge? Were the caretakers complaining of such things, or
No,
any
she
loss
didn't
of?
say anything. She's
Okay.
no, she doesn't have any other problems.
Okay. And do you have siblings?
No, I'm the only child. I
Only
don't have
child.
any other
Okay.
sibling.
Okay. And has she is she on any other medications for any particular disease, like diabetes or high blood pressure or any heart disease, anything like that?
Yeah, she has high blood pressure and diabetes as well, and she's on the treatment for them. And as long as I know, they are under control at the moment.
Okay. And has she undergone any surgery in the past?
She did have this cesarean section when I was born. I don't know. I'm not aware of any other surgeries or operations she might have.
Okay. And in your family, is there any history of someone with cancer of womb or colon or the ovaries? Are you aware of that?
One of my aunts did have cancer. I don't know whether it was cancer of the womb or ovary, but she did have some cancer and she passed away with it.
Okay. Okay. And at what age was it diagnosed?
Uh, she was diagnosed pretty late in her age, like she must
Oh,
have been like in 80s. Yeah.
okay. And is there any history of any drug allergy for
My
your
mom
mother?
is allergic to, yeah, she's allergic to trimethoprim.
Okay. So I'll make a note of that. Okay. Uh, and is there anything else that you would like to add?
Well, no, I can't think of anything. I'm just here to, I was called by the nurses yesterday to come down and I think they wanted to take the consent. They wanted me to sign the consent for my mom to have this procedure done. So
Okay.
I'm really here to do that because I need to leave by train later on for London because I live over there and work over there.
Okay. So, Sharon, yes, we'll discuss the MDT results soon. Um, Actually, she had a scan done, but as you are aware, we couldn't complete it from the tummy. I mean, we had to do it from the tummy. We couldn't do it from down below. And the scan showed that there is a thickening of the inner lining of the womb with increased blood flow to it. So what it means is, like, sometimes when there is, with as age progresses, the womb, because of the amount of the reduction, the amount of hormones, the womb is supposed to shrink, and the lining should also be becoming thinner. But here there is thickening. So we need to see if there is any problem with it. Like, we need to evaluate further. For that, we'll have to do a camera test. That is under
Okay.
anesthesia, like when she can be put to sleep, or maybe we can numb her lower part of the body by a doctor, the anesthetist. Okay, so
Yeah.
with this camera test, we can see the lining, and we'll take a sample of the lining to see to study the cells in it, to see if there are any abnormal cells or not.
Yeah.
So usually this is the way that we follow. Are you
Yeah,
aware of
that's
your
fine.
mother's weight to height ratio?
That should be in the notes, doctor. I don't remember exactly. No, I don't
Okay.
know
Okay,
exactly. Yeah.
no worries. Okay, we'll just look into it. And if there are no abnormal cells, then what we do is we usually go for some progesterone hormone coils called Mirena coil. But if there are some abnormal cells, then we usually go for this, total removal of the womb with the ovaries. So,
Oh,
am I clear so
that's a
far?
quite expensive operation. So when you
I,
think they're not clear, if they're not, it does mean like if she has a cancer.
Not at present, right at this moment, I cannot say that she has cancer or she has not cancer, but we'll have to evaluate her further with the
Okay.
camera test. But
Right.
for the
Okay.
camera test, we need a consent. Okay,
Yeah.
so
Yeah.
just to make sure, like when Mrs. Smith, when she in her olden days, when she had good memory, had she written some document which tells gives a consent to do, like as to what to do later in life when she has lost her memory? Is there anything like that? We call it as
Yes.
advance directive.
Yeah. Yeah. She had because of her condition and she lost the capacity. My dad was given the power of attorney for to take decisions on her behalf, but my dad passed away 4 weeks ago. So obviously I was, we were just busy with his funeral arrangements and all that stuff. So I have not had the chance to get that transferred to me yet.
Okay.
However, obviously I'm the only child, so I suppose I can sign this consent form for her.
Yes, Mrs. Sharon, I understand all your worries and your concerns, but normally in these kind of patients who lack their mental capacity, what we usually have is we go for the advance directive. If it's not there, we go for the legal power of attorney. But unfortunately, your dad has also passed away, and actually, you could have signed if there was there was this legal power of attorney with you. But now that it isn't there, we'll have to act in the best interest of the patient. So that is the thing that we can do, or we'll have to go for court's order to proceed with your mother's
Yeah, I mean,
treatment.
I'm fine, doctor. Obviously, I'm agreeing for her to have that treatment. Yeah, I have no
Anyway, your
problem.
mother
Yeah,
will be taken care of
yeah.
in the in the best possible way.
Okay, your time is over.
Okay,
Yeah.
so
Okay.
we'll what we decide is
Yeah.
and just one more thing, if you could bring your mother
I can't hear you. I don't know. It's your sound
your
mic.
mother to the clinic, to the hospital, so that we can just try to assess her mental capacity, and then queries act in her best interest. That would be great. Any
Right. Well, I won't be able to bring her, doctor, because I said like I'm leaving for London this afternoon. I mean, I'm happy for her to go ahead with that procedure, and if people want to go do that without consent, my consent, it's okay. I have no problem, no issues with it.
Okay, okay.
All right.
So
Yeah.
I'll discuss with the consultant and then get back to you. Okay.
Yeah, that's fine, doctor. Thank you. Okay. Thank you,
Okay.
Sapna. You did really well. A few things, just a bit to clear. So to start with, yes, confirm she is the daughter of the patient, and then
Okay. Thank you.
just ask about, yeah, good. And then you can start by asking, either you can say, tell me more about your mom's problem. So that will just help you to get an idea about
Yeah.
as well how much she knows about instead of clearly saying the symptoms she has, you simply say, tell me more about your mom's problem, what you understand. And then she tells you, obviously I took to the GP and all that story, so that mean, okay, she's aware and she knows everything. That mean we can actually discuss the details with her. And then you will start by saying, and when she says like, I'm here for the consent form and stuff, it was fine the way you started to tell that your mom had this, I mean, you can take a little bit of history if you like beforehand, or you can tell the MDT plan first and then ask the history. It's absolutely fine. So yes, the history was fine to ask that she has any other health problems. The risk assessment for the malignancy risk assessment was good as well, asking her from the family history of any cancers. I would like to basically ask her about the signs of any malignancy in mom as well. So, have she noticed that she has any loss of appetite, or she has recently reduced any weight, or she has, any change in her bowel habits? No, people being on Alzheimer's when they have lost their memory, so that doesn't necessarily mean that they are physically kind of disabled as well. So they are living the routine thing and stuff, and they, for the time being, what is happening in the moment, they do understand that as well. They can tell about their pains and stuff. It's just like they cannot remember things, and sometimes they can't make the orientation, around. So, she might be just, she can't tell if she has a pain or whatever. So we can ask her, did she complain of any pain in her tummy? Does she has any decent loss of appetite, weight loss? And then you can start from there by saying, okay, so, she couldn't have because I think you went into too much of detail of those lining of the womb and what happens in menopause and stuff. You can keep it a little bit simple because there's quite a lot we need to address from the consent and power of attorney point of view as well. So all you can say is, in the menopause, we do not expect any bleeding because the lining of the womb is gone very thinner. So if any women, if they have any bleeding, we like to do certain tests, particularly to take either to do the internal scan to see the thickening of the lining of the womb and take a sample from the lining of the womb to make sure that there is no abnormal changes or cancerous changes. It's absolutely fine to clearly say that or cancerous changes in the lining of the womb. But if you say your mom could not have the internal scan done, and the scan from the top of the tummy that shows the lining of the womb is thickened with increased blood flow. However, this scan doesn't give much detailed information, and then obviously we need to take a sample from the lining of the womb as well. So that has been discussed in the team, and we feel that the best way to proceed from here will be to examine her under anesthesia. And then we will do a camera test. So you need to basically explain what hysteroscopy is and what can be the risk and the complications of the procedure. So then we'll say, okay, so then we will do a camera test, which actually is putting camera, just a telescope inside the womb to have a good look inside and the lining the womb, and then take some sample and send it to the detailed examination, tissue examination. This procedure we call hysteroscopy is quite safe procedure. However, sometimes there can be small risk of infection or bleeding, risk of injury to the neck of the womb, and very rare cases there can be a risk of perforation of the womb during that procedure as well. So these are few risks and complications I would like you to be aware of. And then you can ask her like, so after the information of this, are you still happy for your mom to go ahead with this procedure? Yeah, so if she says yes, I'm okay, then you can proceed further. And then you will say, coming to the consent thing or whatever, you can say, okay, so we need to have the consent form signed, and she then says, okay, I'm here to sign the consent form. So what you need to do basically, advanced directive and stuff, that one we go if we do not know. She has already passed that stage of advanced directive, and she said the mom has the power of attorney was given to my dad, yeah, because she's a complete loss of. So we don't need to actually do another assessment again. It's matter of transfer of power of attorney now. So if it was a father, then yes, it needs to be passed on to her. But what she said was like, I could not arrange that. We need to tell her by saying, okay, so what happens this consent form and taking decision, about their health on behalf of anybody, obviously, is a legal matter. So we like this decision to be taken by someone who has been given the power of attorney. However, I understand because of your dad's death. And when she told my dad has passed away, again, very natural human response, say, I'm sorry to know that, and how you've been coping. Yeah, just ask her a little bit about that as well then. Okay, so coming back to the power of attorney, then you say, okay, so so what we can do, basically, we can facilitate and help you. I can speak to your GP to facilitate that process of power of attorney being transferred to you. and then you can give us the consent. However, because there is no conflict between what the team of doctors feel is in the best interest of your mom, and you're agreeing with that treatment, this should not delay the procedure. Okay, so I will document all that discussion which have taken place, and that you agree with the management plan to go ahead. We will go ahead with this procedure for your mom. And then you can explain about the genesis. So there was a couple of things which were important. Number one, you said she will be given general anesthesia, or she might be given, I guess you are wanting to talk about maybe spinal or paracervical block. No, spinal paracervical block is not an option for this woman. Yeah, she could not have the transvaginal scan because she was confused. She could not understand why you guys are trying to poke things in her that area. So she needs to be put to sleep, yeah, because of her confusion, so that she's not upset that what's going on down there. So it will be general anesthesia. So you don't mention about the regional or any regional block or anesthesia. Number one. And the second one, the thing to say, like, we will, because you don't have this power of attorney, we will take court order. No, we don't need to take the court order here. Court order we need to take if there is a conflict between what we feel as a clinicians is in the best interest of the patient and the patient's representative, even if she would have the power of attorney, and then she refused, no, I don't want my mom to go through that procedure, that will bring the conflict. Then we will take a court order to actually override her right as well. Yeah, or if nobody is given power of attorney at all, or nobody is there basically to understand and do things, then we might need to again take some legal advice. So all we need to say to this woman is, first we will speak to your GP as well to ask them to help facilitate the process. I will, the way you established her Alzheimer extent, that was good. You can ask, like, tell me what stage she is. And she says she's total loss of, she can't recollect anything. So that means she has completely lost the capacity of consent. So we don't need to again do the reassessment. Yeah, power of attorney, complete power of attorney is usually given on that stage when the patient herself has completely lost the capacity. Yeah, so that's what you need to say. So all you need to say is, I will discuss with my consultant as well. I mean, form you're happy for us. I will document. It's important to say though. I will document that into the notes as well, and then we will go ahead with that procedure. Okay. Yeah.
Madam, one question here. Madam, Dipti here. Madam, one question here. In case if father had no power of attorney, so nobody has power of attorney and no advance directive. In that case, we should bring the court, or we should not, or directly just we have to, in the best interest of the patients, we are going ahead. What should be?
Yeah. So if that woman actually has not been to that stage where assessment could have been done and nothing has happened, then in that case, yes, first of all, we will then need to, again, it will be GP who will arrange all that stuff. So we'll say we need to speak to the GP. So what GP will do, GP will arrange for the independent assessment of capacity for that woman first. So there will be independent advocate who will go assess the capacity of that woman, and then they will first declare her loss of capacity after the assessment. Yeah. So once that is done, then the further way to do is if she has done clearly, if there is nothing in place, then you speak to the family members and to the friends and the people around, and you ask, did she ever, express any wishes? What would she like to do? If she come across to certain circumstances of the life, sometimes we just, by the way, we're talking with our family, and we just say something like that, just for an example, kind of, I was just saying to, my family the other day, if I get to any, stage, debilitated kind of stage, kind of these things, do not resuscitate for me. Just put that in, if I'm going, let me go. So sometimes you have just said that, by the way, just like, and the family just say, oh, please, mom, don't say these type of things. So these, you check that family. Does she ever expressed any wish, what she would like to do in some particular circumstances? Then that can be put in place. And some people, yes, they have already done that advance directive. The people who are diagnosed with these conditions, which they know they're going to deteriorate, whether it's Alzheimer Are there certain kind of, they usually do here in this country. The people usually have their advance directive in place, even when they have full capacity. They have advance directive, like when I'm not there, or I'm not able to make, I'm not able to make my decisions regarding my health. So they do write clearly whether this will be the person. If that person is not, then this person. And they also tell about as well, because there's again a legal document. So they're asked like what extent, what type of procedures, what and how, what you would like to do, how much. You can even choose in these certain things, you can take the consent from that person, do whatever that person decides for me. And not in these certain circumstances. They might just say, okay, do this one. So, for example, she doesn't want to be resuscitated, even, she's physically still well and all that stuff, because she's in Alzheimer's or whatever. She know I'm deteriorating, and she can't say, if I get to that stage where I completely lose my capacity as to please do not resuscitate. And in this one, I'm just saying that now, even my attorney doesn't, I'm not giving this attorney to anybody else. So they can have a selective attorney as well. So yes, but if there is nothing, so then you do that assessment first, and after that assessment, then there can be a family member who can be given that power of attorney. And if there is any conflict, people think, this person is not, and the power of attorney, once that is granted, that doesn't mean that person basically can refuse the treatments. Power of attorney is again kind of young children consent of under 18 people. Yeah, under 18 people, if they understand things, they can give the consent to accept the treatment. They cannot consent to refuse the treatment, which is in their best interest. Yeah, so the power of attorney work the same way. Those people, they can take the decisions, but if any stage we feel the decision they are taking, it is against the best interest of the patient, then we override in a mean like that become conflict, then we go to the court, then we take advice from our legal team, and then we take it to the court as well, clearly saying there is a conflict. But in this case here, we know the best interest of this patient is to go under EUA stereoscopy biopsy, and the daughter is happily, after listening the procedure and complications, she's happily agreeing with that. She's saying to us, go ahead with that. I'm absolutely fine. So even if she signs the consent form, I mean, that won't have basically the legal, like she can't come later on and sue us in a way by saying, no, I wasn't told this thing at that stage. This is what we mean. Okay, so she can still even sign the consent form. Important statement here to say is that this consent you're signing won't be valid. Yeah, it's not valid because you don't have the power of attorney, but it's absolutely fine because you don't have any conflict with us. You can sign it, and I will document in the notes as well. Okay.
There's
Yes.
one
Yes.
question regarding this scenario is that NHS does have, because somebody told me that NHS trust has a separate unit which when if such situation arises when there is no legal power of attorney, so the people there are there in the NHS trust special department, so they assign an independent advocate, or the GP does the same. Like, what
Okay.
we have to say?
So right. Okay. So these independent advocate to do this assessment is not NHS. It's not under NHS. So we don't have any special NHS department who will do that. Power of attorney is overall a competency assessment. So that is independent, itself independent kind of a court department. And why we say the GP will do it? Because the GPs can actually, being acute trust in the hospital, you can't really do these things for them, spending so much time, who will be actually talking to the lawyers and all that and trying to that. So the GPs basically know those departments, they will just refer to them, contact them, and they will issue, because GP is the person who basically is mainly looking after those patients overall holistic matters of their health. So the GP basically again will just refer to that service to say, that this person, I feel this patient needs to have this competency assessment done, and then that department will arrange. They will write back to the GP to say, okay, this is the person who will do, this is the assessor. So when we say independent advocate, that means it's not going to be either from the family or from the clinical team. They are different, legal kind of, you can say, trained particularly for that one. So they will then do it. Okay, so there's not anybody inside the hospital, just for emergency situations where we have to do something. Say for example, in this one, although there is no conflict, there is nothing problem, I will have the signs of this woman on the consent form anyway, because that will just help me in future to say, well, she agreed at that stage anyway. But this does have the legal, basically, no, she can't come and sue us. Why we write these, why we sign these ones? There's a legal binding between us and the patient that we have given this information, and this patient has accepted to take these risks. So if anything goes wrong, this person can't come and say, well, you didn't tell me, I didn't know this, otherwise I wouldn't have chosen this treatment, right? So for this daughter, when we are saying this consent, your consent won't be valid, means you can sign it. We can write in the notes as well, you agreed. But say in future, if she wants to come and say, well, no, I wouldn't have not. So say, for example, during this procedure, because of some complication, something, her mother dies, and then she come and say, well, I didn't want it to have my mother to have this procedure or something. This is not going to be valid. That's not going to affect us. How we will be judged? The judgment will be to say, was this procedure really required for this woman? Yes, we know from the practice, from the guideline, and that's what we will do. Not most, all of the gynecologists will do under these circumstances. And then those complications, are they the expected complications and the risk of the procedure? Yes, they are. Then we are not guilty either. Yeah. So that's what the consent is required. Okay, let's go to the next one now.
Dr. Priya,
Madam,
ma'am, just one more
Yeah.
question.
Madam, one question. So, in case if a power of attorney is not there or advance directive is not there, then should we go directly in the with the best interest of the patients, or for that best interest of the patient also lawyer is required?
Okay, so there are two situations then for that circumstances. The one is it emergency situation, or it is something which can wait? If it's an emergency situation which cannot wait, and there's nothing in place, then still we speak to the family. Okay, still you will speak to the family and the friends, whoever are with that patient, to tell them this is what the procedure is required for. And then you will speak to your other couple of colleagues who are on the floor as well, maybe other consultant, other, just all of you will discuss and say, yes, this is actually necessary procedure to go ahead. We should do that, is in the best interest of this patient, right? And then you tell the family as well. If the family says, yes, that's fine, that's okay. If the family still says, no, no, we don't want to, I mean, still, it doesn't matter anyway what they are saying. So your team of doctors, you will decide, yes, it is the best interest, we're going to go ahead, but you will inform your legal team. Okay, so your trust have a legal team. You ring them to say, these are the circumstances. We as a team feel this is in the best interest of this patient to go ahead with this procedure. So what is your legal advice on it? Right? So if there is any legal thing they have to add up, they might just tell us, okay, you need to be aware of this and this. And after that, still, if you all team of clinicians feel this is the best interest, you should go ahead, that's fine. So that's all we will do at this stage. We don't need to go, we can't, because the court and stuff, obviously that will be done next day. There are timings for that. We can't let the patient die. So that's the emergency situation. That will be done, yes, if it's in the best interest of the patient. After discussing with your other colleagues as well and informing your legal team of the trust, you will go ahead with the procedure. If the procedure, investigation, or treatment can wait, then there are two situations. Then you can see, does this patient actually have temporary loss of competence? There is a whole lot detail in the consent. We will be doing that in clinical governance. Okay, otherwise we will be sitting and discussing this whole day. So I will explain those on that stage. Okay, let's move to the next one. This competency assessment, what they are, consent, valid, we do have that in clinical governance session. We will go in detail in there. Right, who is the next then?
Deepthi.
Yes, ma'am.
Okay, let's give you this. Let me just see. Okay, that's for you.
Okay, ma'am. Can I start now, ma'am? Dr. Rina, your mic is open. Ma'am, can I start?
Yes, you can start, Dipti, now.
Yeah. Dr. Rina's mic is open. It keeps on echoing. Yeah. Hello, I'm
Everybody else switch their mics, please. Yes, Dipti.
Yes. Hello, I'm Dr. Dipti, one of the doctor on duty here. May I confirm your name and age, please?
Yes, doctor, my name is Annette Davidson, and I'm 28 years old.
Okay. Good to see you, Annette. Annette, as you are aware of it, you are posted for the cesarean section tomorrow, right? And
Yeah, I have low-lying placenta, so I'm having cesarean section. That's right.
yes. And are you aware of the procedure and how you will taken care of it? Do you have any idea about it?
Yes, doctor, I have 2 cesareans already. So I pretty much know what to expect. Yeah.
Okay, good. So, Annette, I have some. Do you have any other specific concerns for these consultations?
No, not really. You know, it's not like I pretty much know what to expect, really. So no,
Okay.
I'm all right. Yeah.
Okay, okay. And it actually after reviewing your notes and reading through it, I came to know that you are Jehovah's Witness and you have major placenta previa, and you are posted for the planned cesarean section, and your blood group is so positive, and except the previous two cesarean section, is there any other surgery in your case?
No, doctor, there isn't any other surgery.
Any other medical problems? No. Hmm?
No, doctor, no.
Okay. And any kind of allergy to any medicines or anything?
No, as far I'm aware of, doctor, I don't have any allergies.
Okay. Any disease that runs in the family, mainly the blood clots in the legs and lungs and all?
No.
And do you have support at home?
Yeah, my partner is quite supportive, and I have family around as well. Yeah, thank you.
Okay. Yeah, that's good. So, Annette, I would like to just ask you that in case if this is a major surgery and we anticipate that bleeding can be little bit more than the usual cesarean section, so some patients may require blood transfusion. So, what is your wish to till what extent you can offer us some liberty to give you the any other blood products or not direct blood? Can you just make
Yeah,
us
no,
clear?
yeah, doctor, no, I'm Jehovah's Witness, so I wouldn't like any type of blood transfusion.
Okay, but are you ready to take your own blood? That is called a cell salvage, because in case if you are bleeding more, so we can just filter your blood and we can give it back to you after some procedure.
No, doctor,
Are
we
you-
don't. No, I can't have any blood product at all. Neither my own. No.
Okay, so in case even if we take the major measures to control your bleeding and all, and in case if it is a life-threatening condition, then do you allow us to take your womb at least just to save your life as a last resort? No doubt your surgery will be done by the competent and trained doctors. But still, because your situation is like that, your placenta is low-lying and it's major. So are you allowing us to do that?
Well, obviously, I wouldn't like that to happen, but if that's the last thing you will need to do, then yeah, I can have that.
Okay, so Annette, I would like to go through a procedure. First of all, we will admit you, and our anesthetist doctor will also see you. And at the time of surgery, there will be, IV line, and you will be given some fluid. We will put a catheter, and we will check you. And there will be in the OT team will be there. Operation theater nurse will be there. Okay, are you with me?
Yes, doctor. Yeah.
Yeah, and then we will just give a transverse, horizontal incision on your tummy, and then we will just in the womb also there will be transverse incision, and we will take your
Okay.
baby out, okay, and we
Yeah.
will take optimum measures to control your bleeding so that you know you will not require any further emergencies, okay.
Um, okay. Sorry. What was this last thing, doctor? Didn't quite get it.
So in case we will take the optimum measures to control your bleeding so
Yeah.
that yeah, we will not face any emergencies, okay?
Okay.
And yeah, and after the delivery of the baby, we will close the womb in 2 layers usually, and you will be transferred to the recovery room, and there the special nurse will be there. She will check
Okay.
your blood pressure, pulse, everything very frequently, and after you are stabilized, we will shift you to high dependency unit, because usually in such cases chances of bleeding are high. Bleeding is high. So
Yeah.
you will be monitored closely, and
Yeah.
we will put you, okay?
All right. Okay.
And baby will be taken care by baby doctors team. So no need to worry about baby, okay?
All right.
And
Okay.
after 2 3 days, once you are when you are able to mobile and all, we will just take your catheter out, and we will start feeding you slowly, and you will be discharged after 2 3 days in a safe condition, okay.
All right. Okay.
Now, for this procedure, there are some chances of infection is there. To control that, we will put you on some antibiotic, and
Yeah.
we will evaluate you for the blood thinning agents also, because of chances of blood clots are also there, especially after delivery.
Mhm.
Okay,
Right.
and we will put you good pain relief also to relieve your pain. So you will be fresh. You will not feel pain more. Okay,
Okay. Yeah, that's okay.
and so if you are happy to sign the consent form, you can sign it here. I have put my name and role. You
Mm-hmm.
can also put your name and date of birth. Okay.
Yeah. Yeah, that's fine, doctor. I can do it here for you.
Okay. Do you have any other specific concerns about your consent?
No, not really. Obviously, I'm a bit, a bit scared of this, like the what you have mentioned about taking my womb away and stuff. But then I guess if that's the only thing can be done, then yeah, I'll I will have
Uh,
to do that.
Yeah, and your surgery will be done by the consultant doctor, okay? And there will be a group of specialist doctors. We will keep in the loop specialist radiologist also, so that in case in emergency, if we require his help to block the vessels to for that to control the bleeding, okay?
Yeah, okay. Right, doctor. That's fine. Okay, so you're done now then, Dipti? Thank you. So there is still
Yeah,
1 minute
thank
and
you.
26 seconds left. No, that's fine. Good. Well done. That was pretty well done.
Thank you, doctor. I'm
Good.
doing first time.
Yeah, good. No,
That's
it was good. So yeah, that's the important things you did discuss all those, and you know, you were confident in talking about them as well. You can organize a little bit more. So what she says, there are a couple of things there. The one which I would say probably better not to say. Number one, you will be given those pain relief, you will be comfortable and not in pain. We don't need to say that. Just simply say you will be given, you know, good pain relief to, you know, keep you free of pain, because we can't really promise. And with these major surgeries, to be honest, doesn't matter what amount of pain relief we give them, they can't completely be comfortable and out of pain. So don't make that promise. You don't need to worry about the baby. Baby will be looked after by the doctors. We don't know what the outcome of the baby will be. In case we open up, we are straight into placenta. She bleed like a hell before we can deliver the baby, and baby is deficient of all that stuff, and then baby doesn't do well. Yeah, all we need to say is once the baby is delivered, baby will be you know, seen by the baby doctors. That's fine. That's about it. Then there was one concern I was repeating. So, well, if that's the only thing, if I believe that you need to take my womb away, then yeah, I guess I have to do that. So before that, we talk about the womb. We need to tell her what measures which we will take to try to reduce and control her bleeding. But obviously, if it not, then we need to take it out. Yeah. So just these 3 points you need to just put that in. So to start with, yes, it was good that you didn't go into all that history. You just verified that I understand this is your third surgery. You have 2 operations before, and your blood group is this, and you know your placenta is low lying. So to start with, yes, just confirm you're for this procedure, and then catch up to say, so I understand you are this. So that if she has anything else to add up, she can do. No, the details of previous pregnancies were given there as well, why she has those pregnancies. So that's fine. We don't need to ask this question by saying, you know, tell me about your pregnancies. But what important question I would like to ask though, were there any problems during your first 2 operations? Like any injury to any organs or any scarring? Were you told, you know, after the operations, how was your recovery after surgeries? Because that will again very much help us to see if there can be high risk of adhesions. She is high risk of adhesions anyway, but you know, is it going to be really, if she has infection in post-op period or something, or she has some injury already, then she become even high risk. So that I will ask. And then you can ask her understanding of the low-lying placenta, right? And then you will say, okay, and then I can see this time you have your placenta is low-lying as well. So would you please tell me like what you understand from you know, the position of your placenta? So just listen then what she says. Does she already has been discussed, and does she remember, or she knows that, you know, she's quite high risk of bleeding this time and all that stuff. So after doing this initial you know, your information gathering, you can say, then you will say, so the third important thing was she's repeatedly saying, yes, I know I had 2 operations already, so I know what to expect. So that was something I need, because she's thinking it's going to be just straightforward procedure in the cesarean, just like the last 2 times, but it's not. Yeah, it's not. This
Yes,
time it
yes.
is a lot more complex. She has 2 cesarean additions, that story is there, and then low-lying grade 3 placenta itself is and its interior as well is the, yeah, interior. So we need to say, and this one I say, so yes, I can see you have 2 cesareans already. So that's good that you have an idea overall what to expect. However, this operation is this, you know, your this cesarean operation is going to be quite more complicated and high risk as compared to your previous 2 surgeries. And the reason for that is, number one, talk about the adhesions and say, because you have 2 operations already, every surgery heals with scarring, and it can leave, a lot of scarring and adhesion inside. So, you got your womb, in front of your womb is bladder, on the back is the bowel. So when that wound heals, sometimes bladder and bowels can get stuck to the lower part of the womb. So we will need to separate those. If that's the case, we will need to separate them before we can open up your womb, and that can increase the risk of injury to your bladder, bowel, and to the blood vessels as well. Okay, so explain that risk first, which is different from previous surgeries. And second, you will say your placenta is low, and on the front of your womb as well. So there will be risk of bleeding of that as well. And then you say, so you give the main 2 points, and then you start the routine of our that template we had. Yeah, so you will say, okay, so you'll be seen by the anesthetist as well, and he can discuss about the type of anesthesia he will use and any complications and any side effects of the anesthesia. He will explain it to you. You will have the cannula. So try to avoid the technical terminology. So don't say IV line. You will be taken to OT, and there will be OTA. No, I mean, you don't need to take into that detail. There will be operation theater nurse, and there will be operation theater attendant and that stuff. No, just simply say there will be a cannula pass so that we can give you some fluids. Then you will be taken to the theater and seen by the anesthetist, and then you will be passed a catheter as well to empty your bladder, and then we will start your procedure. And then you can start explaining. And now, because you will be on the camera and not on the paper, you can just put your hand in front of the patient facing, and then you can just tell, so if you imagine this is your womb, we will open your tummy through the same incision in the lower part of your tummy, and you can say, okay, that will be horizontal. Don't say the word transverse. Otherwise, as long as you say the same incision, that means obviously she has finasteride previously, she will have the. But if you want to say horizontal, you can say about the same place at the incision, and then we will open your bladder. So obviously, as a cell, like there can be risk of adhesions. So if there are any scarring from your previous operations and your bladder bowel is sticking to the womb, then first we will need to separate them from your womb before we can open up your womb. So that will have increased quite high risk of injury to bladder and bowel. However, do not worry, we are aware of that, so we will take our possible measures to prevent that from happening. And for that reason, your surgery will be done by the consultant, but it says you are a consultant here to imagine anyway. And if any injury happen, we will repair it for you. And then we will open. So keep going again step by step. Then we will open up the womb. So your placenta is quite low lying, and on the hand you can just say it's lying right underneath where we need to open the wound. So the consultant will just put a scan to find out exact position of placenta, and then they will try to open it away from the placenta, but sometimes it's not possible. So when they will open up the womb, there is a high risk that there can be a cut through the placenta as well, and obviously that and then lead to quite heavy bleeding. However, again, we are expecting that to happen, and so they will quickly go through your placenta and deliver the baby, so the baby doesn't have the effect of their blood loss. After that, obviously, we will try to remove your placenta and control the bleeding. So what we will do, you will be given, so tell what we will be doing to prevent the bleeding. Yeah, so what that happening, like we give you some injection, we call it syntocinon, that will be given to make the womb to contract and separate the placenta, and also contract to stop the bleeding. You will also be given the drip of that medicine syntocinon to help to keep the uterus quite contracted. Sometime it may be difficult to remove the placenta, and that can lead to quite heavy bleeding, or the womb may not contract as much as it should do, and that can also lead to heavy bleeding. If that happens, then the next step usually we do is we will get help from the radiologist as well. He will be there in the theater as well. He can put some chemicals into those blood vessels, and on your hand again you can just show like the signs of blood vessels. We put some chemical into those blood vessels to try to block that blood flow to the uterus to help reduce the bleeding. However, if all these measures fail, or sometimes we can then just tie up the main vessels, blood vessels which are supplying to the womb. However, if these measures don't work, then as a last resort, sometimes we need to remove the uterus. no, at this stage, if you establish that blood transfusion stuff at the beginning, which is fine. Otherwise, when you're talking about blood and bleeding, you can address it there. It's up to you how you want to organize it. So just ask about the blood transfusion, so I can see Jehovah's Witness, which will help me to understand like what type of blood you will, if there is any blood product you will accept. So she said, no, we don't take the blood transfusion. So you can say, okay. So in case of very excessive life-threatening bleeding, will you accept, we call it cell salvage, in which we basically collect your own blood, which is lost in this operation, clean it, and then just give it to you back. Would you have that one done, or you don't want that either? So if she says, no, I don't want to, then just ask about a few blood products, like, sometimes we give you separate the clotting factors which help to clot your blood and stop bleeding. Are you okay with them or not? And then, these blood-driven products, actually. If she says no, there's a big no to everything else, then what you will need to say is then, so have you signed the advance directive already? And she says, okay, yes. And that actually is obviously a permanent thing done already. And then you can say, okay, so in that case, no, for anybody else who will accept the blood transfusion, we can actually try all of these measures I've explained to you to stop the bleeding, because we can replace their blood which is being lost by the blood transfusion. However, in your particular circumstances, because you won't take any blood, we may not have enough time to try all of these measures, because all that blood loss which is happening during that time, we will not be able to replace that blood, and that can then lead into quite many life-threatening situations, the conditions later on. So for that reason, we may need to take the decision to remove your womb much earlier than any other woman in your circumstances who will take the blood transfusion. Okay, so this is how you need to compare and tell her, because only saying that we take your, we may not be able to actually, if she's having torrential bleeding, we may not be able to try the UAE or internal ileak ligation or anything. We might have just been going and the placenta is not removing, and we might just decide just take it because we know we cannot replace this, right? So this woman can later on, we can be questioned in the court in case obviously, that, why didn't you try these measures, right? So at this stage, we need to tell her that in your particular case, we may not be able to do certain of these procedures, so we may take this early decision for you. With that, how you feel about it? I won't say will that be okay with you. I need to ask her how you feel about that. And then obviously if she says yes, obviously if that is the last resort I have to do, then must say, okay, so I will document that into your notes and the consent form as well. That we can take your womb out, but that will be done, reassure her that will be done only in case if we felt, that will be life-saving measure. And then you can now, if you see, like if you go step by step, how beautifully you have explained the what can go wrong, what we can do to correct it, and you also brought that thing as well. Now then you can say, if everything goes straightforward, fine, you will be taken into the recovery room. So just that template which I discussed in the beginning, so just follow them. You will wake up with these, you will have the pain relief antibiotics, blood thinning medication, blah blah blah, and then you will go home with this. But if any complication happened, like excessive blood loss, or we have to remove your womb, or any injury happened, then obviously it can take longer time to repair them as well, and then we may need to monitor you more closely in high dependency unit for some time, a couple of days. So your duration, yeah, your stay in the hospital can be slightly prolonged as well. Just the first template which I discussed with you. So it's just the main central bit about the surgery. You need to add if there's anything different. Okay.
Okay, ma'am. Okay. Should we, ma'am, talk about death also,
Right.
like a question,
Yeah.
or
So
no?
who is next?
Madam, should we
Yeah.
talk about death also in the risk factors?
Sorry.
Ma'am, should we talk
I'm not
death
quite
also in
echoing. I
the,
can't understand. Talk about what?
should we talk about
Date.
some patient can die in the life-threatening bleeding, something like that, or
Oh,
no?
yes. So that's why I'm saying life-threatening. Yeah. So when we're saying it's life-threatening, it can be life-threatening. So you can, if you want, I mean, when we say it's life-threatening, that's what it means. You can die as well. But if you want to say clearly, so in these high-risk procedures, we are supposed to tell them death, yes. So either you can say it can be life-threatening, or you can say, I mean, if the bleeding is not controlled, obviously that can lead to death. Okay. But
Okay.
when you say life-threatening, that's what we mean. But you can clearly say in these type of procedures, yes, Jehovah's and placenta and that, yeah, yeah, absolutely okay.
Okay. Okay. Thank you.
Next,
Next is Fatima, but she has put in the group that she won't be able to do. So then
yeah,
next is Lubna.
okay, Lubna, are you there, Lubna? Yeah, Lubna hasn't been able to attend the session right from the beginning till so far. Okay, who is next, Pramila?
Sujata.
Sujata?
Yeah, hello, Dr. Sasi, I am here.
Yeah, okay, Sujata. So this one is for you now then. Okay, this is yours then. Okay, that's your first 2 minutes, Sujata.
Hello, I am Dr. Sujata, one of the doctors in the ward today. Can I confirm your name and age, please?
Yes, doctor. My name is Charlotte William, and I'm 41 years old.
How do I call you? Charlotte is
You can
okay?
call me Charlotte, yeah.
Thank you, Charlotte. I see that you are admitted for laparoscopic hysterectomy tomorrow. Is that right?
Yes, doctor. I'm having removal of womb through keyhole surgery tomorrow. Yes.
Okay. And is there any other concerns that you have?
No, not really. I mean, I was told about this procedure because I had this bleeding so long going on, and my doctor just tried everything. Marina coil, some pills, everything's not working. So my consultant said it's better for me to have the womb removed now. So that's what I'm having it. But what happens about like when we have the discussion in the clinic, because I'm 41 at this stage, my consultant thought it would be a good idea to keep my ovaries behind because I do need those hormones. But I want those ovaries to be taken out as well. I'm really worried about having cancer in ovaries, so I would rather like my ovaries to be removed as well.
Okay. Charlotte, can you tell me why you want your ovaries to be removed?
I'm just worried about, getting cancer in ovaries. My grandma has recently been diagnosed with, cancer of ovary. Um, so I feel like, I should remove it because then I could have a cancer in my ovaries as well.
Okay. And, how is she now? Your grandma, how is she now? Did she have any?
She No, she's doing okay now. She has the operation done where her ovaries have been removed and her womb as well. But I'm really scared of having this cancer.
Uh, At what age was your grandma diagnosed? What's the age of your grandma?
She's 87.
Was she told that it is a cancer which runs in the families? Was she told like that?
Uh, no, she hasn't mentioned anything like that. No, I don't know. She
Okay.
hasn't mentioned anything like this.
Yeah. So, is it all right that I ask few more questions to know a
Yeah.
little more about you before we come to whether we should remove your ovaries? I can tell you
Okay. Yeah,
everything
that's
on
fine.
it.
That's
Yeah.
fine. Yeah.
Do you have any other medical illness for which you are taking treatment with the GP?
No, doctor.
Have you had any surgeries in the past?
I
Any
have
other?
two cesareans.
Okay.
Yeah, that's all.
Cesareans. Okay. And how many children do you have?
I have four.
Okay. And okay. And I see that you had suffered a lot and now you have agreed for the removal. Uh, are you on any other medication right now?
No, I'm not taking any medication other than iron tablets I was put on.
And do you have any allergies, Charlotte?
I'm allergic to penicillin.
Okay. It will be noted in your notes. And is there any family history of clots in your family in the legs or lung?
No.
And how is support at home, Charlotte?
Yeah, I have good support. My partner is quite supportive. Yeah,
Okay. And do you smoke?
I do smoke, but not much. Just one or two cigarettes. Just a social smoking, really, when I go out with my friends. Not a regular smoker, no.
And are you aware? Have you been told to stop smoking because you're going to have a surgery? You're not told because it's not good for your health.
I don't smoke regularly, doctor. I mean, I just take when I go out with my friends. So I'm not a regular smoker.
Are you aware of your height for weight ratio?
Yeah, it's 26.
Okay. Is there anything else you would like to share with me, Charlotte?
I can't think of. I don't know. I can't think of anything.
Sure. So from your history, and is it all right that I go examine you in the presence of the chaperone just to see your
Okay.
blood pressure and your tummy, how it is, and internal examination?
Yeah. Yeah, if you need to. Yeah, that's fine.
So yeah, you have understood what surgery has been planned for you tomorrow, the keyhole surgery. Was it explained to you how it will be done?
Yeah, I was told there will be camera put in just below my tummy button, and then my womb will be taken out.
Okay. And now you want your ovaries also to be removed along with the womb.
That's right.
Was it? Are you aware that because you had two cesareans, it might be difficult to do a keyhole surgery? Was it explained to you? Sometimes we might have to make a cut and remove the womb.
What you mean, made a cut and remove womb, doctor?
suppose, in case we find it difficult to do
Yeah.
a keyhole surgery, we might have to do
Okay.
a open surgery because you had
Okay.
two cesareans. Was it explained to you?
Yes, the consultant mentioned that we may, in case if there are anything goes wrong, then we may need to open up the tummy. Yeah.
Charlotte, and there are some risks to you because of this surgery. One is the anesthesia risk, and it was it explained to you as well? You can have risk due to the anesthesia and due to the surgery.
Okay.
So we will it will be done by trained professionals so that you will not have any complications. So these are the risks, and sometimes because of the previous two surgeries, the bowel and the bladder may be adherent to your womb, and so when we are trying to remove it, we can injure these organs, which will also be dealt with immediately. Then coming to your
Okay.
request for the removal of ovaries, your grandma's cancer was at a very late age, and it's you're not sure whether it is a cancer which runs in families. So, from your history and the examination, it looks like you do not have a high risk for getting ovarian cancer. How- Are you with me, Charlotte?
Yes, I am, doctor. I get you. Yeah.
So,
But I
as
would
my
like
concern,
to, I mean, I have made my decision now, doctor. I don't want to sit on that. So I would rather like my ovaries to be taken out.
so you are aware that once we remove your womb with the ovaries, you will have to be given hormone replacement therapy.
Yeah. If I need to, I will take that. Yeah.
Yeah. So anyway, we have you are not having any medical conditions. Do you have any headaches or migraine, or you don't
No, I
have?
don't.
So we will be giving you hormone replacement therapy if you have symptoms. That will be good for your health of your bone, your brain, and your heart. Okay.
Okay, doctor. Yeah. Yes.
So since so if you are willing to undergo all this, can we sign the consent form now? Can I take you through that?
Yes, doctor. Yeah, I'm happy to sign the consent form.
I will add in your consent form that it is removal of the womb with the ovaries. So I'll add that, and I will sign down below and you can sign here. And I'll also inform my consultant that you want the ovaries to be removed. And I'll be informing the OT team also that tomorrow we'll be removing your womb along with the ovaries. Is that right, Charlotte?
Yeah, that's fine, doctor. Yeah, that's right.
Is there any other concern?
No, that's all.
Thank you for your time, Charlotte.
Okay, doctor. Thank you. Okay. Thank you. So, yeah, just in time, 30 seconds. That was good. Thank you.
Thank you.
Uh, yeah. So, yes, that was right thing to tell her about if she has any additional. I won't say high risk. The word here is additional risk, whether she
Oh,
has an additional risk. So I will say, like, you know, if you can and has not been told that she has the type of the cancer which runs in the family, then and from the information I have from you, you do not seem to be at additional risk. But it would be a good idea to ask about any family history or even her personal history of breast cancer, cancer of the womb, and the cancer, bowel cancer as well. Yeah, because obviously breast cancer and those could history of breast cancer or bowel cancer could change the situation. So that's one. And the important point here was, yes, from a safety point of view, that I'm going to inform the consultant. I will also inform again, please don't say word OT. I will change your name of the procedure on the list as well to include that we are removing your ovaries as well. I will let the anesthetist know and the theater team know that there is a change in the procedure and that we are removing your ovaries now. Okay. So that was fine. So in the beginning, history taking was fine. Whatever you asked, like you were asking about the history of blood clots in the family. Ask in herself as well. Yeah, what her BMI is. What is? Do you have any history, previous history of blood clots in legs and lungs, breast cancer history, and bowel in the family, and herself. And then it was right to ask what her concerns are, why she wants the removal of ovaries to be added up, and then she tell you the reason why that is. Then just go, although it says she has the consent already, just go over quickly about the procedure again, which way this will all happen, because there's just a day before you're saying, yeah. So just make sure she still have the understanding. So instead of asking, have you been told the risk of the anesthesia? Have you been told this? Have you been told this? Just simply say, I hope you have been told about the, the procedure, what it will involve. We will actually put you will put to sleep for this procedure. So there will be general anesthesia. Anesthesiologist will come and see you as well. And will explain any, any side effects, any risk complications of the anesthesia with you. And then, on that morning, you will have the cannula, you will have a catheter passed in, and then, we will put a camera just below the tummy button and then remove your womb. However, because you have 2 cesareans already, there can be a risk of scarring and adhesions from the previous surgery. And so that you explain nicely, bladder bubble they can be. So if that's the case, then we will need to remove those scarring and adhesions first. And that slightly increases your risk of having injury to blood bubble and vessels as compared to any, average procedure. Then check about the blood transfusion. Are you okay with that? What is the blood group? Then she says, I am taking iron tablets. So that means I need to be aware that I need to check hemoglobin. Yeah. So I will say, okay. So are you anemic? When was the last time your hemoglobin was checked? Okay, I will have a look and see if that is up to optimal levels for the surgery. Okay, so that was important point. The other very important point is to ask her if she's taking any contraception. She's 41 years old, and we know she has the Marina first, and then she has an meter ablation. So what is happening after that? Is she has any contraception? So it may be that she's not on contraception, and then she has sex about 2 days ago, unprotected sex. So this woman is at risk of pregnancy then. Or she, because of the bleeding, it's quite likely Marina didn't work, endometrial bleeding not work. For the time being, while she's waiting for the surgery, GP might have started her on combined oral contraceptive pill, and she hasn't stopped taking them because nobody actually went into that detail. Yeah. So it's very important to ask. So all childbearing women who come for any surgery, it's important to exclude any risk of pregnancy and also check what contraception they're on. So that was, I think, important thing I would like to add. And then regarding the hormonal, the ovaries, removal and ovary, that was fine. Telling like, you're not an additional risk. However, if you still want your ovaries to be taken out, we will remove that for you. But I would like you to let you know then you will need to have the hormonal replacement therapy, because obviously, the hormones of ovaries are producing, they are important for the health of your bone and heart as well. So how you feel about it? And then she says, yes, I would like to go ahead with that. Then you can say, okay, so we will discuss and start you on appropriate HRT, hormonal replacement therapy, before we will discharge you. And then you can leave your hormone replacement therapy over there. Now, sometimes the patients can ask you at this stage, so if I'm starting early, will I have high risk of developing cancer, breast cancer, and all that stuff? You can reassure there's no additional risk again having the hormonal replacement therapy up to your average age of menopause, which is average is 51 to 52 years of age. After that, if you continue with the hormonal replacement therapy, you will have the similar risk as anybody else who will stop HRT at the age of menopause. So that's that reassurance. And obviously you have done that assessment already, asking about all that history to check she's fit for. A little thing more we need to add to her procedure explanation is, because she has been, done for hysterectomy, we need to ask about the ovaries as well, to say, because you have the surgeries and adhesions, the scarring, and even sometimes the ovaries may be quite stuck into that scarring and may be difficult to remove them. And maybe doing that, they can be, slightly higher risk of injury to your water pipe, and also the risk of bleeding. Yeah, so that additional risk we need to inform her as well of the procedure. And after that, you can say that that's fine. I can, I will add this to the consent and we can sign that again, and that we have already set up founding consultant in this operation team and changing the name of the procedure on the patient list as well. Good.
How to ask about pregnancy test here, whether you are pregnant or no? We can't ask
Any
directly,
questions?
no? Such cases.
Yeah, so the question you need to ask is, are you using any regular contraception? What contraception are you using? So if she says like, say, we've been using condoms or whatever we're using, then you can ask, okay, when was the last time you had a sex then? Do you have any unprotected sex in last 4 weeks time? And if she says no, she'll always use a condom, then you can say, okay, we will do pregnancy test just to make sure there's no risk of pregnancy, and then we'll go ahead with the procedure. And if she's some other contraceptive method, obviously, the coil or whatever, then obviously you can tell like, we will remove this for you and do so. To ask about the contraception and last sex when that was, and that should help you to decide the risk of pregnancy.
In case like this case, if unprotected sex just 2 days before, then pregnancy test will not be positive, no? At least 3 weeks should be there, no? So in
Yeah, they
that
need
case,
to be
what
3
to
weeks.
do? So in that case,
Okay.
what to do? We have to postpone the surgery.
So in that case, obviously, then I mean, I hope that doesn't happen. Actually, real scenario. That usually doesn't happen because the people who have talked to her about, they have clearly told her to use condom. But anyway, in case it is, then yes, so we need to inform her then that there could be a risk of this, the pregnancy from that unprotected sex, and we have not, we're not able to exclude this by doing pregnancy test today. It needs to be done in 3 weeks time. So we may not be. That's what you need to say. It's up to the fit consultant to discuss that. So they say we may not be able to continue with your operation today. I need to discuss it with the consultant to see what they want to do. Okay.
But ma'am, if it is only 2 days back, then there is no problem of me interfering with the ongoing pregnancy.
For today it's not, but then it takes a longer thing. You need to ask what day of cycle they are, was there any previous unprotected sex as well. So not from the 1-2 days, but it might be some from the previous. So you need to ask. But if she's only 2 days, she's still within 5 days. I mean, it shouldn't be like that. But anyway, if she's still within the 5 days, only one, then just like IUCD we provide and prevent the pregnancy, we can take the uterus off. That is the safest emergency contraception. But if she has some beyond 5 days, then I mean, it's not written anywhere. I'm just talking about common sense, to be honest. So if it's like, if we go ahead, if anybody challenge how we can justify. So I suppose if there is any unprotected sex within last 5 days and she doesn't want any child and stuff, then we can go ahead with the procedure. But anything more than that, then because we can't exclude them, in that case I wouldn't. If it doesn't come under the duration of emergency contraception cover, then I wouldn't, go ahead with with this, because you don't want to end up of sending that histopathology sample and that come back by saying, there was a psych and pregnancy sitting over there. Then you have no place to stay on Earth. Right.
Doctor,
Let's
And
move
how
to
madam,
the
to
next
counsel
station.
ma'am,
her about the risk of HRT with the breast cancer? Again, how to tell
So
her?
when we will tell about the risk of HRT with the
Mm-hmm,
breast cancer.
mm-hmm. How to
So if she
counsel her about it?
Okay, so we can do that as a with some other, because this is not the top, this gynae HRT and this stuff, because that will require a full whole station to do. So we can do that in our structure discussion station if you all feel that you would like to do that HRT with the breast cancer. I will add it to
No,
structure
the
discussion.
risk. يعني if she is asking about the risks of the HRT, or we are counseling, how we will phrase these words?
Okay, so obviously then in that case we say, so what happens basically if they're having the removal of their ovaries beforehand, like if we stick to this particular scenario where she's having this removal of ovaries at 41 years of age, and then she has some increased risk of breast cancer as well for some other reason, then she again doesn't have any additional risk, because we will remove the ovaries. The ovaries are still producing estrogen, yeah. So the amount of the HRT estrogen which we will be putting on is lesser than what her ovaries are already producing. But if we are doing after, it's like we somebody is going to have a HRT just for simple reason at menopausal and there is a high risk of breast cancer, then obviously we need to tell that the HRT increases your risk, additional risk that will increase your risk. Additionally, will make you high risk for developing breast cancer. So in that case, then you can offer her separate, vasomotor treatment symptoms separately, non-hormonal, and then for the bone protection, you can talk about bisphosphonates or other things. Is that your question, Sama? But in this
Yes, thank
particular
you.
woman, this 41-year-old lady, if she has any risk factor of breast cancer, removing her ovaries now and putting her HRT is not going to cause any additional risk till the age of menopause. Yeah, because her ovaries would have produced the hormones till age of 52 anyway, which are rather more than what we are going to replace with HRT. I hope that clears the.
Ma'am,
Yeah,
there
thank
was
you.
one. Sorry, ma'am. Ma'am, there was one safety point, na? In case if patient is on OC pills or HRT, we have to postpone the surgery for 4 weeks, or patient has to stop this hormone pills 4 weeks
Yes, of
before.
course. Yes, yes, yes. So
So,
that's why it's
so we.
important to ask. Yeah. So you need to then do it accordingly.
So in case if she is on OC pills or something, we have to make sure that 4 weeks before she has stopped.
Yes, yes. And if not, then yes, we are going to postpone the surgery.
Oh, okay. That also we have to rule out. Right, right. Okay.
Yeah.
Thank you, ma'am.
Okay.
Madam, after
Who
how
is
many
next?
days will we restart the I mean, we will start the HRT after surgery?
Well, I will need to look into that. You guys have started asking too many theoretical questions. So in counseling, from part 3 point of view, when you're counseling to the patient, you don't need to necessarily tell to the patient. Now you will say, we're going to stop this because it increases the risk of, the blood clots, and you already have the risk of blood clots, increased risk because of the surgery and, then immobilization and blah, blah, blah. So we're going to stop it now. We will start you, after the surgery. Then we will do assessment and we will start you when it is safe. So you can just have a look. To be honest, just look into wherever the guideline is to see. Yes, if it comes as a structured discussion, then yes, you need to know. Then they can ask you when you will start. And that again is individual. That will very much depend on the individual risk assessment of that patient as well. What are their VTE risk and did they have VTE? So just read that from structure point of view, structure discussion point of view. Let's go to the next one now. And who is the next?
Reena D.
So what's happening with Sadia, Ravina? Shouldn't Sadia be there as well as in S?
No, it's not S, ma'am. The 4 people who couldn't do last time were
I see,
Samira,
right,
Deepti, Fatima, and Lubna.
right.
And
That's
then
fine.
we have
That's
started from
fine.
the last person who did the last time and going in the reverse order.
Fine. Okay. Whoever. Okay. Who is next then?
Reena D.
Yes, Rina?
Yes, ma'am.
Okay. Let's see. Give to you to do. Okay, this is your station. It's your first 2 minutes, Reena.
Listen. Hello, I'm Dr. Lina, one of the doctors in the clinic today. May I confirm your name and age?
Yes, doctor. My name is Sarah Clark, and I'm 42 years old.
Is it okay if I call you Sarah?
Yes, doctor. You can call me Sarah.
So, Sarah, how have you been feeling after the surgery?
Well, I'm in a lot of pain, doctor, and I've been feeling quite lightheaded as well.
So, Sarah, should I ask the nurse to give you some pain relief so that you feel better?
Yeah, she has given me some just half an hour ago.
Okay, Sarah, once you feel better to talk, to let me know.
Yeah, I can speak, doctor. You can ask if you need to ask anything.
Okay, so, Sarah, I will just ask you a few quick.
Yes, hello? Hello?
Hello?
Hello, Reena. Yes, I can hear you now.
Okay, so, Sarah, has anyone spoken to you after the surgery?
Yes, yesterday evening, the doctor came and told me about the procedure, but to be honest, I don't really remember much.
Okay, so, Sarah, apart from the pain, complaints as of now?
No.
Okay, so, Sarah,
There's a lot of interruption in your sound, Reena.
hello, is it better now, ma'am?
Yes. Yeah, I can hear you now.
Okay, so, Sarah, were you visiting the GP for any medical concerns like raised blood pressure or any raised blood sugar prior to this?
Yes, I had high blood pressure.
Okay, and were you on medication?
Yeah.
Okay, and have you ever had any surgeries prior to this in your tummy or down below?
I had some keyhole surgery before.
Okay, so this is the second surgery, am I right?
Yeah.
Okay, and how was the recovery from the previous surgery?
That's okay, doctor. I don't quite remember.
Okay, so, and are you allergic to any medicines?
Your patient has collapsed now, Reena.
I'm going to press for the buzzer. And sister, could you please come and help me to resuscitate this patient?
Okay.
Sarah.
Okay, come
Sarah.
back to that.
Okay, so Sarah,
Come back to
I can
that. So
understand.
she hasn't quite collapsed, no, but she's about to collapse. So do something
Okay,
before she
so
gets
Sarah,
collapsed.
okay, ma'am, okay, I get you. So,
Yeah.
Sarah, I'm sorry to tell you that we are in an emergency, and I need to deal this like an emergency situation. Are you with me, Sarah?
Yeah. Okay, doctor.
Sarah, I think we have had a complication in the surgery. Would you like someone to be with you as I share the information with you?
No, doctor. My husband is gonna come at 2 o'clock in visiting hours. He's not here.
So, Sarah, I think that during the surgery, there was a slippage of some bleeding vessel, as can be seen from the examination findings, and there is a collection of blood. So, your pulse rate has increased, and your blood pressure is also on the fall. So, we need to treat this as an emergency situation, and we need to shift you right away
Sorry
to
for
the high dependency
interruption,
unit.
Dr. Sorry. What is the
Hello?
case? Because sorry for interruption. My screen, I can't see any case.
You can't see any case. It's there.
It
So
is
maybe
written
you.
like to add up
Okay,
BSO to the previous consent, and you
okay, so you may.
another patient.
Okay, so you may go out of the meeting and then log in again. That may help.
Okay.
Yeah, okay. Yeah.
Okay, so Sarah, we will shift you to the high dependency unit and we will be monitoring you very closely. And at the same time, we will be arranging some investigations in the form of some blood tests and also some scans. Is it okay, Sarah?
Okay, doctor, yeah, do whatever you
Yeah,
need to.
we will be starting you on fluids and we will be putting in the cannula and we'll also giving you some oxygen so you feel a little.
Okay. We lost you again, Rena. Can you guys hear me? Is my connection or is Rena's connection thing?
Yeah, we
Yes,
can
Dr.
hear you.
Are you
Sandra.
able to follow me?
Sophia, we can hear.
Okay.
Sarah, are you able to follow me?
Yes, yes, doctor.
And Sarah, we might need to take you up for a surgery again to the operation theater. I know this is really disturbing for you, but the collection of blood needs to be removed, and if there is any bleeding vessel, we need to tie it up immediately.
Okay, doctor.
So, hello.
Yes, doctor. That's okay, doctor. Do
Yes,
whatever you
and
need to do.
so in a short while, even the pain relieving doctor, whom we call the anesthetist, will be seeing you, and we will be also involving the and investigations are ready. Definitive.
Can everybody else make sure the mics are off? Okay, Rena. Yes.
Yes, so just to that we might need to shift you to the operation theater again.
Okay. Yeah.
Sarah, do you have any questions to ask?
Well, I just like so what's wrong? Is there some bleeding going on and that's why you need to take me to theater to fix it?
Yes, we are anticipating a bleeding because there's quite a big collection of blood on your tummy, and that's not a normal finding. So that needs to be explored.
Okay, doctor.
And just to
Yeah.
inform you, Sarah, that our hospital takes these issues very seriously, and we will be initiating an incident report for this, and we will try to find out that what went wrong or what could have been done better or differently. And as soon as we are through with the investigation, we will get back to you. We will be open, honest, and transparent about that to you. Is it okay, Sarah?
Yes, doctor, that's fine.
Sarah, so you might hear a lot of people, you might find a lot of people around you. Please don't feel unnerved. They're just to help us to expedite the better management and in a faster way.
Okay, doctor, no problem. Yeah, that's fine.
And Sarah, I'm right here in the ward. Anytime you need me, I will be right here for you.
All right, doctor, that's fine. Thank you. Okay.
Thank you for your time, Sarah.
Okay. Thank you. Thank you, Rena. Right, that's fine. Yes, thank you, Rena. So, yeah, so the approach to start with this type of stations when the patient has something, dropping blood pressure and temperature high and saturations going down or things like that, then you need to basically, as we say, like if it's acute condition in the hospital, you need to first of all, establish the immediate well-being of the patient, yeah, before we go into details. So this woman who is so much hypertensive, that large, the hematoma and everything, second day of surgery, if we start taking previous history from her, that just is, just I think disaster. Because we know all that. For the time being, again, when we start taking any information, just think, do I really need this information at this stage? Is that going to make any difference to my approach of management. Yeah, so she's quite unwell patient. So first of all, we need to make sure that we just establish, some IV lines, or if she require any oxygen or whatever, put her on monitor and stuff. But these are things we need to do in a way. We don't want to scare the patient and make her frightened. So there's no need to say we are in emergency situation and then we are going to deal it as an emergency and all that stuff. Yeah, that one is just for your own understanding. Think that this is emergency basically. I need to start with that. But you need to be very calm basically and focused with that patient. Even when you're going to tell her this, that we need to do this. So for this woman, basically, I will enter. And the other important thing is always first, not you do call the right way, Rina, just for everybody else. Always call the patient with a full name to start with, Sarah Clark. And then don't yourself decide, I'm going to call her Sarah. Or don't just give leading question by saying, is it okay to call you Sarah? No, just ask nicely, what would you like us to call? And then whatever she says, call, speak to them from that name. So after that one, I will say, I will talk to her, start talking, hello, Sarah, I'm Dr. This and this on duty here. And I'm called by the nurse because you've been feeling quite unwell and you're in a lot of pain. Is that right? So she says yes. And then if you see, you can see those findings are given to her on there as well. So before actually I do and talk anything, I will say, so Sarah, I can see your blood pressure is quite low. And you're running quite high fever as well, and that's the reason you're feeling quite unwell. So no, what the scenario says, she's sitting in the chair. Yeah. So first thing I'm going to do is I'm going to make this patient to lie down. Yeah. And it says that the hemoglobin has fallen from this, so she's in active hemorrhage as well. So I would just say, so let's do what we do first to help you to lie down on the bed. You might feel better when you're lying down. And then I'm just going to put some monitor to check your blood pressure and your heart rate again. So don't use the word pulse, heart rate, to check your heart rate. And then I'm going to put one cap on your finger as well to check the oxygen levels for you. And if they are coming down, I may give you some oxygen through the mask. Okay, is that okay? And you can just all simply say as well, like if you feel the patient appears to be scared or frightened, and then you say, don't be frightened and scared. It's quite usual doing this monitoring. Okay, that is just to keep an eye to make sure that you are well. So reassure her and then say, so what next thing then we would like to do, we'll see if your cannula is working already, the one you have for the patient time, then it's fine. Otherwise, we will put 2 cannulas in your hands and then start you on some fluids that will help you to pick up, your blood pressure, and that will, improve your the way you're feeling. You start feeling a lot better. And then at the same time, then we will take some blood. So you can just talk about those things first, yeah? So we'll take some blood as well to check your hemoglobin levels and also to check your clotting, of your blood. And then because you have a high fever going on as well, it looks like there probably some infection as well. So I will also send your blood test to check for culture and sensitivity. And then we will start you on some drip. And then, we'll start some antibiotics after discussion with the microbiologist interest. So this is the basic things you will do, yeah? And then you need to now start asking her the other things. So so I can see you had this, your womb taken out yesterday. So, I mean, it's still relevant to ask her, did anybody came to you and speak about the operation and stuff at this stage, yeah? I mean, in this emergency situation. So I will say, so you had the operation yesterday, and I can see your catheter has been removed as well. So have you been able to pass urine? And do you think you're passing appropriate amount of the urine? And if she says no or whatever, you can say, so what we need to do, because your blood pressure is low, I'm going to put that catheter again so we can, that will help you to empty your bladder. You won't need to go to the toilet repeatedly. And it will also help us to keep an eye on the amount of the urine you're passing on. Yeah, so tell about the immediate things which we need to do and explain as well why we need to do. So do these few things first, and then you will say, then you can start other things. And then you can say, so, tell her about the hematoma as well before you take any history, right? And then you can say, so, there is some swelling on your wound where we open up your tummy. So it looks like some collection of blood. So it appears that, you know, some blood vessel is still bleeding inside under the skin, and that's why this blood is got collected, and that's causing you that pain, and that also is the reason for your low blood pressure and, you know, your fast heart rate. So we will need to, you know, empty. We may need to take you back to theater and put you to, you know, and maybe we may need to put anesthesia as well, and then open your wound and then clear that any clots which are collected over there, and then see if there is any small tiny blood vessel bleeding, then we can, you know, control that and then stitch your wound back again. Yeah, but try to keep your tone of saying that as calm as I'm talking, because that can be quite otherwise quite scary for the patient when we tell them emergency, or our tone appears is something serious going on or something. They really get frightened. So, so these are the initial few things you need to say, and then you can get some information, yeah. And then you can say, okay, so just to help me to decide, you know what will be the better way to deal with you. Tell me, like, you know, if she says she has been able to pass urine, you can ask about was there any stinging and burning at time of passing urine. Yeah, we need to keep that high temperature in our mind as well. Yeah, I mean there is some infection going on as well. Are you having any cough? Are you feeling any difficulty in breathing? Any chest tightness? Are any, you know, swelling on your legs? Any pain in your legs you have noticed? And then say as well by saying like, okay, I will have actually look on your legs as well, because sometimes there can be some risk of blood clots in legs and lungs as well after the surgery. So I will make sure. However, I can see you have been put on blood thinning medication to prevent that clot being formed. So because you are bleeding at the moment, I may stop that blood thinning medication after discussion with the hematologist because it's making blood thinner, and that can be a reason of the bleeding as well. So we will stop there for the time being till we have controlled your bleeding, and then when it's safe, we will start you on that as well. Meanwhile, we will put you some tight stockings to prevent the risk of you know, any blood clot, and we will give you some fluids to avoid any dehydration as well. So you just take things as you're going along, yeah? And then you need to say, so I'm going to speak to my consultant and inform about this, and then I'm going to speak to the anesthetist as well, so he can come down. So instead of saying pain relief doctor, just say the word anesthetist, they understand. I'm going to speak to the anesthetist as well, and he will come down to see you in case if we need to take you to theater again to open up to drain that, you know, collection of blood from your wound. After that, we will, you know, monitor you more closely in our high dependency unit for more close observation, just to make sure the bleeding has stopped and you're recovering nicely from then. And once we are, you know, happy with the recovering, then we will bring back you to the ward. And then at this stage, you can take a little bit of more history if you like to. Ask history of blood clots in the family, any bleeding or clotting disorders she has been diagnosed. Otherwise, you don't need to go into the detailed history here in this particular woman, because she's everything is documented. You know, she has been told everything that's in the notes if she has anything, and she's so unwell. She's not really able to at this stage give you answers about her smears or about her any other conditions or any past surgeries. So we don't really need to ask that. Yeah. So the important main point is that you have taken your microbiologist on board. You talk about so I will pass the catheter. Whenever you say the catheter, just talk about the urine test at the same stage. I will check your urine for any infections, possible infections, because you're running high fever. And I will also send your urine for culture and sensitivity. And we have already said with the cannula, I usually keep in mind, you know, when you're doing the cannula, just again, imagine what basically we do when we're doing, yeah, when we put the cannula, what we do, we just take the bloods for those, whatever is required, yeah, full blood count, liver function, UNEs, and our clotting coagulation profile and culture and sensitivity. And then we attach the drip to that cannula, yeah, fluids, and then we give antibiotics through that cannula. In this woman, obviously, if her temperature is high, you need to send her lactate test as well. And then yes, that's all is about. And you can ask, like, you know, is there anything you would like to ask me before I go speak to the consultant, and then make arrangements to you know, drain your blood clots, and then we control your bleeding from the wound. And that's all. Yep. Any
Thank you, ma'am.
questions?
Thank you, ma'am.
You're welcome. Any quick question before I go to the next scenario? Okay, who is
Ma'am, I
next,
just want,
Pramila?
ma'am, I
Yeah,
have
yeah.
a question. Ma'am,
Yeah.
in these stations, do we at all have to speak about the incident report and things like that?
Oh, yes, yes. So the incidence report won't be, yeah, so there will be incidents, but not the way we are not going. So how you say, when we say, you know, so yes, so we need to explain by saying, so bleeding in the wound or inside bleeding is one of the known complications of this procedure. However, we will still, you know, report it as an incidence, and we will look into detail to see if there was anything different we could have done to prevent it from happening. So when we talk about the risk incidence, if there is a clear error already, say, for example, we cause injury to the bladder simply because we didn't catheterize the patient, or we perforated somebody's uterus and bowels because we used the trocar down to elevate the uterus instead of something else, then there is a clear error happened. We know that error has happened. In that case, we will say, clearly say, I apologize, you know, that this injury has happened because we did not, we failed to pass this catheter, we didn't. However, we take it serious. We're going to put as an incidence, and then we will do routine analysis, because we do have a procedure in place to make sure these things, you know, this doesn't happen. It still has happened, so we'll try to find out what went wrong, why we failed to put that, and then, you know, this injury happened. So we will be, you know, we will inform you as well about the findings, and obviously the lessons will be learned, and we will make sure and, you know, discuss and share the learning within the team to make sure it doesn't happen again with any other patient. So this is the way when clear, then you say what went wrong. But when there is some of the expected complications which can happen, then we don't need to say that what went wrong. Yeah, they may not have particularly anything went wrong from error point of view. You know, it's one of the known complications that some bleeder can be left, you know, some these type of things. So for that one, I will say we will see if there was anything different we could have done to, yeah. So maybe
So,
he
ma'am,
was
Ma'am, I have
in
a
this
question.
case, no point. Madam, in this
Ma'am,
case, no incidence report.
no, we are going to do incidence report. Incidence reporting is done not only when things went wrong. We do for anything which goes, you know, where the outcome is not the smooth outcome. So any bleeding, any post-op complications, any APH, PPH, preeclampsia, shoulder dystocia, they all, you know, diagnosed breach, everything you report the incidence. As a clear, I have told you the reasons why. Yeah, even if the things we may not have done anything wrong, they just give us an opportunity to see. Who knows, when we start this, actually look into the matter, we come to know that this woman actually was on, you know, anticoagulation for whatever XYZ reason, and that was not stopped before the operation, and that's why she's bleeding. Yeah. So that's why, for
ma'am,
that reason, just to make sure that we haven't missed or was there anything different, we always do the incidence reporting. So incidence reporting will be done in every post-op complication.
so ma'am, she's hello.
Yes, please.
Yeah, yes, ma'am. My query is that this is probably the scenario she's developed a rectus sheath hematoma. Am I right, ma'am?
I don't know. It's rectus sheath is subcutaneous at this stage, and that doesn't matter. That's not important at this arena stage.
So, ma'am, but
Don't worry about it.
no. My question is that this is. I mean, this is not an accepted complication, right? So, what
Sorry,
exactly? How would we put it across?
into incidence form? I haven't quite got your question, what you want, Reena. Please, can you repeat it?
Ma'am, I'm saying that when I'm explaining to her that we will look into
Yeah.
this matter, so what
Yeah.
exactly should be my language?
At this stage, all we have told, as I said, like all we will say to say there is some, you know, bleeding in your wound. So the word wound you need to use, because we know it's anterior abdominal wall hematoma, yeah? So there is some bleeding and collection of blood clots in your wound. So we need to take you to theater. So we may need to open up the wound and remove those clots, and then obviously, you know, stop that bleeding. we're going to, this is one of the complications, known complications which can happen in this surgery, that there can be some bleeding inside the wound or inside the tummy, but still we're going to put that as incidence form to look into detail to see if there was anything different we could have done to prevent it from happening. Okay, so that's all we need to tell to her. We don't need to, obviously, till we open up, we won't know where that is bleeding. And that from incidence point of view, you don't need to, the risk incidence form you report is, you again will say anterior abdominal wall hematoma. You don't need to go into the technical details where exactly it was and what was. You don't use any, pure clinical terminology there. Does that answer your question, Reena?
Yes, ma'am. Thank you, ma'am.
Okay.
So
You're
I
welcome.
have a one question. Can we not say it could be a collection of blood in your wound, or maybe collection of a person in your wound, because we don't know what is this swelling.
Okay. So, okay. So number one, it's only second post-op day. Yeah. So we wouldn't expect that purulent infection into that wound, which will give her, that swelling of 16 centimeter. Where is that scenario? Let me go to the scenario again.
Yeah, it is right because it is 16 centimeter. But differential
Yeah.
diagnosis we have to tell. Na?
Let me get there first to the scenario. Why we are saying they. Come on, where is that scenario gone? No. Okay. Right, so it says hematoma, number one, already there in the scenario. But the second thing is what makes me to think more about the collection of blood. And number one is just the second day. On the second day, you can't have that bigger abscess, just after, on the second day, within
Yeah,
few hours.
but she
Yeah?
has this temperature also 38.
Yes,
So we
yes.
can say this hematoma get infected or
Okay, let
something.
me get to the, okay,
Because
give me 1 second, just give me 1 second. Let me talk about why we feel at this stage. And then again, it's not like, okay, if it became like is hematoma and infected as well, that patient is going to sue us. It's like we need to, in simple words, explain her what's going on. So her blood pressure has fallen down. Yes, her temperature is 38 as well, so there is infection. Hemoglobin says it has fallen from 13 this morning to 10. So there is active bleeding. There is information here as well, right? Now, regarding this infection, that's why we did ask about the questions regarding any other additional. Hematoma can be infected as well. There could be UTI. We can't just simply say that temperature is because of that particular hematoma. It could be UTI. She might be having some chest infection as well at the same time. She might actually be starting some DVT in spite of low molecular weight heparin, VT prophylaxis. So you need to ask those few questions regarding to, so that's why we asked about any stinging, burning, and pain when you pass urine. The pain in lower abdomen, I haven't asked particularly. She won't be able to differentiate whether the pain is, she's going to say there is a pain, but she won't be able to differentiate whether the pain is with hematoma or because of UTI. And then we did ask, do you have any cough, any chest infection, or any sore throat you feel? Yeah. So then yes, 38. We are going to investigate. That's why we send the blood culture and sensitivity, urine culture and sensitivity. And if she give me history of cough, as well as say a sore throat and I'm feeling like, cough and all that stuff, then I would have requested for the chest x-ray. So to proceed for this management, we will do, sorry, so I missed one thing. We will do the scan of this hematoma before we take her in as well. Okay, so we will be doing bedside scan and then we take her to theater to remove their blood collection. Okay.
yes, okay.
Okay, so I just give you this little this to read.
Dr. Safia, just one more doubt. Can I ask?
Yeah. Yes, of
No,
course.
she was started on low molecular weight heparin
Yeah.
for DVT prophylaxis. So actually, it should be stopped, and it takes time for its action to stop as well. So this is an actual complication which shouldn't have occurred. Right? So the entire duty of control and instant reporting has to be done definitely. It's like that, no?
I have not heard you properly because there was some noise and your voice was interrupted quite a lot as well. So if you want to tell me again then. So she's on low molecular weight heparin. So what happens?
No, actually, if there was a bleeding vessel which was untied and low molecular weight heparin was also started, so there is a chance that it will keep on bleeding. So obviously, it is our mistake. So we need to do an instant reporting. In this case, right? It has to be done. It is our mistake.
Okay. So number one. She is on low molecular weight heparin. She will be, and that's why we asked, you know, in the history we asked, is there any history of blood clots in your legs and lungs? And then about whether she was any coagulation, she will tell us. But if she was not, everybody after the surgery will be put on VTE prophylaxis, yeah? So if there is some bleeder left, we didn't leave it intentionally, right? We didn't leave the bleeder intentionally, and then we would have think that we shouldn't start on low molecular weight heparin because we have left the bleeder. Right? So this is not a error. The bleeder being left, that went undiagnosed. That's why that bleeder is left over there. So we started as per protocol care of low molecular weight heparin. What important is now that we tell her that because you are bleeding, I'm going to stop this blood thinning medication after discussion with the hematologist because this thinning of blood can cause further bleeding. So that is important to stop. So why I don't want to say to her to go to say, well, that is our fault because we left the bleeder and then we started on low molecular weight heparin as well. This is not the case which has happened, isn't it? Yeah. So the bleeders can be left as the complications of the procedure. You guys need to understand the difference between negligence and between the expected complications or errors. Yeah. So negligence is clear negligence. Yes, somebody was already on low molecular weight heparin preoperatively, and we failed to stop it. Or somebody was on combined pill or something which increases the risk of VTE. We didn't stop, and now she developed VTE. Or we perforated the uterus with wrong instrument. Or we, so those are negligence. That one is you need to say, we will see what went wrong. Okay. So, and the incidence form is not again, it's not only for this woman will have the incidence form. Whenever any complication happen, even the blood loss more than 1,000 in a cesarean section, nothing may have gone wrong at all, but we still do the incidence form. So incidence form will be done in every case where some complication has happened or some error has happened or some negligence happened. Incidence form is also being done if somebody has fallen on the floor because they slipped, the floor was wet. We do incidence form for that as well. Incidence form is done when there is less staff on the labor ward or in the ward, say there should be like 6 or 8 midwives, and that night somebody called off sick and we end up having only maybe 4 midwives. That will also be reported as an incidence form. Okay, so when we will do the clinical governance, that will clear your concepts, what incidence form basically is. So incidence form is not only for the mistakes and error. So this woman will have the incidence form, we have no doubt about it. But that one is to see if there was anything different we could have done. I don't know what's going wrong with the slides, why they have started cutting. Okay, is that clear now? Just keep things simple, girls. Just keep them simple, okay? Don't get them complicated too much. Right, I have messed up something with these slides. Okay, just fix it. I'm gonna give me 1 second. Right. Okay. Can you all check your mics and put them off Somebody's mic is on and there's quite a lot of noise going on in there. Okay. Right, Pramila, who is next?
Prabha.
Dr. Safia, there is no screen.
Yes. Screen is not visible now.
Okay, let me share the screen. I was just fixing it up. Okay. Yeah. Are you able to see now?
Yes, ma'am.
Okay,
Yes.
Rabab, are you
Yes,
with us?
doctor.
Yeah.
Yes.
Okay, so sorry, let me just have some bit of disorder in my slides today. So that was that one we done. Okay, let's do this one. That's for you,
Okay.
Rabab.
Yeah.
Dr. Safia, there is a caller 2 opening his mic.
Okay, let me see whose mic is on. I can't see anybody's mic other than Rabab, but okay, caller 2. Who is this lovely person? Caller 2. Sama? Sama Ibrahim, it says. So can you please put your mic
No,
on?
yeah, I'm not the one. Caller 2 is the one opening. I don't know who's caller 2.
Yeah. Caller 2. Okay, so caller 2, whoever this person is, everybody, can you check your IDs, what you are? I'm going to exclude you from the course for the time being. So you come back after putting your mic off. That's your first 2 minutes. Rabab, you can start now.
Yes. Yeah. Hello, I'm Dr. Rabab. I'm one of the doctors on duty today.
Yeah, this is a structured discussion. So you can tell me what you will do. So you're performing this abdominal myomectomy, and then you realize there has been a bladder injury. And what will you do?
Okay. First, I will inform the anesthetist that I have a bladder injury because this might prolong the time of the operation. So the anesthetist has to make his arrangement for that. Then I will inform the staff nurse and the theater staff that I have such injury. Meanwhile, I will inform my consultant that I have this injury. Till he comes, I will assess if there is any other injuries out there. I will check. I will also ask the theater staff to reinsert the catheter, and I will inquire why it was not at the from the beginning. I will ask also for the urologist. I will inform the urologist on duty to come and assess for the bladder injury. Yeah.
Continue. Yeah. Continue what you will do. Yeah.
Yeah. Okay. So if he did not, meanwhile I will stabilize I will continue doing the myomectomy and make sure that the hemostasis is secured till I will have the help from the consultant and the urologist.
Okay.
Mhm.
Yeah.
Okay.
What else you would like to do?
Maybe I will ask for the staff already. They put they have supposed that they put the catheter and so okay, doctor.
Yeah. Is there something you want to say for this management, or is there anything further you want to add?
I will ask for. I can do the suturing. I can also start suturing. The bladder tear.
Okay, so how you
I can do it
identify the
with.
bladder injury and how you repair it?
Yeah, I can identify by like seeing the urine is coming from the bladder and the integrity of the bladder is not intact, and I can see also that but already the catheter was not there, so I will not be able to assess that. I can be only by direct visualization of the bladder itself through the direct inspection. We can go for suturing. We can see which part of the bladder is injured, like which part is the bladder is injured, like is it the trigone, is it the dome of the bladder, what is the size of the bladder injury, and how it is affecting the surgery. I can ask for
You can leave the bladder repair. Just continue with manager the rest of the
okay. So I will also I will okay. I will see if there is any bleeding. I can ask for cross-matching. Sorry, doctor, it is not in my mind now.
Okay, that's all right. Don't worry. So yeah, so about this, when some injury happen or some complication, intraoperative complication happen, how we go about it. So there are two aspects of that. One is related to identification of the injury, and then obviously immediate, correction or repair, and get the appropriate help. Like obviously when there are any intraoperative injury from exam point of view, because you are ST5 and a real floor as well, obviously you will call your consultant, and then you will also call the specialist of that specialty. So yes, you will call the urologist. You will also ask them to inform the consultant to come. So that's one aspect of about the, like how we're going to manage it and how that is going to be done. After that, it will be like, okay, so how after, how you're going to complete that procedure, then where this patient will be monitored. So depending upon, again, the injury, or then you need to, can you all hear me?
Yes.
Yeah.
Yes.
So you need to, monitor the woman where she will be monitored, and then you can, so you will explain that one. Then here comes the duty of candor, about telling that woman when she wakes up, explaining her about that injury and the complication which has happened, how we will have repaired, and also then being open and honest to accept that this happened because of this mistake that we failed to wash the catheter, and that's why this injury happened. To provide support to that woman, obviously there's going to be number one, traumatic from their point of view. Then obviously, she came for simple procedure or one procedure and ended up having this type of complication. And then there can be element of being anger element as well from the patient. So we need to then assess that if patient obviously feels angry about the procedure and she wants to make a complaint, then we need to, so the person who is I'm dismissing and the person who is logging in again and again, that's the person whose mic disturbs us. So whatever the ID you're coming with, caller 5 or whatever, can you please put your mic off? Yeah, because it says caller 3, caller 4, caller 5, and nobody's saying who that person is, and the mic then disturbs. So that's why I'm dismissing you. That's why you need to keep re-entering. So please put your mic off, whoever you are. Yeah, so then we'll be to continue with the patient to explain, take the responsibility if she wants to make a complaint, to facilitate her, to tell her, yes, we will facilitate you, give you all the information, how to make the complaint. Then obviously to reassure how that has been corrected, how we're going to take care of that, what follow-up she will need. That explanation of this is going to be quite upsetting for her, so we need to offer some counseling, make sure whether she would like to have that counseling done. Then we will tell that woman, yes, we're going to, report that as incidents to see, because we have a proper, this pathway where we must categorize the patient before we please put your mics off. Yeah, you're wasting time for a whole group, whoever you are.
Please, too much wasting of time, and integrity of this lecture is not maintained just because of caller 5.
Okay. So yeah, so you will then talk about the that person. You will tell about counseling, and then you're going to say we will complete the incidence form. You're going to tell the woman actually that we will going to do this, and then we're going to do detailed analysis to find out, because we have a pathway and we make sure that the patient has been catheterized before we do this procedure. So we're really going to look into that to see what went wrong, why we failed to do that, and then this injury happened. And then you will say, I will also make sure that I see this patient before she is discharged again, to give her an opportunity to talk, ask any question if she wants, and then explain her follow-up as well, what follow-up will be required. So there's a one side of that regarding the correction of repair and the patient dealt. Then the other side, the other limb of this scenario will be from our own within the team clinical risk, the clinical governance point of view. So what we need to do then after this surgery is within the team also we need to discuss and have a team brief to see why we failed to do that. Yeah, so non-blaming way again. So we are trying to just find out like what went wrong, why we failed basically to do that, and then we need to identify, was it like some new assistant who came to assist, and that's why dinner. And it's not unusual that at the last minute your assistance is changed. So you come up in the duty and that ST2 or ST3 who was supposed to assist with you, that person has called off sick or for some reason that person hasn't come, who according to rota was supposed to come in. And then some other ST2 or ST3 who actually was supposed to go into the OPD with her consultant, that person is asked to come and assist you. And that person has arrived actually, right, you have already in there, or that person hasn't realized because you are scrubbed up, everybody else is scrubbed up, and she also thinks she needs to scrub up and then to start. And she didn't realize that she needs to actually do, because she was not again organized and prepared for this one. So in this way, these type of errors can happen, you know. So for that reason, we also need to then understand what happened, yeah, why the, and when we were checking then our list, why we didn't check up at that stage, how we missed the catheter, why we ticked or did we not take, why we didn't check, has patient been catheterized. So that's one thing. And then the second thing is that we also need to make sure the person or the assistant who was supposed to catheterize the patient, we provide support to that person as well. It can be quite, scary experience and traumatic experience for that person as well, thinking made that mistake and now I'm going to be in trouble. And obviously then also having the burden of that guilt that because of me and my mistake, this person has suffered so much. So it can be quite, stressful, you all know, being clinicians. So we need to also then make sure that we provide support to that, our assistant. Then I need to take responsibility as a surgeon as well. Why I actually did not check, why I did not speak to my assistant, why I not double check with assistant, see that she know about the, about this procedure. Has she done this before? If it was some new person, or why I didn't check, it was my responsibility being a surgeon as well. So that's we will be doing. Then we need to, check with that assistant if the other person who is, if the person is really stressed and feeling not able to, and that person is shaken up enough and feeling not able to continue with the rest of the work. Like we need to basically do the assessment to if she's safe to continue with the work. If not, then we need to speak to the consultant and send this person to home. And then obviously, tell the person to take some time off, and then tomorrow or whatever. Then we need to fix another meeting with that person as well, with your assistant in a couple of days time, where you both can actually sit and reflect on that. Yeah, why that happened and what were the circumstances. So circumstances maybe just like as I've explained, she was pulled off from the OPD last minute. She came in and she thought, everybody was scrubbed up, the nurse was ready with the trolley and everything, and she assumed the patient has been catheterized or whatever. She's called just to assist, so she came and just stood on the other side to assist, whatever. Yeah, so we can all then see retrospectively what went wrong, and then we can correct it. We both need to, myself as justified as a surgeon, and she also, we need to reflect on that. So reflection mean that we do that analysis. Yeah, what went wrong, what could have been done differently, and what we learn in future, how we going to prevent it and apply in our practice to make sure that this never happen in our practice again. So this is called reflection. We need to do that reflection, and then I will encourage the assistant to discuss that with her supervisor clinical supervisor, and I will also discuss with my clinical supervisor, and we both will make it a part of our appraisal meeting. Okay. So to start with, if I just quickly go over, the immediate thing will be yes. So as soon as I recognize or I suspect there is an injury, I will inform the anesthetist that I'm suspecting the bladder injury has happened. So obviously he can then manage and plan his anesthesia accordingly. You will let the scrub nurse know that you're suspecting this injury, so she can get the appropriate instruments ready if we require. And then you will ask the somebody to call your consultant. Meanwhile, obviously, you will ask some of the nurses, one of the nurses, to catheterize the patient. And then the other thing you need to do is you need to secure the hemostasis and then wait. So all we need to do at this stage is secure the hemostasis. We will not continue with the procedure basically because we can cause more injury or something. But obviously, we need to make sure we score the hemostasis. And if securing hemostasis means that we are at a stage where we must complete this myomectomy now and take it out, then obviously we will do that. So the better word is to say to secure the hemostasis and to see if it's safe to wait till the urologist arrives and repair the bladder or the consultant arrives. So that was clinical one. The rest I have told you already. So after at the end of this procedure, you follow that patient limb. Then patient will be transferred in high dependency units. You will go tell, explain, follow up, blah blah blah, and then come to your own side. The team debrief and your assistant meeting, and then refer the notes. Okay.
Ma'am, can I ask
Yeah.
a few doubts?
Yeah.
Actually, suppose the patient is under spinal anesthesia and she is conscious. Should we inform the patient that this might take a longer time and that such an injury has occurred at that time?
So if the patient is already under spinal or something, she's conscious and awake, we inform them, yes. She will be informed then and there that we are suspecting this injury has happened. So we may need to do this and this. So, as soon that's why we say when the patient is awake. So if she's already awake, then during that procedure, we will be telling. And we tell them, we inform them that this is, we are suspecting this to happen. However, don't worry, we will be able to correct it. And then, yeah, if the patient is awake, then yes, you will tell then and there.
And for all injuries, do we have to call the urologist, or if our consultant is okay with, suppose it is dome and all, is it okay with the consultant, or do you usually call for all injuries urologist?
No, you will never repair the bowel or bladder or ureter or anything yourself. Because it come under to provide the high quality of care to the patient, and high quality means that the repair must be done by the most competent person in that. So although from theoretical point of view, we all read and learn that, like how to identify these injuries and what methods are used, but you don't repair it yourself. That needs to be done by the urologist. So they will come and repair it.
And after the procedure, routinely, do they put the methylene blue or something to check for leak?
Yes.
And do we have to put an abdominal drain also?
But that depends again. If the putting the drain is quite, not encouraged now. So unless the repair was difficult and we still have a bit of suspicious, a bit of oozing going on or anything like that, then we can put the drain. Otherwise, no, not routinely, no.
Okay, ma'am.
Minimum tubes, yeah, because that increases the recovery time for the patient, yeah. Increases the risk of any deep wound infection, discomfort that will make patient won't be that quickly and easily mobilized, that will increase the risk of VTE. So unless there is some hemorrhage or something, I mean, if we have a suspicion that this bladder is not repaired still properly, we shouldn't be closing. And that's why we are calling the urologist, yeah. That's we're not doing ourselves. So the other reason where we need to put the, maybe like, okay, we are just, doing, and there was some bleeder, we're correcting, but there is a little bit of oozing still going on, like, where you clearly can't actually identify anything, a little bit, where you think, oh, I'm not really sure, and that's that. Then really, if you think, then you might leave the drain. Otherwise, drains are no more a kind of, encouraged to be put in, because of enhanced recovery, the enhanced recovery incentive as well. Okay.
مصطفى انت عارف الصالون ده ما كانش فيه مخده في مكانها ونايم كده اقول له اسكت يا مصطفى بسمع معلش لا حاجات ده بص سيبني دلوقتي طيب روح سيبني انا بسمع الكورس.
Ma'am, can't you mute her?
Well, I can't even find here who is there. Then for some reason, go through it again. Then I'm trying to mute. For some reason, it's not doing. And ma'am, can you mute color 5? I mean, how? This is unfair. When I'm telling as well clearly, the person who is needing to, rejoin the meeting repeatedly, why that person is not listening to me to put the. Can you guys look and see whose is on? Can you identify from the thing? This
yes,
person
it's
could
caller
be
5,
possibly.
Dr. Safiya. It's caller 5.
What should we do with this caller 5, honestly? Caller 5.
Sajila, one name is there. I don't know.
It looks
Sajila.
like, I think, is that Anila?
Dr. Safiya, you have
No,
the option to mute.
no, doctors. It is Arabic speaking lady. I think one of her kids opening another mobile, so
Yeah.
anybody to check their kids.
So it's shortlisted now. So can Halar be speaker? Candidates, please check. Or maybe that person actually is on duty and the family is, recording or doing something. I don't know. And the kids are preparing beforehand as well for her mom. I'm sorry, girls. I understand. Obviously, it's quite challenging and difficult with you guys doing duties and doing all that stuff. But just try to make it. Okay.
Ma'am, we should give here antibiotics and catheter and love, all this story also we have to tell. Bladder injury.
So this is the main first thing you must say, the contents I have discussed. After that, if there is a time, then the examiner, if they want you to, they will ask like, okay, tell me what is the technique of bladder repair. Although it will be done by them, tell me what the technique is, what is being used, and how this should be followed up. So they might ask you, and if they ask you, you can tell. Otherwise, you don't need to go. There won't be the time to go into that detail because there's a lot of, this is more again about a pathway and the process rather than actual repair and management of the bladder injury. Okay, this is about the process, like what immediately you should do, tell your team, inform, open, let the patient know, and all those stuff, risk incidents, how you will be dealing within the team, and so this is more safety related and clinical governance related scenario. But if the examiner would like you to talk about that as well, they will ask you the direct question and then you can answer. Otherwise, don't worry about the technical management of this repair.
What should we answer, ma'am, in case if in structured discussion if they ask, like just in 2 layers, like that simple, or we have to narrate?
No, you just need to tell whatever the way is, 2 layers, and then how long the catheter should stay, and what will be the follow-up. When she's discharged, you need to make sure you are in the follow-up with the gynae for her myomectomy point of view, and you make sure she is seen by the urologist in the post-op recovery time as well, and then she has the appointment with the urologist after whatever the time is. So you need to arrange the follow-up as well. Then you will explain that. So all of you can just read and revise bladder repair today, please. You need to just have an idea about that because in structured discussion, if the examiner want to, they can ask you that question, but you won't be otherwise repairing it yourself. And I don't expect basically they will take you to the technical side. There won't be time basically left. Okay.
Dr. Safia, in the structured
Yeah.
discussions, when I appeared in the exam, there was like 4 questions already written on the, paper, or one of my friends said she appeared before me and she said that this is only one question was there. And I was a bit confused that where to stop. Shall I give her
Okay.
give the time to ask?
So can you tell me what 4 questions were there when you did the exam? So if you can tell, we can build up on that.
This is enhanced recovery, program. Regarding that, there was 4 questions, so they were written on the paper. So I was just looking at the question and I was answering.
Okay.
But
okay.
in case before me was maternal collapse, they said how you will manage, and she said he was quiet, and I have to start from A to Z.
Yeah.
So how to know that?
Okay. Yes, I got your question, Sajila. Yeah, that's fine. Thank you. So in the management of emergencies, as I discussed in some session before as well, or maybe in pre-session, the management of emergency needs to be very robust. There is a clear protocol. Now you need to understand there's a difference between protocol and guideline. Guideline is the college recommends you, and that's the evidence-based practice, and we usually follow that, all of us. But sometimes if we feel particularly to the circumstance of that particular patient, we need to deviate a little bit from the guideline, we can, because that just is a guidance. Protocol means you must adhere to all those steps the way they have said. So you will see from the guidelines as well, nice, when it says the protocol they have given, they're very clear points, steps, this, and this. So when it's an emergency situation, your cardiac arrest, shoulder dystocia management, preeclampsia, you just simply need to start and keep going with. You don't need to wait for the examiner. And maternal collapse and cardiac, these they are just, nobody will interrupt you in between anyway. You just need to literally tell, reflexly, in a kind of a mechanical way, I will approach, I will make it safe, I will do this, I will do this, I will do this. So you need to keep going in that order. The structured discussion, when it comes to any other structured discussion stations, then it very much depends upon, you should be able to know your whatever, the total management plan of that is, and you continue unless the examiner interrupt you. So either there will be 3-4 questions they might be given on your scenario already, so you can start from those questions and answer them. If there are no questions given, you summarize your scenario and then start. Okay, so the examiners are different. Some just sits quietly, they just keep sitting, okay, and keep staring at you. Just complete. That means you are supposed to complete whatever you will do. What is your management plan? Okay, so it's not a discussion. All right, it's not a discussion with the colleague. It just is that person want to see how you're going to manage it. Then just continue as we did this scenario. I will do this, do this, do this, and then after we will do this. If the examiner want to ask something, they will interrupt you. Okay, if they feel you're not going there where what we want to, mostly they will interrupt you and ask you, okay, can you tell me about this? Okay, so if there is some mark about the repair of the bladder, that examiner will ask you how you repair that. Okay, that's fine, the urologist will do, but what technique is used, how that is done. So they will ask you question. If you feel you have done everything, so you don't stop, complete up to till end as we have just done that. So when you re-listen, just see, we concluded that at the end what we need to do. And after that, if there is any time, you can actually ask the examiner at that stage. So I feel I have given my management plan, but I will be happy to answer if there is any specific questions you would like to ask me, please. Okay. So at that stage, then examiner is not going to withhold. We can't just sit thinking, well, no, I'm not going to tell you. You guys, but you should speak. So they will tell. Okay, unless there is nothing, and you right from the beginning go very blunt and lost somewhere, and the examiner feels like you have no clue what you're talking about. Obviously, they're not going to. Unless then again, it's fine. Just take it like a colleague, and just ask. You can ask, are there any questions I need to follow and answer? You would like to ask many questions, or you would just like me to give my plan and then just start and keep talking? Right. Let's go to the next one now. No, let's do this. Cheryl husband. Okay, how many have we done, girls? Have we done 5 yet or not?
Yes, 5.
We have done 5?
Yes.
Hooray, that's a break time now. So we're gonna have half an hour break to eat and drink, your toilet runs or whatever, and then we come back. Right, okay. We are back. So again, somebody, can you guys confirm me? You can hear me.
Yes, ma'am.
Okay. So some people on the list I can see from our previous batches, but it's been ages. I haven't heard from you guys anything. So can you please at least, send me a message on WhatsApp to let me know what your plans are, what you're doing, what you want to do. Yeah. Okay. Shaima. Oh, Hira, are you here? Can I hear your sound? Can you say yes? Hello? Mubashra?
Yes, Dr. Sabia. Assalamu alaikum.
Walaikum assalam. You doing well?
Yes, Dr. Sabia, I'm doing well, and I'm really preparing for the November attempt.
Okay, good, good, good. So yeah, so all of you, please get in touch with me on WhatsApp, please, because we need to refresh you as well to see what else you need to, and what deficiency, anything, any sport. Okay, so please feel free to let me know, particularly the people who seriously are planning for November exam. All right, I'm not ignoring
Thank you.
you. I'm thinking about you guys as well. Right. So I was just thinking about a few other things as well to cope with the stress, anxiety, and all that stuff. Obviously, it's quite difficult. It's quite challenging how to deal with the nerves on the day of examination. It's natural to be anxious, have a lot of anxiety. Some of us are good. I mean, everybody will have anxiety. It doesn't matter how strong nerves you have, and you will be a bit anxious as well. But some of us obviously are naturally gifted. We can channel and manage our anxiety in a slightly better than others. And some of us really struggle. They might have a very good knowledge, they're pretty good, but when it comes to that focus on the day to perform, they find it difficult to deal with their nerves. So any one of you guys who feel really, you feel you get really pounding anxiety on that day, and these type of exams and those and palpitations and all that stuff, it may be worth for you guys to think about and maybe start taking some anxiolytic, maybe mild dose of propranolol, but start it like about 4 to 6 weeks ahead of exam. So it just helps you to calm down on the day. Don't just start anything just on the night or a day before. Start like 4 weeks or 6 weeks ahead of that. So these type of things, try to make sure, again, we have been through that as well. I know most of you obviously are right, somewhere in the middle of career, you got young children as well to look after, and then obviously tough duties, but still try to make some time to literally go out in the fresh air, to have a little walk, whether it is like even 10 minutes. These measures, they sound like just like as to the patients we tell, these general lifestyle changes are important. The way the patients feel, we're just saying they don't really work kind of thing. We don't feel they're important. We also feel, as when I'm telling you that they probably not, but believe me, they do. They increase your efficiency, your memory and everything. So please start making that habit as well. Make sure you eat and drink enough as well. So I basically, what I have done throughout my life, and I strongly do believe that probably has, that's the reason of my confidence and everything I feel and find very easy to communicate with the people and talk as well. There is a prayer in our Quran given. It was like just a small little I want to tell you. So when the Moses were asked by God to go and whatever spread the message, there was like it was Pharaoh's time. Obviously there was very strict, strong king, so Moses felt very nervous, and he felt, because Moses has a tongue tie, so he had a slurred speech. So he felt very nervous how he's going to actually go and speak to such a strong king and tell something different from which he's telling already, to do something different to people. So he asked to God to say, he prayed in a way to say, so in Arabic, the people who understand Arabic, you will know what I'm referring to is Rabbi Shrali Sadri wa Yassir li Amri wa Hlul Uqdatan min Lisani wa Yafqahu Qawli. So for others in English, if I translate, that was kind of, oh God, give strength to my heart, remove my anxieties and nervousness, make my task easier for me, and also make my communication effective enough to leave impact on others. It's just my habit right from my school days, for my exams routinely. I just, I pray that way. And I personally believe that has really helped me. And this helps me to really stay calm in exams and everywhere. So I can suggest you guys as well. I mean, you don't need to say that in Arabic. You can just write down whatever in simple words, whatever you believe in. Just keep praying that as well. These things do help. They are kind of meditation as well. They really help with your confidence and everything. So try to adopt these few things as well. Right. Okay, so let's do something different now then. Yeah, we were going to do the angry husband. And it's really difficult. It's very challenging actually to deal with it angry, whether they're angry patients or they're angry husbands or relatives. They are no breaking really in the real world as well. But that make it easier if we know how we need to approach them. Okay, so who was the next one then?
Myself, ma'am. Pramila.
There you go then. Is it your scenario, Pramila?
Ma'am, did we do the similar scenario in infertility? That UAE and hysterectomy?
Yeah, I think we did in. No, not in. Have we done this? We did in pre-session.
I feel like we have
Yeah,
seen the
we will
situation.
do-
What do others think?
Yeah,
we did that in pre-session. I
we had
remember
done
now. So we moved to some other one. Yeah, we did that in pre-session. Okay.
Okay. Is this the one, ma'am?
This is for you now.
Okay.
Okay, that's your first 2 minutes, Pramila.
Good morning. I'm Dr. Pramila, the doctor on duty. May I know your name, please?
Yes, doctor. I'm Mr. Jason. I'm Tracy Jason's father.
Yes, Mr. Jason. I can see that you are really anxious and waiting for us. Uh, but before I explain anything about Tracy's condition, may I know what you know about Tracy's condition so far?
Yeah, so I had a call this morning from Tracy to say she was in the hospital to have some, some operation done. And so, and then she couldn't quite tell me the detail. The line was disconnected.
Yeah. So I can see that it's really an anxious situation for you, seeing our own daughter
Yeah,
in the hospital.
that's right.
Yeah,
Yeah, and then I got this call to come. I need to come to the hospital. There is some emergency with the Tracy, so I'm absolutely,
yes.
kind of devastated because I have no idea what's gone wrong with my child. So
I'll explain to
could you
you
please tell me
what it
how is
is.
Tracy?
Yeah.
What happened to her? Yeah.
Actually, when she came today morning, she was bleeding heavily. That's why we had to do an emergency surgery for her. But be reassured, she's okay now. She's in safe hands now, and she is recovering. But before that, I would like to give you some other news because why she was bleeding heavily. Also, you have to know.
Yes, that's what I'm really worried. Like, what went wrong with her? Why?
Yeah.
Why was she bleeding?
Actually, Tracy had come to us 2 days ago. She was actually pregnant and she wanted to have
Oh.
termination of pregnancy.
Oh, my poor child.
Yeah, I know it's quite
She never
shocking to
told
hear.
me. She never told me that she was pregnant or that she was even in a relationship or she was sexually active. I mean, she's just a little child.
Yes, I can
So why you
understand your
guys not,
concern.
contacted us, the parents at that stage? Like, was her mom with her at that stage?
No, actually, Tracy had come alone. And according to our policies, actually, any girl who is more than 13 years of age, if she comes and requests termination of pregnancy, we always first see whether she is competent enough to understand what we are saying. And once we find that she is competent enough, it is our duty to provide her with this medications for termination of pregnancy. We always see that what we tell her, she can understand, she can retain the information, she can make a choice regarding her condition. But along with that, we always encourage them to inform their parents also. So multiple times we had actually encouraged Tracy, but she was very adamant that she's not
How
going
can
to
you, I
inform.
mean, how, if she's only 15 years old, doctor, how can she understand what is good for her or not? Before she take, and then, I don't know what you guys have done with her, and now she's, fighting for her life. How can you not actually contact us, the parents,
Because
and you took her to the operations and surgeries?
See, Mr. Jason, it's that for any girl who is, as I said, above the age of 13, there is a confidentiality issue which we have to maintain. So when such girls come to us for termination of pregnancy, we always make sure that they are competent enough to understand the situation. We tell them what are the complications they have to anticipate, what we are going to do, and only when we make sure they are competent enough, we give them the treatment. But at the same time, we always encourage them to tell the parents. But if they are not willing to tell the parents, then we cannot inform the parents without their confidentiality, unless there is some safeguarding issues involved. So we always, in these girls, we do the safeguarding assessment to see whether there is any safeguarding issue associated. In such a situation, we will actually inform the parents even if it is against her consent, and also the social service. But other than that, it's not in our hands to inform.
I understand what you're saying, but then at the same time, I mean, she's just such a child. She might have been a bit scared to tell us, but you guys could, even if she was saying, no, I don't want to, you could inform us. We are the parents at the end of the day. We would have wanted the best for her.
Yes, I understand that you would have wanted best for her, and that's why we always encourage them to tell the parents. But according to the confidentiality issues, our hands are bound, And not only that, if we had just refused her to give this treatment, she might have gone to somewhere else where it is not safe enough, and her life might have been endangered. So that's why we had to give this treatment. And when we gave the treatment, we had specifically told her that there will be some amount of bleeding, and we had also instructed her to immediately report to us if there is any excessive bleeding. That's why she actually came here. And when she came here, she was in quite a lot of bleeding. And at that time, I think she changed her mind and asked us to inform you. So once we got her consent to inform you, we informed you that this is the situation. Otherwise, also, since now, if it was a life-threatening situation, we would have definitely informed you. So
Okay, well, I'm not quite convinced from this, but anyway, it's okay. So can you please tell me how is she, and can I go and see her?
Actually, she is still in the theater, and what we did was we had to remove the remaining contents inside the uterus to stop the bleeding happening. And while we were doing that, this pregnant uterus is very soft. So at that time, there was a small injury to her womb, and our consultant has been involved, and they have made sure they have repaired it properly. Now she's okay, she's recovering, and once she's shifted out of the theater, and once she is okay, regains her consciousness, I'll take her to you. We will sit with her, we will talk with her, and later on, once she recovers, we will slowly break the news to her of what had to be done. I know this is a really stressful situation for you.
It is absolutely devastating situation that we didn't know that our child was going through all this, and we were not there to support her when she needed us the most. This is awful. I don't know. I
Even
don't
she
know how
will
I'm
now
going to deal with this.
realize that she should have informed you at that time. Even she will realize it now. And if you want some more support from your family, I can call them, bring them, and ask them to come here. And as she is recovering, we will also tell her, and we will give some counseling for her, because she will be really worried and frightful now. So we'll give her counseling, and we have to also take care of her future contraceptive practices also, so that she doesn't land up in an unwanted pregnancy. Not only that, when you have got unprotected sex, there is a chance of sexually transmitted infections happening also. So those things we will counsel her, we will give her apt advice, we will give her before we discharge her. And we will be doing an internal analysis for this. We will be trying to find out if anything could have been done differently in this situation. And we will update you regarding what our findings are and what conclusion we have reached. How do you feel, Jason?
Okay. Yeah. Yeah.
Do you have any further queries to ask me?
Can't make any sense, but
I know you
can't think
have
straight at the
taken
moment, doctor,
anything.
anything, but
Yeah.
I know
I
you
know.
are talking about whatever you guys felt was right to do, but I'm still, I'm really angry
Yeah, I can
about this
understand.
whole situation, and I'm going to put the complaint. I'm going to sue this trust. I just don't agree with making some child only 15 years old to go through this all without the support of her parents.
I know, I can understand your concern, but this is the laws and that we have to follow. So, so I will, as I said, I will let you know what our internal analysis report comes out like. But still, if you want to go ahead with the complaint, I can facilitate with that. There is something called as PALS. I can make you contact with them. You can give the complaint, and we will definitely look into that. I know you would have been really worried and wouldn't have taken anything till now. So just relax a little bit. At present, she's okay. If you want something to drink or have something to eat, I can arrange for that. In the meanwhile, if you want to contact somebody in the family, that's also okay. And I will later on make sure my consultant also meets with you and talk with you. Is that okay?
Yeah, that's fine. Thank you, doctor.
Thank you. Thank you for the time.
Good. Very well done, Pramina. Very well done. So I don't feel there is really anything I need to go over. You did perfectly replicated the station which we have done in the recording already. So Yeah, it's absolutely lovely. You did include everything. You did acknowledge that I'm sorry that you're worried. The only thing I will say, I obviously I can understand when we think there is so much we need to tell and talk in this station, we can be a little rushing through the conversation. So hopefully in the exam, obviously you will be seeing the person as well. I mean, I don't mind to come on the camera from next session. If that can be helpful, the person who is presenting that can come on the camera as well. I think we should do that. That will also help you
Yes,
to
ma'am,
see
that
the
would be
expressions.
helpful
Yeah,
actually.
yeah,
Because
yeah, yeah,
otherwise both of us start talking
yeah,
together.
yeah. That's right. So we'll do that from next session. So yeah, I need to just put a little bit of makeup on before I come on camera. So we'll do that from next session. All right. Okay. So yeah, so it was fine. The only thing is, obviously, in between, you need to just make your tone go a little bit more empathetic as well. Your words were fine. You were listening, but you were listening as well. And obviously, because I was not in front of you, probably you didn't anticipate. Give a little bit time and just say acknowledge in a bit calmer tone to say, I can see you're very much worried, and it's natural. However, so you did answer the worries anyway when he said like, how could you do that? How can she understand? You can say, we always make that sure by doing this. That's we call it giving competency, that the child is able to understand the information given, and then he can analyze the risks or the benefits and disadvantages or any risks of the procedure. And if they can, then make the decision, then we have to go ahead. Yes, we do encourage them strongly. We did encourage Tracy strongly to inform the parent, but she was very adamant that she doesn't want to do at that stage. And that's why we, could not contact you. Because if we would have done so, we could lose Tracy's trust, and then she may not have come back to us for her termination, and she might have ended up of going and trying to get this procedure done somewhere, or try to adopt a practice which is not safe, which could be life-threatening for her. So for that reason, we have to keep that balance, maintain that balance. However, we do that assessment to make sure if there is any, we are concerned about any safety of the child, then we do obviously inform the parents or whoever we need to, even if the child doesn't give the consent. But it was absolutely fine. The rest of all was okay. Everything was fine. You did establish what you know about her, and then so in the beginning, right? I wouldn't straight away say that I have to give the news. I would give a little time to say he's upset, and he said he was bleeding. Let him start first to say. So can you tell me what happened? Why she was bleeding? And then wait, because the word I have to give you news is taken as a positive word here. So I would expect that you're gonna say to me that you have become a granddad now. You have been a grandfather. That's the news. Just the word news means some good thing coming up, or we say bad news. But I wouldn't say anything in that way. All I will say, okay, so you have been coming. So can you tell me what Tracy told me to you about this? And then it was right to say she had some problem. She had a bleeding after some procedure, and for that reason we needed to take her to. And then you can start and say yes, she was pregnant. When he asked like why was the bleeding, she was pregnant. She had the termination done. That was fine. It was all fine. Just good. So who is next, Pramila?
Anilasri.
Right, Anila, are you ready? So any particular scenarios you guys have in your mind? Could anybody find out that scenario of sepsis, something wrong within the investigations we discussed last time that appeared in one of exam in India? No?
Hello, Dr. Satya. Assalamu alaikum.
Yeah.
I just want to ask a question. Yeah, Dr.
Yes,
Satya,
please.
I want to ask a question. Is it a matter of confidentiality? First, we ask the father, how do you know, and what do you know about your daughter? And I will tell you later on when she will recover and she will tell you herself. Is it
No.
correct, or we have to give the information regarding?
Yeah, so usually that's how we start. Like, okay, so can you tell me what Tracy, told you this morning? And then yes, she hasn't. He didn't know that she was pregnant and all that going on. But in the scenario, I don't want to go back to that slide. I will then miss this slide. In the scenario, it was written that the Tracy has decided this morning that she will tell everything to her father, and she made a call, but she couldn't complete the call. So that mean, in other words, Tracy was prepared basically to tell the father. So that mean we can give that information to the father now, and that's why I wouldn't hold that information now by saying, well, no, we can't tell what went wrong with her or what she had. Because now she's in a life-threatening situation, and then if you don't want to tell him why we have called him, yeah. So that's rather a very negative point that we called him, and no, we don't want to tell what went wrong. All we're trying is your daughter's life was in danger, but she's not anymore. Okay, so you can see how devastating situation that can be, and that actually will put us in a lot of trouble. So because we have called her, you can start simply though, and she said she started the call, but then the call was disconnected. So that mean it says that Tracy made that mind that she want to tell everything to father. So we will take that as a consent from Tracy. Yeah. Okay. Okay. So this is for you, Anila.
Thank you, doctor. Thank you.
You're welcome. Hello, Anila. Are you still there?
Yes, ma'am.
Okay. This is for you. So I start your 2 minutes.
No, it's a structured discussion, ma'am.
It is, yeah. That's your first 2 minutes.
I'm Dr. Anila, one of the candidates for the examination, and I've gone through the and ready for the discussion. Summarize it. Mrs. Clara Binns is immediate post-op patient who's been operated 6 hours back, and seeing the scenario of increasing pulse rate, tachycardia, and hypotension. And the patient looks pale. My first diagnosis would go for internal hemorrhage. So I would always call for help from my team, whoever is available on ward, to immediately make her put the head down, that is the legs little elevated, and start the fluids. If she's already on fluids, to start one more line And when they are starting the second line, I would ask them to take the investigations for to check for the hemoglobin and mainly coagulation profile, and also sample for the blood uh, for the cross match. I would ask them to connect the monitors for if they are not connected, to connect for the recording the pulse and BP. And also I would immediately, as my consultant is there, we can arrange for one bedside scan if possible, and inform the theater, and also arrange somebody to regarding inform the blood bank also to see to make arrangements for the blood, and start off IV fluids, mainly the crystalloids, till the blood has been arrived. Then
Okay, I will just add a little information here, Anila. Sorry. So she had 30 meals in the first 6 hours, we can say, and then now she has no urine output in last 1 hour.
Okay. Then second thing I would think of when there is no urine output, other thing is any ureter was being ligated or cauterized. One thing which I can, one thing is I will send, apart from this, I would like to send even the creatine and urea levels. And if needed, if I think fluid, when I see on the scan that there is an hemoperitoneum or some fluid is there, one thing I can arrange for an intravenous cystogram or a urogram. If we are suspecting the ureter injury, that I would go through the notes if I have not attended the case to look if any additions are there, any difficulty in removing this one, and also look for I mean, inform the consultant, whoever have done the case.
Okay. Anything
Any
else you want to?
investigation reports here?
Investigation and creatine levels are quite high. Her hemoglobin has come back 6.
Ma'am, I
And
could not hear you.
her coagulation as well. Yeah. Okay, so
Can you
her
repeat
urea
the
and creatinine are raised. Yeah,
Okay.
her urea and creatinine are raised. Hemoglobin 6. And yeah, there's these two.
So I should suspect somewhere an injury which is close to the ureter. Even the vessels must have been, the blood vessels must be injured, or and also the ureter would have been damaged. So
I've
I need
lost your sound. Yeah.
I would like to shift her to the OT and plan for a laparotomy.
Okay. So this is the examiner, Anila. This examiner doesn't want to talk at all. So you need to continue whatever you think you need to tell, and if you're done.
Okay, once as my consultant is with me, I would like to go for a laparotomy. Look for any blood vessels have been bleeding to immediately ligate it, and if the urine was induced, to inform the urologist. And also, meanwhile, if the as the hemoglobin is low, I would like to start off blood as soon as it has arrived, with the help of the who will be looking with the help of the anesthetist. We will be seeing that vitals have been stabilized first, And then generally we would like to go for a general anesthesia in these patients. And once if we think the bleeding has been reduced, I mean been ligated, and there is no further bleeding detected inside, then I would, if the ureter is injured, I would hand over to the urologist to complete it. If needed, stenting may be done and the ureter will be repaired by the urologist. Once the procedure is over, I would document this all in this one and debrief this uh, to the team who is there. And once the patient has been shifted to the, we'll shift the patient to the HDU and debrief the things that has been happened since morning to the HDU team there, and would like them to start off on to maintain her vitals continuously, her input output, IV fluids, a good pain relief, give a good analgesic, and also start off on thromboprophylaxis after 6 hours. Has she been reoperated? And also I would debrief this to the patient and the family members once the patient is out of anesthesia and she is conscious and coherent. Afterwards, I would document this. I would fill an incident form to the and inform the patient that this will be looked after, where the problem has gone wrong and what can be done best next time so that this incident doesn't repeat again for the next patient. We would also discuss this in the meeting next time, in the audit meeting, if it is a repeated case. And I will give, risk management will be planned, and I would arrange a debrief the patient about how the follow-up is going to be, how many days she's going to be in the hospital, and what next can be done for her will be discussed with her, and also writing a letter back to the GP one at the time of discharge so that she'll be under follow-up.
Okay.
Okay.
Yeah. You still have 1 minute if you think anything. Okay. So we close it here. And thank you very much for doing this session. Yes, your approach was right. To do how you will deal this patient. It looks like she has some internal hemorrhage going on from her tachycardia, hypertension, and also abdomen being hot, and tender on examination with complaint of shoulder pain. So this lady, but there are a few things I think in the beginning is important to know. So yes, you will say it's an emergency. So you will initiate the protocol, obviously, of an emergency. It looks like you can say from the vitals and from the examination findings, given that she has some internal hemorrhage. So you will initiate the protocol of hemorrhage management. Yeah. So you will call for your consultant, anesthetist, and the nurse and other help available. Yeah. So then you will ask somebody to contact the blood bank to arrange the cross match the blood, and start releases negative blood till then. And start the fluid. So the approach will be same to go approach the patient first of all to check whether she's anxious or not by calling her name, and then it will be same like you will immediately monitor the pulse oximetry. There will be blood pressure and pulse and their continuous monitoring. If oxygen levels are low, she will be started on oxygen and then 2 wide bore cannulas. And to start and take the bloods, obviously, again for full blood count, UNEs, LFTs, and coagulation. And then you can just start her some fluids for the management. And then the next step comes out is, the examination of her abdomen. So you can say, like I was saying, the patient tender heart with the shoulder chip pain that reflects some blood collection or some fluid collection inside the abdomen. So this woman will need to be taken to theater immediately. By now then, but you need to have some more information in your hand, yeah? So you need to you will say, I would like to get some information as well. I will ask somebody to review the notes to give the information about any complications during the surgery. Did she had any hemorrhage and bleeding during the surgery? What was the blood loss? And if she had a blood loss, if she had a bleeding during that time, how that was managed. Has she been given Transfusion already? What fluids she has been given? Because there are two things going on. One is, yes, she has internal hemorrhage. The other is we don't have the urine output past 1 hour. Now, you could think of injury to the ureter, but unilateral ureteric injury can't basically can cause complete anuria. Yeah, so she did have some urine output to start with, and now she's in complaint. So there can be two reasons for that. The one is, unless you had some bladder injury where actually all the urine is leaking inside, but that won't make the patient to be hypertensive, but she could be. The other reason, if the serum creatinine and that is that looks like she has gone to acute kidney injury, so it's AKI, yeah, with complete anuria.
Yeah.
So so you need to ask about that as well. Heart fluids were replaced, so it may be she bled during that time as well, and her fluid and everything hasn't been not replaced to the level, yeah, where it should have been. And then if our urine output has been so low for last 6 hours, what was done? Because according to our Meals chart, we should have alerted and done something already, and she might have had something done already as well. That is important piece of information we need to know. And then obviously about the woman's VTE prophylaxis, what VTE prophylaxis she is, and any other risk factors of VTE or any bleeding or clotting disorders she might have. Yeah, so you need to again, as I like, repeat all those blood tests, exclude. Now what can be, so what happens basically is, well, she still has an ongoing PPH, but in the exam, I think in this exam they had put a scenario where she had a PPH, and it was similar type of thing. She has maybe 10 mils per hour for first 3-4 hours, and then she had nothing for 2 hours. So this is the management of the patient after the management of PPH or hemorrhage, surgical hemorrhage. How we monitor afterwards. It's very important to replace the correct amount of fluids and replace the blood, and then monitor to think about the complications which could happen after that. Yeah, so somebody who have a great hemorrhage, basically they can have the risk of acute kidney injury. They can have a risk of pulmonary edema. They can be a risk of DIC. So this is about basically monitoring those and the correction of those. But anyway, in my scenario, she's still hemorrhaging as well. So so it will be that emergency protocol you need to initiate. Then you will say, after collecting all that information, and then you will debrief the patient to say, that we suspect there is some bleeding going on inside, so we may need to take her to back to theater to open and see from where she's bleeding, and then stop the bleeding. So, but there are a couple of things you will do before you take her to theater. Yeah. So the first thing you need to do is to do a bedside ultrasound scan to find out what's going on, and then depending on, after discussion, you can say with the consultant, you may have, you may do CT scan as well. That can help you if from an urea point of view you want to think about any bladder injury or anything like what's wrong. And this our collection in the body could be blood plus urine as well. So I will say we may need to do that as well, depending upon that consultation. Just mention. Otherwise, it looks more like internal hemorrhage. So yes, so you say, so there will be immediate, and then you need to know the amount of fluids we need to replace. How you start with the crystalloids, and then you start with the after fluid expansion. You need to go on to O negative blood till the proper cross-matched blood is available. You need to obviously take the hematology and the blood bank on board as well. Those fluids, and you should know the amount of those bloods, how they are replaced after home, because in structured discussion, obviously it can goes into detail. How much blood, after how many bags of blood you will give FFPs or platelets, what should be the fibrinogen levels, minimal fibrinogen levels, how will you correct that? So all of you, if you could just a PPH guideline, nice guideline, they have given very nicely that one table of that fluid management and the management of these. So just bring that one for you guys to have an idea about that, how that will be replaced. So yes, so you need to then mention about that you will, check account once you have these results back, then you need to then talk about the possibility of acute kidney injury. That is more likely, because if there is only bladder injury or ureteric injury or whatever, that won't cause these creatinine and all that to go very high. So we need to send basically for this woman, not only the creatinine in urine, we need to have EGFR for this woman, we need to have albumin creatinine ratio, we need to have a protein creatinine ratio as well. That will help us to then stage the kidney disease. But with anuria and raised creatinine, she looks like acute kidney injury stage. We need to establish from EGFR what stage she is so that we can manage her. So then after, the consultation and discussion with your consultant, if he will decide to do, so you need to say with the consultant, if the consultant will, it won't be you as a ST5 unless they say consultant. Yeah, it says consultant actually. Yeah, so in that case, obviously that will be you. So after the correction of that, then you will need to say that this patient will need to be transferred to not only a high dependency unit, I think she needs to go into ICU. And she will be monitored on the meals, and you will need to very closely observe for the acute kidney injury to replace. And once you have raised the bloods and everything, then you need to keep eye on the electrolytes as well. And if our urine output, she start having some urine output, then it's fine. And if there is a requirement, obviously, you might need to do some, you might need to start on some temporary dialysis as well. So that's about that management. Then you need to also mention about, once the bleeding has been controlled, and then you will closely follow for the results of your coagulation profile, because this patient will be at a high risk of going into DIC. So there will be close monitoring of that to replace the, the products accordingly to prevent that from happening. This woman you will be keeping on meals chart, street intake, output record, and then obviously you will be keeping an eye on the pulmonary edema. And also on cerebral edema. Yeah, so she needs to be really in ICU. So you will need to take the consultant ICU on board as well. All right. And so obviously then she will have correction of hemorrhage. The other thing, VTE prophylaxis, you would then need to assess that as well. So you will discuss with your hematologist to how that should be, started, after when that will be started. So for the time being, obviously the most important thing, you need to say she's at high risk of having, VTE as well, because of all that going on. If she's so much dehydrated or she's going into acute kidney injury and immobilization, so we need to keep close eye on that as well. So she will have the TET stocking at this stage, and then we will start prophylaxis when it's safe to start off the discussion with the hematologist. And then yes, just as a routine thing, when she obviously recovers, she will require a debriefing of that. It can be quite upsetting and traumatic for her and for the family, so debrief of the family as well. Risk incidence, yes, to complete, to see again, yes, do the detailed analysis to see was there anything different could have been done differently to prevent from this happening. And then after deep analysis, after the detailed analysis, to learn the lesson, to share that learning within the team, must say that as well, to prevent any this type of complications. However, we can still say this is one of the the known complications which can happen after that difficult surgeries. Particularly if she has a large side dermoids is taken out. Yeah, so debrief of the patient, debrief of the team, your risk incidence form, and then provide counseling, arrange counseling, because it can be, this is going to prolong her hospital stay. Just assess if she's very much stressed from this, then arrange the counseling for her as well. And then make sure that I see her just before the discharge as well. So by that time, if she has any questions, she can ask me and I can explain her everything, and then I will arrange her, I will make sure before the discharge, the appropriate follow-up is arranged in the gynae clinic after 6 weeks, or depending upon how the things go. And then also, because of our AKI, you will also make sure that she's been reviewed by the urologist in the ICU as well, and they have a clear follow-up point plan for her as well. So you will make sure that appropriate follow-up has been arranged and the appointment in the urology clinic has been arranged as well for her. Okay, any questions?
Ma'am, in
Any
such
questions?
situation, ma'am, in such
Please.
situations, there will be question, answer. Like examiner will ask question and we have to answer. Next, we have to tell. Or we have to tell the whole scenario.
Okay, so again, that's an emergency situation. I will start talking. You start talking. If the examiner want to stop you and ask some other question, they will ask, and they may not. Okay, so you know what to do. You have been asked how you will manage this patient. Manage me.
Yeah, so no need to wait for the next patients. We can just continue our tap. No problem, na?
After care, about any specific, or we want to take the scenario somewhere else after starting, then you start and you say, yes, there is some internal hemorrhage, and as soon as you say, okay, well, it looks like she is in acute kidney injury, and if no, I have the marks actually going towards, okay, how you identify acute kidney injury, what investigations we should do, what follow up, and then I might give further questions. Okay, if that happened, and then what else are the complications you need to manage at home? Then that's a different thing. Then the examiner will come forward. They're not going to hold the questions. If there is anything they need to ask, who has the marks? Okay, but I will suggest just talk. But obviously, you talk. There should be conversation, not just like a non-stop, kind of thing. So just continue. In structured discussions, continue. Unless the examiner, but obviously in the beginning when I said I would like to have, after doing the initial stabilization of the patient, oxygen monitoring, fluids and all that stuff, when I said I would like to get more information about the what was the complication and the surgery procedure details, then you can ask, do I have the details of these? If they give you the details, that's fine. If they say no, you don't have any details for that, then it's okay, you continue with that. The rest of the plan. Okay, any other question?
Thank you.
Who is next?
Shazia.
Yes, Dr. Savia, this is me.
Shazia. Okay, Shazia, this is for you then. So your first 2 minutes start.
Yes, Dr. Sophia, can we start?
You can start. You can
Okay,
start,
I'm
Shazia.
Dr. Shazia. Yes, I'm Dr. Shazia. Now I'm going to review the gynae list that will be going to be done tomorrow. My first patient was 21-year-old, planned for diagnostic laparoscopy. Her BMI is 18, and there is written that what we will do if there is fine adhesions intraoperatively. So in this patient, I will first just check the consent, whether everything was there, and then regarding her BMI, I will explain the patient that her BMI is 18 and there is might increase chances that laparoscopically she might have risk to the injury to the major vessels. And but we have the experts available, but if we may need to go entry by the open technique. And regarding the adhesions, I will ask also that whether she has any sexually transmitted diseases before if she is treated completely. And I will ask also the consent was taken about if we find the adhesions, we will go the adheolysis, and I will check also for her urine for pregnancy test, and I will ask for her last menstrual period also. Okay, for the next patient, this is 52 years, para 4, planned for laparoscopic right ovarian cystectomy. Her BMI is 38 and the cyst was huge with 10 centimeters solid cystic. For this patient, this is postmenopausal. This is
I can't hear you, Shazia. Hello?
None of us can hear.
Hello? I can't hear you, Shazia.
तुम लोग सब इंटर
Can you guys?
क्लास हो रही है.
Yeah?
Yes, Dr. Safia. I don't know from where you did
Can
not
you
listen
guys
to
hear
me.
me?
Yes, Dr. Safia, I listened to you.
So you were just starting your second case, yeah? You were just starting your second case. We can tell if you can tell
Okay.
us about the second case again.
Regarding the second case, she is postmenopausal. She is postmenopausal. Her
No, we can't hear you,
BMI
Shazia. Connection is quite poor. Hello. Do you want to leave and join the session again, Shazia? That might improve. Hello. Can you guys hear me? Is it my connection or Shazia's?
Yes, ma'am, we can hear you.
Okay, so can next person take this till Shazia can get until she gets sorted her connection and stuff, and she can take the next one. Ramina,
Selena.
who was next to Shazia?
Selena.
Selena is not in. Selena not in, so go to the next person.
Sadia.
Sadia, this is for you. Hello, Sadia. Are you there? Is Sadia in the session? I haven't seen her name, so I think she's not.
Next is
either.
Reena. Reena.
Okay.
Hello.
Okay. Next person, please take
Yeah.
it.
Yeah, I can do.
Okay, Rina.
Yeah.
You want to take
Uh,
2 minutes? Are you okay
yes,
because you have
I want
you've
to
been
take 2
treating this
minutes.
anyway?
Yeah, I want to
Okay.
take 2 minutes.
All right.
This
Okay.
patient has a 4 cases.
Yeah, that's fine.
Hello,
Yes, hello.
Dr. Safia, I finished.
Hello. Can I start?
Hello. Yeah. Yes.
Yeah.
Shazia, we
Hello.
are not able to listen to you, so that's why we're taking it to Rina, so you can do the next one now. Yes, Rina.
Hello. I am Dr. Reena Kumari, MRCG Part 3 candidate. In first scenario, my pre-op management will be this is the patient, 21 year, planned for laparoscopy for the chronic pelvic pain, and her BMI is 18, so she is at a risk of the she's at a due to low BMI. She has a risk. She is a risk of the injury. To minimize the risk of injury, I would like to ask some question from the patient and review her the notes. So in question, I will review she has any risk of the endometriosis, like she has any chronic, as per her notes, she has a chronic pelvic pain. So I will check her LMP to exclude her pregnancy, and I will ask about the risk of the PID by taking history, like any history of a STI, or and I will check her the allergies and any medical comorbidities, because it help in the recovery any previous surgery. And I will ask about her blood group, and I will check that she was informed about the surgery and informed consent was taken, and as well as I will check her the consent is ready, and what she knows about the patient, what she knows about the surgery, and any concern about the surgery, and anesthesia fitness was done or not.
Okay, continue.
Okay, and I will check her the investigation. Any recent investigation is done, what is her the blood group, and any FPC is done, and is she's the young risk of the pregnancy. So I will check her the urine pregnancy test before the surgery. And I will ask about the concern, explain that she is a chronic pelvic pain. So she might have a endometriosis, and if she is agree, so we can, this is the diagnostic procedure, and if she go for the surgery, and if we found any endometriosis like ovarian cyst or any adhesions, so can we remove it? And I will explain that this is a diagnostic procedure, and maybe we not found any cause of the endometriosis. Regarding the second case, she is a 52-year-old, para 4, planned for the laparoscopic right cystectomy. What will you find cyst and BMI? So this is also high risk patient, and she has a large cyst, and she has a large cyst, and her BMI is high, Also, it is a difficult procedure. I will she is at a risk of and solid and cystic component. So I will ask. She has a risk of the malignancy. So I will take a history recording the patient, recording the symptom that she has any uh, any she has any pain, any bloating, and any history of a weight loss, and she's any problem like she's a if she's a menopause or not, because it's not mentioned in her notes. And she has any previous surgery, because if she has a previous surgery and her high BMI, so laparoscopy could be a risky. And she have any health issue because she's a 54-year, and any diabetes, hypertension, if she's on any medication, like she's maybe menopause or in the HRT, if she's a HRT, or any hormonal component, so she stopped before the surgery. And if she stopped when she was stopped, at least should be stopped 4 weeks before the surgery. And she has enough support at home, is she's smoking, and when was her LMP, and if menopause, so she's updated with the smear or not. So I will review her the notes, and CA125 is done or not. So we need to do this risk malignancy index before the surgery to see how much risk of the malignancy in this case. If it is a very high,
Okay,
like
sorry. Okay, so how you calculate the risk of malignancy index?
risk of malignancy by the checking her the menopausal status. I will ask the LMP, LMP, if and by the ultrasound and CA125.
Okay, so she is, she's menopausal and her CA125 is 150.
So
So what will
she's
be
a high
the
risk. Yeah, it will be more than 250. So I need to
okay,
inform the.
tell me what that will be. Do that calculation and tell me what that will be.
Sorry.
Do that calculation and then tell me exactly what's the risk.
Will take the pen.
Mm-hmm.
So it will be more than 250. 150 into
Okay,
2.
so now tell me what criteria you use. So she's
So I will.
postmenopausal.
She's a postmenopausal, and she's a high risk
Yeah.
of malignancy. So I will involve the
Just
oncology.
stay there. Just stay there. We are doing the calculation of risk of malignancy index. Okay. So tell me. Okay. So for postmenopausal, what number will you give?
2 or
Okay.
3. I will give menopause,
No,
premenopause. So it is
no, is
0.
no. Tell
1. Menopause is, I think, 3. So
she is menopausal, so we don't need to talk about premenopausal here. Yeah. So okay, for
yeah,
menopausal, it's 3. Okay.
3.
And then
Menopause
do
is a
what?
3.
Yeah.
Sorry,
And then
menopause
what
and
you do?
ultrasound. If 2 features, so we will give the 3.
Okay.
She
3
has
for
a
that.
large
Okay.
cyst. It is a, yeah. So she has a large cyst, 10. So and cystic component. So I think it will be 3.
Okay. That will be 3. Then 150 is this 1 to 5.
So it is a very high, 350 into 3. So it is a.
What are, yeah, what are we
It
doing?
will
Are
be
we
more
adding
than
them?
1,000. More than 1,000.
What are we doing with them? Are we adding them, subtracting them?
We will multiply,
These numbers? Okay,
and it
let's
will
say
be
that,
more
yeah.
than 1,000.
Yeah. Okay. So I want you to do that because in the exam they do ask. In last exam, the examiner did ask the
Okay.
candidates to do that. So
Yeah.
sometimes it's very basic knowledge. I know you all know it, but sometimes what happens, it's not in our nose and we don't know what to do it. But see, so be very clear in your again conversation and communication Just simply say
Yes.
she's postmenopausal, so there will be the status will be 3. It's a complex cyst, and these like solid cystic and septas. Okay, 3 for that, and then 150. So we will multiply them all together. 3 into 3 into 150. Yeah. So 3 into 3
Yeah.
is 9, and you multiply 150 with the 9, and that just will bring your that will make it 900. Okay, so be able to
Yeah.
9 into
So
okay 50.
yeah, it will be more than
You can do that.
1050.
Okay,
So
okay.
I will
We'll do
involve
that way. Yeah.
before the surgery. I will involve the MGT oncology team. So discuss about their surgery, and it should be done by the oncologist and not laparoscopy, and by the staging laparotomy.
Okay, your time is over, so I will stop you here now. Right. So yeah, so you're gonna do that in time. So what happens basically in these operative list management? People do get confused. They start talking actually about the whole management of that patient. Yeah, you need to remember this is the patient who has been seen in the OPD already a few times. Whatever would have been given, she would have given all the information already. History taking has been happened already. Whatever the investigations were required, they have been done already. All those procedures you need to keep in mind. And then the consultant on that month, the procedure has been explained, and now they are for the list tomorrow. It all has been done already. So
But
don't
like
wait
in
in
this
history,
case,
this and this and this history.
725
So
are not done, so we have to
this
pick
is,
the
yeah,
we had to pick the
sorry,
missing
can say again?
investigation. We need to pick missing
Yeah,
investigation as well.
let me tell you, let me explain now how you can proceed this. Yes, they can be information gathering, but what you needs to understand here is that you're sitting literally in your consultant or supervisor office. Yeah, so you both are going to do this list tomorrow, and your consultant just want to, or even if you are consultant, you all do the surgeries and lists, so you all know. We like to see our list day before, yeah, and either we go and see our patients as well, otherwise at least we see the list, what procedures we got, we review the notes of the patients. And the reason for doing that is because we want to kind of become a bit more focused, think a bit more, before we get into the situation to say what the risk effect of this woman, what difficulties I might come across with the surgery. If I do, how I'm going to, deal with them. Is this patient at high risk of hemorrhage or something? Do I need to speak to the interventional radiologist to be there as well? Do we need to have the, the blood available for that woman already? So that's the purpose of this, yeah? So what this one is actually to assess what complications or difficulties in surgery can be, to make our ahead plan for how we will be mitigating them, and what I should expect. Okay, so the way to do is you can divide, you can talk on 3 different ways. Okay, there can be 3 bullet points you can talk when you're talking about the list procedure. Number 1, you need to talk about the route of the procedure. Okay, so think about, okay, the route of procedure, say is laparoscopy for this first lady. Okay, so just focus is a route at the moment. What possible complications or problems I may have to do the laparoscopy in this particular woman? Yeah. Okay. So yes, the problems can be that she is BMI is very low. She's 18, but it's not really that low. It's okay to do with a Ovaries needle, but obviously yes, you can say BM being low, obviously there is a high risk of injury to the blood vessels and bladder and bubble, so it needs to be a very careful Ovaries needle entry, and then the proper pneumoperitoneum, and then ARP, the open technique can be considered as well. Then the other thing, what we can, you still think about the complication or problem can come in diagnostic laparoscopy, any type of additions if we come across, right? They can be another further risk for the procedure, injuries and all that stuff, okay? So for that one, you can say, so to summarize, you will say she's for the diagnostic for pelvic pain and primary infertility. Okay, so if somebody has a chronic pelvic pain and primary infertility, obviously our differential is already this. There may be some additions in there, yeah, and that's why she's getting pregnant. And the possible reasons of the additions can be We know it can be either, the endometriosis, or unless she has some previous surgeries, or she has any sexually transmitted infections in the past. Okay, so that is something you will say. So the second, obviously, the risk I suspect with the laparoscopy procedure for the procedure is the possibility of any additions in the pelvis. So I would like to review the notes to see, and then you clearly say what, does she have any previous surgeries in the pelvis? Is there any history of endometriosis? And if there any history of previous sexually transmitted infections, right? So you will be careful about that as well. So that's what you need to think about and keep in mind. And then what else you need to think about is regarding the procedure itself. Okay, so one was route, second is the procedure itself. And no, the procedure is, yes, we're going to do the diagnosis, and then we're going to check the tubes and stuff. So you will say, okay, so we have to do obviously the tubal patency, so that test as well. And then obviously you need to think about, okay, in that procedure, what possibility I can come across. As I said, like we can come across the adhesions. Okay, so adhesions can be then, if we come across, then adhesions can be obviously two type of adhesions. One can be, we do have the degree of those, fine, moderate, thick adhesions. So then you need to, consider that one. So you can say, okay, so the possibility if we come across the endometriotic or those adhesions is, then obviously that is something I need to make sure whether we have discussed with the patient already that, what we are and how we are going to proceed if I these adhesions, right? And then you can say, and then you are given one particular situation there already. So then you need to talk about the management of that. So, okay, so I feel that, and that's why that possibility is given, that this is one of the possible findings you can find. So you need to be prepared ahead of time. So you will say, so I will then make sure that we have explained or taken the consent from the patient that if we find fine adhesions, obviously the idealizes, those adhesions can improve her chances of infertility. However, they're not going to make any change her pelvic pain. So you will take the consent whether she would like us actually to go ahead with the adhesiolysis. Okay, and that's fine. I'm not going to worry about the moderate, thick, and those adhesions because that's not the question here. Okay, so just talk about that. So that's about your procedure. And when we're doing the procedure, you think about, then you need to think about what are additional comorbidities this woman has, or what other risk could be, right? So the additional comorbidities, obviously, we have already talked about her BMI. Her BMI is low. Other possibility could be, obviously, we need to exclude any risk of pregnancy. So we need to make sure, you need to say, I need to obviously exclude the risk of pregnancy. Is she on any contraception already? Is there any risk like any unprotected sex if she's not any contraception? Is there any risk of any latent pregnancy? So you will obviously make sure that their pregnancy test is done tomorrow morning before the procedure as well. Okay, or any other health conditions. The three categories: the risk are the complications you can suspect about the procedure itself, the what you can suspect from the procedure, the route of procedure, about the procedure, and also any comorbidities. Okay, so that was the first lady. The second lady now, 52 years old, she's part of four planned for laparoscopic right ovarian cystectomy. What will you do if you find cystic solid cyst of 10 centimeter and BMI is 38? So again, just see, okay, so she's postmenopausal. You can start from the background risk first. So the background risk is she's a high BMI. Okay, and the other one I will think if she's postmenopausal, why we are doing only the cystectomy, right ovarian cystectomy? Why we are not doing actually bilateral oophorectomy? That is something that should come into our mind. For postmenopausal woman, what we want to do by keeping her ovaries behind. Okay, so that is something I will just pick up from
I
the
have
list and I
one
will say,
question
so
here.
she's being postmenopausal.
Dr. Safia, I have a one question
Sorry?
here because menopausal status is not mentioned. Only the 52 is written. So how we will know she's a menopause or
Even then, even then, if she's not menopausal at the age of 52, basically, even when we are going for abdominal hysterectomy for the women, about from 46 or 47 years beyond, we encourage them to have oophorectomy done. Okay, so
Yes,
still, even if she's not menopausal, still I will be thinking about why we are doing only right cystectomy and I both of, but that might well be that she might already have the other the ovary taken out, or she might already have actually abdominal hysterectomy done with other tube or whatever. So, but I need to. That is something I need to think about instead of why she has been brought for here. Okay, so and then the other thing I need to do here particularly is I need to look on the ultrasound scan to see the features of the cyst. where is the result of CA125? What was the risk? And what is the plan? Has the MDT discussion taken place? Because I can't just assume that somebody has been silly enough just to put for right ovarian cystectomy. There might be reason behind it. Okay, so I need to basically know that. Has this case been discussed in the MDT? What is, so I need to have the detail of the her ultrasound scan report. I need to have the CA125. I will review. So you will say I will review those, right? And any suspicion of malignancy. And then again, because our and the second obviously is BMI, just any the comorbidities you can again talk about. So being laparoscopic route for BMI 38, obviously is high risk again for the risk of injury. In this one, particularly best option will be to go by open entry. The risks again are same as will be with any ovarian, any laparoscopy, risk of injury to bladder bowel. Now, this woman will be at a slightly increased risk of, we may need to turn it to laparotomy. Always think about any other alternative procedure we might
Dr.
end up.
Satya,
So then you
Dr.
think,
Satya,
yeah,
here we will not ask
yeah.
about the symptom of symptom of malignancy like weight loss, bloating, and this.
Okay, all you need to say, I will review the notes for any
Okay.
symptoms or suspicions of malignancy. We're not going to ask the woman because this is not what you're doing at the moment. You're not
Yeah.
asked to assess the woman. You're just discussing possible, so you got the notes with you. You can review and just find out what day. That's what you do. Just think what you do when you review your list for next day. Yeah, this is what you always do. Don't you go and look for the results and these are the scans. Yeah, so just keep it natural like that. So you would like to have on the scan report BA1 to C125, and then what was the collective and how that been, but you will be aware. So if you then come across, and that's very common sometimes, yes, the scan says as a simple cyst, but when we open up, we need to understand the pelvic scan, the ultrasound scan has a very limited sensitivity. So it's not unusual. The sonographers are reported as a simple cyst, and when we actually are doing, we find no, actually there are some solid areas. Yeah, but if we haven't considered it beforehand, then we're not able to do anything different other than what consent we have taken. Yeah. So for that one, then anyway, they have given you the possible option there, and when you open and you find it's a cystic solid cyst of 10 centimeter. So for that reason, we always, discuss with the patients anyway. When we're doing that, if there is any suspicion that it looks suspicious or anything like that, we might do this. But in this moment, obviously, we're going to do the cystectomy or oophorectomy anyway. So that will be taken, but then you will need to be careful, make sure that the tissue which you're removing, that has been removed completely and carefully, and there is no spillage in the peritoneum if you come across to that situation of solid cyst.
Dr.
Yeah.
Satya, here like you
And
give
then
me 125, 125 or 150. So the risk malignancy index came 1050, and she's for the laparoscopy. So we can say she need the staging
no.
laparotomy.
Okay, no, let's not confuse it with this. I just gave you for examination point of view that if you're asked for the calculation, how you will do that. I'm not saying this woman has the CA125. Yeah. So you need to say this woman definitely would have the low risk of malignancy. That's why she has been put on right just for the cystectomy.
But
Yeah.
we will ask about the
So
investigation. When we go for the investigation, I will review her notes, and her blood investigation is
yes,
done. Hemoglobin is the complete blood count is
yes,
done.
that's what I'm saying,
The
darling. That's what I'm saying. That you will say I will review the notes for the details of the ultrasound scan report, characteristics of the cyst. I will also find out and review the result of CA125 and also review the notes. Was there any sign and symptom suspicion of malignancy? I would like to look into the notes. What was the plan? Has this been discussed in MDT? Right. So we have done that. Yeah. Just focus to
Okay.
listen it. You can write on your questions and you can ask me at the end. Okay. So yeah. So these are the possible complications you can come across. You just need to think about tomorrow what it could be. And any other comorbidities. Yeah. So BMI we know is 38. So this woman will be at a high risk of VTE. So what we need to do is, if obviously, and the other possible thing can happen, we may not be able to remove this cyst laparoscopically, then we need to convert it to laparotomy. Has the consent been taken for laparotomy? So we need to make sure that has been done. And then being her BMI 38, if any injury happen and the duration of the surgery prolongs, then I need to have the background, the facilities are available to provide VTE prophylaxis during the surgery by providing pneumatic pressure. And then also to put her on appropriate. So you need to basically tell what I know or suspect, and I will be prepared for that. And this woman we will need to do the VTE risk assessment and then put her on appropriate prophylaxis after the surgery. You don't need to worry about at this stage to say that appropriate prophylaxis, what that will be. Will that be stockings or will that be low molecular weight heparin or what? That again depend. Have we been able to just, she had only one ovary maybe, and then we remove it, oophorectomy and cystectomy, went everything straightforward. We may not need, if there is no additional risk factor for VTE, we may not need to put her. We can just give stocking maybe the time she's in there. We send home to say, stay active, mobile, and drink a lot of water, and that's fine. So do not again worry what prophylaxis we will go. All we need to know that you are aware this woman is at high risk of VTE in case the surgery prolongs or the stay in the hospital prolongs. All you need to say is she's at risk. If that happens, so I will put on appropriate prophylaxis afterwards as well, after the assessment of risk. So that's about her. Evacuation of molar pregnancy, this size of uterus, a heavy bleeding during evacuation. So when they have already your question, your consultant is asking you, the supervisor, what will you do to manage this? Then answer only please that particular situation. Don't go about other things, right? The first one, the consultant say, okay, if you find mild adhesions, what will you do? Don't talk about the management of thick adhesions and the moderate adhesions, what we will do. Here it says, tell me about the bleeding. What will you do? You just need to tell about, oh, if we come across the bleeding, this is what we will do. Don't then start, if there is a high risk of perforation as well, there is a high risk of this one, and I will do this. To the answer. Okay, to the point answer. But overall, again, see what can be the risk of the procedure. So suction evacuation, at that stage, generalized risk, you can talk now. You will say because it's a molar and obviously the uterus is more fragile and soft. So there can be a risk of, injury to the cervix, bleeding, infection, perforation. We need to check, she has a, group and SAVE done. And does she have any problems with the blood transfusion? If you have to do this, she's not Jehovah's Witness, and has she been consulted about their risk? And then you will inform them. Then you will make sure that it's done when the consultant is also present or done by the consultant. She's rhesus negative, so we will give her anti-D afterwards as well, and then answer this particular question: what happens if the blood start bleeding heavily? Yeah, so you tell about your syntocinon, and then also tell about you would like to give after the completion, but if she's heavily bleeding, then obviously you will give it even before that is completed. That's all. Fourth one, 33, plan for myomectomy due to menorrhagia fibrosis at 12 centimeter, quite large side, right? Past surgery of umbilical hernia repair. So here again, you can just quickly see, okay, so what are the background risks she has? So background risk is her BMI is not given here. So I need to know the BMI. What is the root of the procedure, which I have written here. So let's do laparoscopic. So if it is laparoscopy, then again, you need to think about, so you need to know BMI. If the BMI is not given, you will say I will review the notes and I'll find out what the BMI is, because obviously the BMI has the impact on the root of the procedure. So if she's high BMI, just add what I have said in the previous scenario about the high BMI. So you can just say, so it can be, potentially it is obviously a difficult surgery. It's a large size fibroid. Then again, what you suspect can happen, what are the background comorbidities here? Think about, if she's menorrhagia myomectomy, what is her hemoglobin? So in this particular case, yes, you need to know hemoglobin. Has she had again a group and SAVE? Has the blood transfusion been discussed with her? Other possibility, just like what you are discussing with them in the consent, other possibility is if we couldn't do the myomectomy laparoscopically, we may have to do then laparotomy. So has we discussed and taken the consent? This is the time you check now that has that been discussed and make the consent. And then have we discussed, like the other complication obviously is with the myomectomy large size fibroid. If she goes in hemorrhage and we're not able to control it, we might end up doing hysterectomy. So has we discussed that and has that consent been taken? Now, third one is past procedure of umbilical hernia. Now, if we are doing the laparoscopic, all we need to do is just discuss with the woman what extent of hernia she had, when that was, and then obviously on the blind entry, if you're doing laparoscopically, there can be a risk of recurrence, so we can consider open entry, and then we do proper suturing of the rectus sheath and everything according to the colloid. But we need to discuss with her if we are doing, just laparoscopy, there can be a very small risk of recurrence of the defect. Okay, that's it. Simple. So divide into three. Problems are any complications with the root of the procedure, complications you can suspect about the procedure itself, and third one is what additional or other comorbidities she had. Simple. That's all required. You don't need to worry about asking, I need to ask this history and I need to ask this city, and you don't need to go for the simple basic things either. For every patient to say, I need to do the full blood count, I need to have this, I need to check she's seen by anesthetist and anesthesia. No, it's not. That is done. That one is just your some planning of your list for tomorrow. Okay, and it says as well, like you're required to discuss the risk in each case, what measures you will take to minimize these risks, and then show the order of the list. Okay, so order of the list depends very much on the consultant's individual choice. There is no right and wrong for that, as long as you can tell why you want to do that way. Some people would like to do actually their major surgeries to start with. But usually on average, what I have done and what I see my most of the colleagues as well, and I think probably you all do that, we actually like to do the simple and the short procedures in the beginning for a couple of reasons. The one is you will do those because then you don't unnecessarily have to make those patients to keep waiting longer and stay nil by mouth. And then with that, that list is ticked off as well. The procedure which we think can take longer, or there can be a risk of complications, obviously in that particular procedure, it's going to take longer time, so we usually put them at the end. Okay, so usually what happens is, mostly I have just seen almost standardized all over. The evacuations, if there are any evacuation, they're usually done the first on the list. After that, usually diagnostic laparoscopies. After that, any therapeutic laparoscopy, and after that, major procedure. And this is very standard list because it's only one session list. So they usually are 3 to 4 cases. Okay, so one evacuation, one diagnostic laparoscopic, therapeutic, and one major surgery. This is very typical standard list. No, you can ask me questions, yes, please. And the
Hello,
rest
Dr.
must be
Satya.
asked in the group, not here. Yes. Yeah.
Hello, Dr. Satya. What I understand, I have a confusion in the case 2B, who is 52 years old and play for laparoscopic right ovarian cystectomy. It means this question, what will you do if you find a cystic solid cyst of 10 centimeter? Means this question is, for my understanding, means this question is asked by the exam, means her consultant is asking what you
Yeah.
will do
So your
when you will
consultant is
find this
asking,
solid
yes.
cystic
So,
cyst.
yeah. So the consultant is asking that you are, obviously operating for this. So you have consented for ovarian cystectomy. What will you do if you find this 10 centimeters? So what we need to do beforehand to think about is I could come across, and if I come across, have taken the consent from the lady. And if you haven't taken the consent, so if you come across that this actually is not a simple cyst, this is a cystic solid, that area, then what I'm going to do, if you can just remove the cyst the way you have planned already, whatever the laparoscopic is, then you will remove it and send for histopathology. But if you can't remove it by laparoscopic way, just because we were assuming it's a simple cyst, but we have ended up of this, solid cyst or whatever, and we need to convert it to the laparotomy. If you haven't taken that consent, then you're not going to remove that cyst. Okay, so that's all about like whether you have done that preparation already or not. And if you haven't consented, then you're not going to take it. For simple cyst, you have opened, you're doing, and then you find out no, actually it's a quite complex mass and it looks like in a spread as well, but the patient hasn't been consented about that, you're not going to do anything then. You're not going to take any additional biopsy or any samples or anything. No, you will be doing only what the patient has been consented.
Okay, so means consultant wants to ask, means to his intention to ask what we will do before surgery. We have to consult with the patient regarding if need of laparotomy and staging laparotomy, if we will find the complex. That is the intention of consultant to ask from us.
Yes.
Okay. Okay.
Yes,
Thank
exactly the same way we discuss with the patient when we are taking the consent. We do that, don't we? We say if that happened, for fibroid, when we're doing the consent, we're telling them, okay, we're doing the keyhole surgery, but sometimes it might be large in size, that there might be adhesions. We may not be able to take out, and then we may end up opening up your tummy. Will that be okay with you? That's the consent. And that's what you need to check here now. Has that been discussed with the patient? And then we say, okay, and then if it didn't even happen and you continue to bleed quite heavily, we will take the measures to stop the bleeding. But if that didn't, we may have to remove the uterus to save your life. Will that be okay with you? This is the consent for hysterectomy. So at this stage, you just need to check, has those been done? Yeah. Okay.
Thank you, Dr. Satya, for clarification.
One query, please. You said in the reproductive age group we have to do urine pregnancy test on the day of surgery. Is it irrespective of her LMP? Suppose she had an LMP within last
No,
2 weeks, should we do?
I said we have we have to exclude the risk of latent pregnancy. So if she hasn't had the sex, or she's not sexually active, or she's in a contraception, and there's then we won't. But if they are in reproductive, usually we do pregnancy tests. Let's put in a simple way, even if they are in contraception. Okay, unless they actually have a normal period, last period which was normal, absolutely normal, and they haven't had any sex, because the contraceptive methods also have a risk of failure. So other than that, for some women who say that I have my period last week and it was my proper expected period and I haven't done any sex since then, maybe you don't do the pregnancy test on them, but the others you will. So all you need to say is, I will exclude any risk of latent pregnancy. Don't go to these details, pregnancy test. When you say that, that automatically means that you will assess she's not pregnant. There's no risk of pregnancy. Whatever the way you do, that's a different thing then. If you think you need to do pregnancy test, you will do that. So for that, just say, I will assess. Right.
But Dr. Safia, we will during the pre-op round, we will say like this. I will ask the patient she aware about her procedure and complication related to the procedure.
When we're doing our pre-op round, yes, then we can quickly check with them. Yeah, that's a different thing. Then you obviously are reviewing the patient, you're seeing them and talking with them. That was just like, as I said in the morning, we will also check. Does she have any questions? So she's going for this particular procedure. Is that right? Are you still happy to go ahead with that procedure? That's okay. Okay, so let's do one more then, so we can get a bit more into know. So Shazia going to do that. So Shazia, if your sound has been sorted out, then please tell us and start it.
Yeah, it's still skipping because I have done all the question, but when I realized it's my signal was lost, so it will happen again. So somebody else can do next time. I will have a good internet.
That's it. Who is next, Pramila?
Neelam.
Okay, start.
Okay.
First 2 minutes starts now.
Ma'am, here also it is about risk and all, or we have to only prioritize the list? Same way, no? Okay.
You prioritize the list as well. Yes, that's the part of the task. Okay, your first 2 minutes are on. So start now.
Okay. Yeah, hello. Good evening. I'm Dr. Needham, one of the candidates for the exam, and I have read the list. There are 3 patients. One is for a 62-year-old lady who has been planned for laparoscopic right cystectomy and has abdominal pain. And the scan is showing 6 centimeter simple ovarian cyst and CA125-8, and that's why the looking to her menopausal status. I'll calculate the RMI and it is less than 250. So risk of malignancy is less. Her BMI is 22. So looking to her BMI, it is okay, but we'll have to see whether she has undergone any previous surgery and what may be the reason of abdominal pain. Is it the torsion of the ovarian cyst, or maybe some other factors which might be there? Is it associated with nausea, vomiting, any other cause of abdominal pain like appendix may be there, appendicitis may be there? So I'll have to review the notes that what may be the other associated things that might be there in the differential diagnosis of abdominal pain. And at the same time, I'll also see for the comorbidities of this patient, because she's 62 years, whether she is having any chest related condition or any hypertension or any diabetes like things. And I'll also like to review the notes why she is going for laparoscopic right cystectomy, where because after menopause she should be posted for bilateral oophorectomy rather than cystectomy. So I'll like to review why this consent was taken. And at the time of laparoscopy, I'll also like to review the consent, whether it has been taken that if we find anything else associated pathology like appendix or anything, then we might, should we go ahead with that? Or if there is torsion, then should we go ahead with cystectomy or oophorectomy? And if needed, if there is any complication, if needed, can we go for laparotomy? So we'll review the consent, whether it has been given or not. While doing this laparoscopy, we'll have to first view the whole abdomen to see any other cause of abdominal pain, and accordingly do the surgery. And the second case is 31 years old, hysteroscopic resection of 4 centimeters submucous fibroid. She is at high risk because her hemoglobin is less, she is anemic, as well as she has history of endometrial ablation and recent miscarriage. All these leads to maybe difficulty in even entering through the hysteroscopic route. So I'll review her notes and see whether she has been explained about the risk of complications and her future pregnancy, whether she wants any future pregnancy or not, and then whether some will put some this mesoprostate is given or not, because we may find difficulty in entering because of the previous failed endometrial ablation, and we may find inside adhesions or synecia inside the endometrial cavity. So and looking to our hemoglobin, we'll put blood for group and save. May require, if there is excessive hemorrhage, may require blood transfusions. So I'll ask her, I'll review her notes whether she has any reservations for blood transfusion, and if needed, if she is not willing for this further pregnancies,
Then because of the menorrhagia, because it is a 4 centimeter submucous fibroid, we'll have to see whether we will be able to do it one sitting or not. We may require second sitting also. And if she is ready for Mirena insertion, at the same time, we'll have to review the consent. That if she is having menorrhagia, then maybe this Mirena can help in reducing her menorrhagia later on after we remove the submucous fibroid. The third case is laparoscopic hysterectomy, menorrhagia, and ultrasound shows large uterus with echogenic myometrium. So I'd like to review whether any other scans or MRI or other investigations have been done to rule out any blood test also to rule out endometrial carcinoma or maybe choriocarcinoma have been done or not. And I'll ask her BMI, what is her BMI, because accordingly we'll take care whether laparoscopic hysterectomy, the route of whether we'll do open entry or we'll do by Ovaries technique, and any previous surgery that may make it difficult, any history of comorbidities, and whether what was her baseline hemoglobin, and whether blood has been grouped and saved because she has history of menorrhagia. And at the time of surgery, we'll have to see whether enlarged uterus is there may be adhesions associated, and if there is any we have to review the case whether consent has been taken for associated procedure, like if there is ovarian cyst, large ovarian cyst or broad ligament fibroid or something difficult, or there may be some adhesions because of previous surgery. So we'll have to review the consent whether if there is any difficulty, we may need to convert it to laparotomy, and there is a high risk of injury to the bowel and bladder too. So we'll review the consent, whether all these consent has been taken or not. Regarding prioritization, because the first case is having abdominal pain, so I'll take this case as the first priority. And the second priority would be this hysteroscopic resection, and the third would be laparoscopic hysterectomy. This would be the priority.
Yeah, well done. That was
Okay.
pretty nicely done.
Thanks.
So just a few things to add. Yes, so if you just start applying this structure to see if there is what can be the problems of the route of entry, what is the procedure itself, and what are the comorbidities. So yes, 62 years post-menopausal, yes, the first you would like to know why just this hysterectomy, just like I said the last one, and why not oophorectomy. So review the notes and find out what the reason is, CA1 to 5, and then the calculation wise you can say her risk of malignancy index is quite low. And then abdominal pain, I'm glad you did consider that you need to keep that in mind because of that, because the cyst may not be the cause of pain, abdominal pain. If we are doing that as a diagnostic of pain as well, then yes, we need to keep in mind what to do if we come across with the adhesions or any other, or do we have the consent then to do the corrective surgery. And then yes, background comorbidities, if there is any from anesthesia point of view, so any medical on all those. And then always for the laparoscopic procedures, unless we say it's diagnostic just for the triple patency, mostly all these cystectomies and stuff, you always must take the consent for the laparotomy to convert into laparotomy if required. The same apply here, although it says simple cyst, but you need to just say like, what if we open and the cyst happens to be complex cyst, then do we have the consent to take the biopsy in case. So that's about her. That was not very complex case. The second one, 31 years old, hysteroscopy resection, 4 centimeters, submucous fibroid, menorrhagia, hemoglobin low, failed in endometrial, BMI 90, and recent miscarriage. So yes, first of all, just consider the background comorbidities, additional comorbidities. She had low hemoglobin, it's important then we try to know when this hemoglobin was done actually, when the result is, has it been on iron tablets, or what has been done on the correction, has the group and save been done, has the blood transfusion, possibility of blood transfusion in case of any heavy bleeding been discussed, and is she okay for the blood transfusion? Yeah, so if we are suspecting something, we need to talk about that. The second one is BMI 29. So we see there's a slightly higher BMI as well. That's overweight BMI. So we will need to then here do the risk assessment for her VTE risk, because obviously hysteroscopic, all those procedures where basically put the patient into the lithotomy position, they itself increases the risk of VTE quite high. So we need to just discuss for that one as well. So do we have a background, will we have the background preparation to put that pneumatic pressure in case the procedure get prolonged for any complication, because of any complication. And then we say, depending upon the duration of the procedure itself and the hospital stay, you will need to consider the VD prophylaxis. Recent miscarriage 8 weeks ago, yes, the only thing about that will be to make sure that she has done the pregnancy test and that is negative. And was there any histopathology sent? That's it. I won't go into much details of the molar or the choriocarcinoma or anything. 4 centimeter to the complications of the root, which is hysteroscopic. Yes, the first one is if she has a failed endometrial ablation, it can be a difficult procedure because of the addition. So obviously there can be slightly additional risk or high risk of injury to cervix, infection, bleeding, and the difficulty. And we may not be able to actually, there might be, the procedure may be impossible. So we may not be able to actually do the procedure hysteroscopically. So we need to discuss that with the woman. The other risk obviously is always with the hysteroscopic procedures where we think the things can go wrong in case, we are struggling to take this, there were additions, all that. Then there can be slight increased risk of fluid overload as well in these women. So we also need to just keep that in mind. Other important thing about that was if we feel, we can't do, or we are finding like some perforation happens during the procedure. Now come to the procedure itself. So obviously 4 centimeter submucous fibroid, doing hysteroscopy is a large size from hysteroscopic point of view from that route. And then we also need to say, I will say here again as well that I would like to look, we'll see the ultrasound scan, and also whether any MRI was done to clearly see the penetration into the myometrium. Is the cleavage plane clearly, separated and it's not extending actually up to the myometrium? And then also, yes, there is obviously risk of perforation in this procedure and the heavy bleeding. So if she bleed heavily, is she okay with the blood transfusion? And if perforation happen, then we need to make sure that we have taken consent that we may need to repair that laparoscopically or even laparotomy. So has that consent been taken? And always with the fibroids, whether the small fibroids with doing hysteroscopy, always talk about the hysterectomy as well in case if it's very hemorrhagic and we're not able to fix it, because of the perforation or any injury to bladder bowel, then we need to, and if it's bleeding and not able to control, then we make the uterus. So hysterectomy consent has been taken. 42 years old, again, laparoscopic hysterectomy, menorrhagia, large uterus with echogenic myometrium. So for her, yes, you would like to basically, well, these two BMI is given. This woman, we need to have the information about her BMI again. On the pelvic scan, it says a large uterus. Then again, like what is the history of her period? If she's a heavy period, enlarged with echogenic means adenomyosis we are suspecting here. So and what is the size of the uterus? Yeah, we need to know. And then if she has the adenomyosis, she might have endometriosis, endometriotic issues as well. So we need to be aware of that as well, that we may suspect. So when you're coming to the menorrhagia, the condition is a background risk BMI, what is the hemoglobin group match has been done, group and save has been done, is she okay for the blood transfusion? Coming to the root laparoscopically, obviously for laparoscopy there are always risk of injury to bladder bowel and blood vessels, and then depending upon the BMI, which you can ask the examiner, do we have the BMI? But the BMI is, if it's a large BMI, then you can talk about obviously those risks and alternative route of entry. And then again, if any, we're not able to complete it laparoscopically, we may need to convert it into laparotomy. So have we taken the consent for that? And then when in case we come across the adhesions, endometriotic adhesions or anything in the pelvis, and we're not able to do the complete hysterectomy in case of hemorrhage, we may consider to do subtotal hysterectomy. Yeah, so that could be done. And then obviously, if there are adhesions, then there can be increased risk of injury to bladder bowel. If you categorize into these three categories, you should be fine, basically. So route of entry, procedure complications, any background comorbidities, complications because of that. Right.
Ma'am,
With one more case, Pramila?
Ma'am, in the last slide, 62 years old, that solid cyst.
Hello?
So in that case, we can't go for the procedure. Na? We have to just stop the procedure, na? Because we are suspecting here oncology. Hello?
No, we have taken the consent for the cystectomy. So if we can remove that, we will take that cyst out and send for histopathology. We won't do any additional like peritoneal biopsy and all those staging laparotomy.
Even that is
But
a
we have taken the
solid.
consent for cystectomy, so we're fine to remove the cyst whether it's solid.
Okay, okay.
Yes.
No need to stop the procedure. Okay,
Yes.
okay. Thank you.
No, we will remove the cyst and send for histopathology. We will not do the additional like staging, taking samples from the peritoneum or anything else of the peritoneal washings and stuff.
Okay, ma'am. Thank you.
Are we done with 9 cases, Pramila?
Yes, ma'am.
One more. Okay, who is next?
Madam, the first one we will do salping oophorectomy or only oophorectomy. That
Salping oophorectomy. Always salping
bilateral.
oophorectomy.
Bilateral.
Yeah.
We should not
Bilateral.
talk
And this
about
one as well,
hysterectomy.
even, yeah, always bilateral salping oophorectomy. So we need to find out why. She might not have the, other tube taken out of already, ovarian
Okay.
tube. So you need to know why.
So we'll leave the uterus and give. So we should give a choice. Where should we remove the uterus also? Because if they
Okay.
ask for
So, okay. Yeah. What? If they ask what?
no, should we give them the option if she is not 60 to 52? If it is like last case, should we give them the choice when both the tubes and ovaries are removed? That uterus also can be removed and put on HRT for only estrogen, something like that. Or we
No,
should
why
not
we will
discuss.
remove that? No, we will not. So if somebody needs even postmenopausal or whatever early one, if we just need to do a cystectomy and oophorectomies, we don't offer them with the abdominal hysterectomy unless there is a reason to do it. Yeah. Just simply because we don't want to just go into an extensive, more invasive surgery if we don't have to. But regarding the removal of the ovaries, is the way around. If we are doing somebody's hysterectomy for menorrhagia or whatever, usually after the age of 45, like 46, 47 or beyond, then we do talk about the removal of the pros and cons of removing the ovary. So we can discuss that.
Okay.
Do you really, we can't also remove the ovaries, but if you do, these are the benefits and these are the disadvantages. But
Okay.
you don't offer hysterectomy just because thinking that if we are removing the ovaries, then what's she gonna do with the uterus? Let's remove that as well. No, that's just simply why we would want to do some more invasive surgery and get a risk of injury to bladder bowel or something else and may end up of a hemorrhage or anything. So no. Okay, last question now. And who is the last one?
Ma'am, echogenic myometrium, that is adenomyosis, na? Madam, echogenic myometrium, that is adenomyosis, right? In last case.
It is adenomyosis, likely to be a it's likely to be adenomyosis. That's we're talking about the possibility of endometriotic adhesions in the pelvis as well. Yeah.
Okay, okay, thank you.
Okay.
Actually, we have reached one turn. So if
Okay.
anybody whose name was earlier called and who was not there, like Fatima, Lubna, Selina, Sadia, anyone is there?
Yeah. Is anybody there? If no, okay,
Fatima,
let me just call one of the. No, Fatima basically is not able to do.
Selena
She
and
has
Sadia.
told me she does Tuesday, so yeah. Selena sent me a message. She's not here today. She's post call. I don't know
Sadia.
about Sadia. She hasn't messaged me, but I can't see her on the list either now. She's not there.
Lubna.
Okay, let me just see who I want this to do. Lubna is not there either. Okay, so I'm just randomly going to check some of the previous one. Is Hira, are you there?
Hello, Assalamu alaikum, Dr. Safian. Yes, I'm here.
Okay, Hira, you do this.
Okay, ma'am, I can see. So actually, I haven't done so many days, so might it will not be very proper or structured. Okay, I'll start.
Yeah, so it's a structured discussion again. I mean, we have done something similar today.
Yeah, ma'am.
So, yeah.
Okay. Okay, I will try, inshallah. So let's start. Ma'am, I will start.
Yes, you can.
Okay. Hello, I'm Hera, one of the Part 3 candidate, and I'm ready for the structured discussion. So
Okay.
there are.
Yeah, just
Yes, ma'am.
proceed.
Okay, so so here is a case where the perforation. This is a case where the laparoscopic sterilization has been going on, and my junior colleague Asitu, she has made a there is a perforation had happened while taking some at the beginning of the procedure. So the immediate concern is that first of all we will we have to see that immediate concern that first of all I have to stop the procedure. The first thing which we are going to do is stop the procedure, and we have to see that we have to stay calm, don't shout or don't blame to the junior colleague at present, and then we have to see the patient is stable right now or not. We have to inform the anesthetist that the procedure is about to be, we have to inform to anesthetist that this complication has happened, so might be the possibility of the prolonging of anesthesia, and then scrub nurse and OT scrub nurse as well as the circulating nurse to inform, because we might need the extra instruments right now because now we have to proceed for the laparotomy, and we have to inform to the consultant as well. We will inform to the someone to inform the consultant, and here blood need to be collected for the cannula need to be passed, and because it's very important that the patient is stable or not vitally. So to continue on IV fluid and arrangement of blood, is there any bleeding is happening from the site or not? We will be required some other person instead of this junior colleague, because she might get more upset, and it will be more disastrous to continue with her right now, and is she's okay, and that's the thing. And then after that, ma'am, I will continue myself.
Continue, yes. Yeah.
Okay, so this is the thing, and these are the immediate action which I will take, and then definitely here because there is a trocar instead of a standard uterine manipulator which has been perforated the uterine cavity, so this procedure needs to be transferred to the laparotomy, and then we have to by the time the consultant will be arrived, and if the family is outside, we have to just make them aware as well. Here we have to during laparoscopy we have to see one more thing, we have to see from the laparoscope that there is any other injury had happened, other than, only that perforation has happened, or there is any other bowel involvement or the bladder involvement has happened as well. And so might we have to need to involve the other colleagues as well. And then if this is a small perforation, which is required to be only need observation, we have to start on IV antibiotic as well to this patient, to give antibiotic as well. And if this is a small and needs repair, it can be possible laparoscopically, or we will because of involvement of the other bowel or bladder possibility, then we have to proceed by laparotomy and then further. What else? So we will directly look, and under direct vision, it's better idea to remove at that time the procedure, and we will not complete now the procedure, because laparoscopic sterilization, if we will continue right now, maybe it will more complicate the chances of more manipulation. Maybe it will make the perforation more worse. So later on, after repairing of the the perforation, then we will do the complete our procedure. Or if there is any blood bleeding is during the procedure, or patient is required blood transfusion or other colleagues, so we will involve, and we will make the repair complete. After that, we will, once the patient will be fine, we will transfer to high, according to the patient how she's vitally stable, we will transfer to dependency unit. We will complete, we will Meo's chart, we will keep for Meo's chart for some time, like for blood pressure pulse and monitoring and intake and output charting for this patient. And after that, we will debrief the patient and debrief the team as well. And we will write the incident report and we will discuss the junior colleague in a non-blaming way that whatever, and we will see, is there any additional training needs are required, or is there a need for, there was any psychological issues, there is any work, it had happened because of the overwork, and what was exactly the reason. And so we have to assess for the thromboprophylaxis to the patient, and we have to discuss in the detail, and we have to do the duty of candor to the patient as well, and we have to explain everything to the patient, and we will write everything on discharge summary, and we will explain all the red flag signs when to return back, and what else. So, and like at the end, root cause analysis and all. Yes, ma'am. Nothing is good. And
Anything else?
yeah.
Okay, that's fine. That was good. So yeah, so just like we did with the previous one as well, you can just start from, obviously after the immediate management, what we need to do after that, you can actually complete first the patient management, like taking to the from the point where you say which she will be transferred to high dependency unit for close monitoring, yes, on Meo's chart, her pulse, blood pressure, temperature, and her intake output strict record. And when she's awake, then we will go and explain her. So you can complete actually that bit first. So we'll explain the patient about this, the complication which has happened, and also to reassure her that it has been repaired appropriately. And we will be open and honest to accept the responsibility of, that this happened because of our error, that a wrong instrument was used, and that's what happened. And then you will assess how the patient take it. You will reassure to the patient that we are going to actually do a report it as an incidence and do a detailed analysis, because we do have a checklist before we go ahead with the procedure. And then we also make sure that the appropriate instruments are used. So we will do that and find out what went wrong, why we failed to follow that. Okay, and I will reassure to the lady that the lessons will be learned. We will find out what went wrong, lesson will be learned, and that will be communicated or disseminated within the team for learning, so that it never happens again. Okay, so and then you will decide, depending upon how the patient feels. If she finds it's like traumatic, then I will offer her for the counseling. If she feels angry in spite of our the explanation and reassurance of learning from this, if she feels quite angry about it and she wants to put a complaint, we will facilitate that process, give her all the information how to make the complaint, and also reassure her that that it is her right and this will not compromise her further care going on. And then obviously you're going to say, like, you will make sure that she's seen by the consultant at the end as well. I will also ensure all these patients who have any kind of complication, we always like, not necessarily something going wrong from this point of view, any major PPH or anything, because when we give them information immediately after the procedure, they are still, a bit under the influence of medicines, pain relief. Sometimes they do not understand all that information at their stage. So we like actually to do a debrief meeting with them before the discharge. So somebody like at the level of 55 or above will go and speak to them all again to make sure they understand things. If they have any question, they can ask. So you need to say that. We will make sure that they, go and debrief and see that patient at this stage, and then explain her any possible follow-up. Okay, so that's about this, about the patient. Then you can start about your team and all that side. So then you won't confuse things, yeah. And then you can say, and then we will have a debriefing of the team as well to see what went wrong, why we failed, and why that happened. So first of all is obviously you need to then say, let me start from the beginning. Then no, so the start will be same, just obviously standard way. As soon as you see that trocar in the view, you're going to the first very important thing here is slightly different from bladder injury of the scenario, that you will stay very calm. So you will say, I will stay calm. Obviously there will be very nervous scene to see, but I will focus to stay calm. and in a calmer manner. First of all, I will tell my assistant or ST2 not to move the trocar, which she think is the uterine manipulator, not to move that at all, right? In a calmer way, but you must say in a very calm way. I will ask her not to move it from there. I will then keep the trocar in my camera view all the time. I will inform the anesthetist that this what has happened, and then obviously he can prepare for the according to anesthesia. If there needs, obviously that will require to be prolonged. You're going to inform your scrub nurse as well that this injury has happened and we need to have the appropriate instruments for the repair of the uterus. You're going to ask your one of the nurses to immediately call the consultant. And meanwhile, obviously, yes, you are going to just, depending upon if the sterilization has, obviously that one is just by the time you have entered the scope, so sterilization obviously not done yet. So you will say you will not proceed with the procedure of sterilization, obviously, because what we don't want here now is we do not want the trocar to be moved from the view and from there, because otherwise we may end up causing more damage to the viscera as well. Okay, so for the time being then all you're going to do is and you're going to also then make sure, because we don't know, she might not be bleeding now because the trocar basically is occupying that space. So when we remove the trocar, she might just bleed so torrentially. So we need to actually do the blood group and 7 cross match available. The anesthetist needs to make sure that she has 2 wide bore cannulas in place and the fluids. And you guys will alert the hematology and also to the blood bank that you may need the blood for this woman. And then so at this stage then you're just going to stay calm, keep that in there and wait for your consultant to arrive. You will not change your assistant at this stage till the consultant is arrived, because she might just during that time you might cause an injury. So let her stay, but just reassure her by saying to stay calm and reassure that these type of mistakes can happen. So she do not need to be nervous and worry too much. So she can focus actually to stay calm and stay over there. So once your consultant has arrived, then obviously you will hand over that to your consultant, and then they will depend up to her how she wants to proceed. And once the trocar obviously will be removed then from down below, and depending upon then what is the size of the defect and whether it's bleeding or not, then the consultant will take the decision to repair it. Whether she feels to or he feels to repair it laparoscopically, or if it's a larger defect, bigger defect, the patient is bleeding heavily, then the procedure may need to be converted into the laparotomy. Okay, so obviously that will be done. So uterus will be repaired first, hemostasis will be secured, and then obviously the bladder bowel, they will be examined for any suspected injury from the trocar, and then after that sterilization will be completed, and then start that limb I have already explained to you. The patient will be transferred to the high dependency unit, and then just that part I have completed. Then you need to continue and say, then we will have a team brief to see what went wrong, why that happened. So you need to, yourself, you will also check, that it's like will be quite reflective and learning from practice for myself as well, to see. So this ST2 who has been, was this the first time she was doing that procedure? What went wrong? Why she could not have the right instrument? Why she could not recognize that this is not the instrument to be used? So it's the first time she's doing, was she under some stress or whatever? Yeah. So why she like? And then also it is very important to check with the scrub nurse as well, because the scrub nurse should know, as per our protocols and pathway, that which instrument needs to be passed to the surgeon and to the assistant. So what happened here then? Is that like, was she like some inappropriately trained scrub nurse who didn't know what instrument to pass? Or actually the ST2 or the assistant directly actually picked up the instrument from the trolley herself? Yeah. So I hope you all know, as a protocol, the surgeons are not supposed to pick up these instruments straight themselves from the trolleys. They must ask the scrub nurse to pass on them. And you are, I hope, understand simple reasons for that why. So right, so that's obviously something we need to find out from both point of view, what was not right with our results. But then you will then reassure the team as well not to panic and not to worry about it. We will look into, and then yes, you will take your ST2 to the side room. It might be quite traumatized experience for her, and you will reassure things can happen. But important is that when she feels better, she must reflect on this and then learn from there. So then again, the same thing, if she's quite quite much nervous and stressed and you feel it's not safe for her to continue with the rest of the duties, you will speak to the consultant and send her home. And then you yourself will also think about, like, that you have also missed why you failed to actually check with your assistant that she has done this procedure already and assisted and she's aware and knows what instruments or what she's doing, what she's supposed to use. And then yes, when she's back next day or in couple of days time, you will have a meeting with her where you both of you will do the reflection. So the reflection mean under three four categories, which we will again do when we are doing our clinical governance session. One will be to see, okay, what went wrong, how could we prevent it, what we learned from it, and how we are going to apply this to our practice so that it never happens again. So she will do the reflection note. You will also do that. You will discuss, both of you, and then you will encourage her to discuss with her clinical supervisor and include that into appraisal meeting, and you will do the same. Okay, so and this should be done, and then we see risk incidents. We have already talked about that. That will be done, and then the lesson will be learned, and the learning will be disseminated and discussed within the team as well. That's all.
Dr. Safia, I have a question.
You want to ask me?
Dr. Safia, in this, the very first question, what are your immediate concerns? What do we say to that? What are my immediate
So
concerns?
so the first very immediate concern will be that she should not move the trocar. We don't want the trocar to be moved from that view now, because it can cause some traumatic, obviously, some extensive injury. So that's why we said, like, when I will see, obviously there will be very nervous scene, but it's very important that I stay calm at that stage, because if I panic, then the assistant can panic, and if she moved the trocar from there, it can cause. So that's my first immediate concern, and also to tell then to them. And then the second one is, obviously, the second concern immediate will be that this woman can now hemorrhage and bleed very heavily. And what will be your immediate actions? That obviously we just talk now. But immediate will be telling to your anesthetist here, calmly first tell to your ST2 not to move and stay calm. It has happened, but stay calm. And let your scrub know, call your consultant. These are your immediate actions. And how will you manage this? That's all that detail we talked about. She will remove the trocar and then repair and bleeding and then patient recovery and all that, and your own debrief, teams debrief and everything. So,
ma'am, one question, please.
Yeah.
After all this procedure has been done, you said we will go and talk with the patient when she recovers. So before that, should we talk with the relatives, or should we ask her consent to disclose these things to the relative?
Yes, no, we don't talk to the relatives before we talk to the patient. The only time when we go straight for the debriefing of the relatives is if the patient has died. Otherwise, first we will talk to the patient. And then after that, she tell to her partner, family, or somebody else, and then the partner go very angry and decide to talk to us as well. That's the different case. Then we will speak to the partner. We'll listen as an angry husband, a partner, or anybody else.
Hello.
Okay.
Hello, Doctor. Hello.
Yes.
Dr. Safia, as you said, after the consultant arrive, and then he or she will decide whether, after removing the trocar, whether to need repair or whatever. After that, consultant will complete the procedure, tubal ligation.
Yes, consultant. Please don't confuse yourself into too much complications. Of course, the consultant will do. And if the consultant asks you to do it, you can do it. That's not a big deal, okay?
No,
Don't
no,
worry
it's
about it.
not
You don't need to
mean.
tell that in the procedure.
No,
Yes,
means my
when the
point is.
consultant is doing, she can complete it, because she's doing it, she will complete it. Or even if she asks you to do it, you can do it. That's not a problem. That won't have any marks to say or lose. Anything to
No,
lose
no,
there.
that
Yeah, okay,
was
tell
not
me. Yeah.
concern. Means we will do the tubal ligation. Means my concern was that we will complete the procedure. Means tubal ligation.
No, that's what I'm saying. Yeah, that's what exactly I'm saying, that is not important at all. When the consultant is, so what normally happen, obviously, so this complication happened, we removed, and then obviously that is very stressful thing with the consultant will do, repair the uterus and all that stuff. Then it's just a routine thing. Usually when we are called for any complication, we go by, the ST5, 3, whatever happened, and then the consultants go to repair that. They usually complete the procedure, whatever it is. Yeah.
Okay.
Because
Okay.
already
Thank
the anesthesia has been extended, there has been always complications. So we just want to finish and complete the process. Usually the consultant will just complete it. So it's not now the normal thing happening that the consultant for learning purposes will do, I do this and you just now you can continue with your sterilization. No, the consultant will just complete the sterilization procedure. All you need to say is, again, you don't need to worry about saying that then now we complete the sterilization. No, just simply say after that the sterilization procedure will be completed. That is enough for you, unless they ask you. First thing, they won't ask you this question, but if the examiner particularly asks you, then you know, okay, will you do it? Yeah, your consultant do. Then it's absolutely up to the consultant. That's your answer. Once the consultant is there, then the total responsibility of the patient and decision making responsibility goes on the consultant. Okay, so the answer should be if there is any scenario that the answer that will depend on the consultant what she wants. And that's why we said in that one as well, it's up to the consultant. In the previous, when there was a bladder injury, we said right from the beginning, I will ask to call for the consultant and also call for the urologist. But here, all we said is, when the consultant arrives, it will be up to her whether she wants to do by laparoscopically. She can, and also that will depend on the defect as well, how much damage and what is the size of the defect. She can do it. Okay. So, right, that's done. Now, from core surgical skills and from post-op care, is there anything else, any other scenarios you guys think have come into recalls and you would like to ask me? Briefly, we can discuss. Any confusions from any similar type of recalls? Yeah.
Yeah, ma'am, one question here. That 15-year-old girl MTP that pretend products and ERPC we did. Say, for example, in this scenario, she had already called her father, and say in a real exam, if it comes like she has not informed her father, and patient is serious or bleeding heavily. In that case, what to do? How to inform relatives? Because if we break the confidentiality, then again it's a penalized. So, what to do in this situation?
Okay. So in that case, we will speak to the father. We will tell the details. Now, what happens when we speak to these young people? We did that in early pregnancy and sexual health as well. What we said, what promise of confidentiality we made with them was, I will, this consultation will be confidential. We will not discuss with any third party without your consent unless we have serious risk about your safety. Okay, so that safety can be social safeguarding, that safety can be the clinical safety. So here is a risk of safety now. This child has gone, in such an extensive procedure now, and in so much of complication, we cannot withhold this information after calling the father as the next and the next of kin. When something goes unexpectedly wrong, or somebody dies, or something is gone, patient is gone into coma, we can't have the consent from the outpatient unit. The next of kin basically is the person. The next of kin name will be given by whoever goes to the hospital, is the person who they feel our information can be discussed. But if we feel this is the type of information we can withhold and it's not going to cause any problem, then we will withhold. So that's the balance to keep. Shall I break the confidentiality here? In that case, we will have to break the confidentiality to know the father, because again, it's, as I said earlier on as well, it is rather very serious, and we will be in a lot of trouble if we ever call some parent to say your child is serious and blah blah, and then we do not give them information on what has happened. So we need to also think about what is the amount of stress, trouble, pain, trauma, whatever you want to say, we are going to give those parents. Then it's better don't call them. Don't tell them if you don't want to give the details. Then don't call them to the hospital anyway. Yeah, but that's not the case. Here we are concerned about the child safety. The person's life is going, the child may or something. We can break the confidentiality here. Okay.
Ma'am,
It
in,
does
ma'am, in one of
the one. Just one question, 1 minute. The other one
yes,
where we do like that angry husband one, where we ended up of doing hysterectomy of that woman. No, that is a slightly different situation. No, having a hysterectomy or having total infertility or something, they are very sensitive matters, right? And that is an adult over there. So in that case, we asked the partner first, how about, what happened. And when the partner went into all those details, then we knew there was nothing, they were all collectively, the both performing, and then we broke the confidentiality. But if in that particular case, the partner didn't know anything, the partner said, well, I don't know, I wasn't, I was out or I was somewhere else, I was abroad and I've just come back, then we won't. All we will say, she needed to have some treatment done, or she needed to have some surgery done, and there are some complications happen in there. So, but it has been managed now. She's out of danger. She will be recovering, and then when there, we won't break the confidentiality, because it's very simple thing again. If my partner, husband, whatever, is abroad even or wherever in this time of of the time when there is communication, everything possible, even the person is not in the town or at the house, I can always give a ring to my partner or husband and let them know this is what is going on and I'm going for this. This is natural thing we will do. And if I haven't done, then there must be some concerns there, right? So that's being adult I want. So that's the difference between two situations. Yeah.
Thank you, ma'am.
Go on.
Ma'am, in one of the stations that we did today, she had already given a consent for hysterectomy, and then later on she decides to go for a removal of the ovaries as well. So in such a situation, do we have to take two consents separately, or the previous consent can be updated?
Yeah. So yeah, again, it doesn't matter. We can just add that procedure, and that's usually we do. We will just add the name of that procedure on next to what we have written already, and then you will sign at their place, not only the place down where we are supposed to SI. So whenever we make a change or we delete anything cross, say even it's like a writing mistake, like when I was writing and I made some mistake and I want to cancel, even there you have to put your signatures, so you own that I have changed this. So similar way, if we add something, then you will say added on, you will write on the date, and then you will add like saying, so the removal of both ovaries as well, then you will put your signatures, name and date, and you will ask the person to do at the same place as well where you have made the change. Okay.
Dr. Safia, but before we heard, I think
Unless we have a time, it's in the clinic and we have a lot of
form.
time actually to go through the whole. Okay, sorry, yeah.
Sorry. So we already discussed in the last course that if it is like that she has changed her mind, then we have to take the new consent form for the removal of the ovaries, not to make the amendment on the
So
paper.
that was exactly I was just going to say when you were speaking. So yes, if we have a time like in OPD or something like that, and depending upon the time, if we have a time, we can just take another consent. But another consent again means then we will have to explain all those complications, everything again, and just say the same way by saying, okay, so if you understand and you agree with all that discussion which I've written over here, then we do the sign. So it depends. If it's that particular morning, then I can just add that procedure and we both can sign over there. Okay. So these are not again, these are not really the things which should you really worry. Take them as a common sense kind of thing. Yeah. And nobody will ask you, what will you do? Are you going to change the new consent or that? Just simply say, if it's a time in the clinic, then we can go through the procedure, these one, and write a new, these one, and otherwise we will just add over there and we both sign. And I will write out the date. You will write the date of that addition as well. You will write added to the original procedure on this date. Okay. And then you will do that.
Ma'am, we wanted to see some, ma'am, we wanted to see some samples of consents and that laboratory lab values, how they are in the UK lab reports are coming, like hemoglobin and all that stuff, and plus consents for all procedures, like so at least any samples, so we can just have a just visual impression in our mind.
Fine.
Thanks.
That's fine. I will do.
Dr. Safia, I have put 3-4 topics, just like pre-op ward round or post-op full-blown sepsis or enhanced recovery and VVF after the hysterectomy. So we can discuss it on the group.
Okay. So we have done the pre-op round today. We did 2 stations. I think you probably were not there. You went for the
I
maybe.
was in the emergency.
Okay. Yeah. So we have done the pre-op today. Vulvovaginal fistula, yes, we can do at some stage. Then what else you said?
enhanced recovery structure discussion, because
enhanced recovery structure discussion is a part of our structure discussion stations. You know, when we do that, that
okay.
is there already.
Okay. And
We'll be doing that.
post-op sepsis, either it is a pregnancy with pregnancy or in gynae case, but full-blown sepsis, you know, how to use the structured discussion about the MEOS chart and critical care and review and all these things,
Okay,
like
so
how to
basically
carry
that one, yeah, so that one we also did today. So yes, I will bring those charts for you guys to just see and become familiar how you quickly see the MEOS and pick up what is abnormal there. We put those ones, but that actually we have done that today. You know, the one case where we said there was anterior abdominal wall hematoma, and then there was some high temperature as well. Yeah. So the basic will stay same in sepsis as well, you know, that we will be passing, you're doing this and take these blood cultures, start your antibiotics after consultation with the microbiologist. The only additional thing you need to do that one is then into the scenario, you need to find out, is there any possible cause? Then you will need to take the history as well. If there is no clear possible cause, just like as we asked that woman, so the possible causes of sepsis in routine post-op cases could be UTI, some chest infection, some DVT, an infection over there, an infection in the hematoma. In post-op cases as well, it could be endometritis. For this up, there's some wound infection. So that additional history you need to take. UTI history, always ask for the chest infection, UTI, and the DVT. So then you can find out, you know, what is going on. So then just will be send those. And if you're suspecting some injury, say the scenario says something, she has a right flank pain as well, or some, you know, ureteric injury or whatever, then you will add further by saying, so the main will stay the same anyway, antibiotic and everything. Or you will say then obviously say that we will do some ultrasound scan, or we might do the CT scan as well to find out. If we are suspecting some collection inside, you know, maybe some urinary leakage we're thinking about, then we can say we can do maybe erect chest X-ray, abdominal X-ray as well to see for fluid levels, or CT to find out an injury. If she's giving us any chest infection symptoms, cough, and you know, all that going on, then we can add up chest X-ray as well. Okay, so that should be simple and basic. What you get from the scenario about the possible cause of the sepsis. All right.
Ma'am, is there any personal group on Telegram to discuss? Because I think it's a common group. Because yesterday when I saw it was more than 500 members, I was unable to confirm
Does it
how
make
to.
any difference? Does it make any difference though? There are 500 or there are 10 people.
So we can
It
put
should
all
make it.
the.
Of course, that's why I said put that in the public group. Doesn't matter. I don't mind people to have some other people to have some free information as well. It's absolutely fine.
Okay.
Okay.
And ma'am, all
Yeah.
these recordings we can download, or it is just like, because sometimes when the internet is interrupting, no, so suddenly that it gets interrupted or recording gets interrupted. So can we download and keep it safely in our laptop or somewhere?
So we don't give download access anymore now, unfortunately, because people previously has misused. Then unfortunately downloaded the recordings, and now they're running their own case, their own full course, unfortunately. So yes, so
problem comes with the internet, because nowadays so much, even in UAE also, sometimes it will be very good, sometimes it will be totally down. So
I absolutely understand that. I absolutely understand that. But then, obviously,
at the time of
unfortunately, we
exam,
had been very generous. We had been previously very generous. I'm still generous, to be honest. Keep sending these all the recordings to everybody, full, you know. But this is how the people have been misusing it.
oh no.
So, yeah, unfortunately. But
That's
you still
something
should
we
have
don't
enough
have an
time, you know,
internet.
during your cooking, this and that. Just always keep them in the background.
Because I have only one at the time of exam. But in case if you want to see if downloaded, we can do forward, backward, everything. No doubt it will be only by me, not by anybody else. That I can assure you.
Okay, we will look into it.
Thank you, ma'am. Thank you so much.
Okay then, so I'm gonna close now. So next one is going to be what is going to be next one? Antenatal care. I think you can check just on the, I think it's antenatal care. Should be antenatal care.
Antenatal care.
Okay.
Recording of antenatal. So we
Goodbye
can
now then.
Thank you, Dr. Sophia.
So, every one of you, please, if there are any specific cases, I don't see much of, enthusiasm coming out from you guys, and an incentive. So any, scenarios which you feel in antenatal, whatever the module we are going to do during that week, if you feel, you can always, on WhatsApp, you can put up, we would like to do this scenario, and if I already have them as a part of the course, I will tell you, yes, don't worry, there is part of the course, and if it's not, then I can add those ones. Okay, so I repeatedly say, please, it is absolutely up to you guys how effectively and efficiently you want to use my knowledge and skills to help you prepare, but you obviously need to take incentive as well. Okay,
Thank you very
so
much,
let's
Dr.
close
Sakia.
here.
We
You're
are
welcome.
Prioritization we will do
Yes,
separately, ma'am. Labor room
Sorry,
prioritization. Labor room prioritization we will do separately, ma'am.
that will be done in delivery management or labor management. Yeah.
Okay.
Okay.
Dr.
Thank you.
Sophia,
Bye
I just
now.
want to ask you
Yes.
that if you will get any recalls from the last recent exams, because we are having very much difficulty in collecting that recalls, Nobody is actually disclosing that, maybe giving even idea.
No, I have these recalls and I'm actually putting them in modules. We are doing those recalls, actually. We did
Yeah,
quite a lot in
I,
fertility and all those, and today as
but
well.
there were 3 exams and every day, every time, 3 days, 4 days. So it's a lot of things here. But
I do
didn't
have them. Most of them are repetition. Most of them we did have in our course anyway. They are present in our ones, but anything which I don't have, I have added that. Don't worry about it.
Okay, thank you.
I have all 4 days cases, so
And for the
I will
recording,
make sure
Dr. Sakia,
definitely.
we have to send email to Dr. Talha. Is it Talha?
Okay, so the email, and I have checked with that, so you will receive some email about whatever the response is. Okay, don't worry.
Oh.
I'm actually gonna make sure now, just now, to check that he responded.
Sure. Thank you very much.
Thank you very much,
Bye
madam.
now.
Madam, last questions. All these people, all these other mentors keep on telling you have to use that word WHO checklist in all the pre-op rounds. So here we never use. So is it like a mandatory rule kind of thing? That WHO
It is.
surgical
Yeah. So yes, it is. It is mandatory. So what we do, it is also called the pre-op. Yeah, so what basically happens is the 4 teams set up, all these things we check, okay, which procedures we are doing, which patient complication, getting prepared as well if things go wrong, who is going to do if any patient goes into cardiac arrest, who is going to do what and how, what will be, this patient is there are possibility of these complications, and if that happen, what will be our plan. And also then to check for every patient then individually as well, all these, like, has the patient been name and date of birth, and that's been checked, had the name of the procedure checked and matched, has the patient been catheterized, has the site of the surgery, particularly in other type of surgery, where the right, left, and those situations are there as well, that is being checked and ticked. So that is called WHO. That is done. Yes, that is absolutely done before every patient and before we start the list. Yeah.
So, ma'am, in
Okay.
exam also we have to pre-op rounds, we have to mention that we will do WHO surgical checklist.
So the WHO surgical checklist happens inside the theater, not in pre-op round.
So in pre-op round we should not tell.
You don't need to say that. No, not in there. In between yourself, if somebody has that, actually, what is WHO pre-check list, just share in the group so everybody else can see what that is. Okay.
Thank you.
Okay. Bye.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you, ma'am. Thank you.
You're welcome.